Meanwhile, we request our speakers to kindly provide their presentations to our volunteers. May I request all of you to please keep your cellular devices on silent mode. And for those joining us online, to please put yourself on mute as we will be starting shortly.
Arogyam Paramam Bhagyam, Swasthyam Sarvartha Sadhanam. Good health is the greatest of human blessings and means to what all we aspire for in our life. This quote from Ayurveda is very apt to suit our full day engagement towards one of the most disastrous non-communicable diseases today in India and across the globe. Good morning, everyone. It is a great pleasure for us to have you all here at Translational Health, Science and Technology Institute, Faridabad. On behalf of the organizing committee, I would like to extend it's our great pleasure to welcome you all, the dignitaries, guests, faculties, scientists, and students who have joined us today, either in person or through online mode, to attend one-day symposium on metabolic associated fatty liver disease. The aim of this symposium is to train and educate researchers working in this area to highlight the research efforts being pursued at THSTI. THSTI has an interdisciplinary team of scientists working in this area for the therapeutic development and also the biomarker discovery. We hope that you will enjoy the sessions and have a day full of scientific discussions. With this, I now request our Executive Director, Professor Pramod Kumar Garg, to kindly come up on the stage and deliver the welcome note. Thank you, sir.
Thank you, Ruchi. Good morning, ladies and gentlemen. It's my real pleasure to welcome all the dignitaries who have graced this occasion, including my teachers, senior colleagues and colleagues, Professor Acharya, who is online, Professor Chawla, who is here, Dr. Ajay Kumar, Professor Saraya, my colleagues Kaushal, Shalimar, and Manoj, and many other faculty and from THSTI and outside, all PGs from different hospitals, and PhD and postdocs from THSTI. A very warm welcome to all of you to this one-day symposium on NAFLD or MAFLD, whatever you may call it. I don't have to emphasize to this audience that how important this disease is or has become. It was there all through, I think, but the attention has been focused on this for last about 2 decades, more so in last decade, when we realized that it is something that is associated not only with liver-related mortality, but also other causes of mortality being, for example, diabetes and cardiovascular disease. THSTI, as those who are working here know very well, but those from outside should know that it's a kind of a unique institution where it is not just another basic science institution where we do basic biology. This is a unique institution in the sense that besides basic biology, we are engaged in translational medicine in the true sense of the word. We have a very big diagnostic division, we have drug development divisions, and we have very large clinical research programs, particularly in the area of mother and child health. I think perhaps one of the largest cohorts of pregnant women has been established here, called Garbhani, where more than 8,000 women have been enrolled and are being followed up for more than 5 years now. And second phase started where our birth cohort has been established. In addition, we also have what is called as academic CRO, where this is Clinical Development Service Agency, or CDSA, where we supervise and monitor and guide clinical trials across the country, multi-center trials. And there are currently 17 clinical trials which are running under CDSA. Now, in terms of the areas where THSTI is working, besides mother and child, there is a big division on tuberculosis. Another is on virology. And as you would know, all of you would know that THSTI was engaged in multiple fronts in SARS-CoV-2, including vaccine development. And I'm very happy to tell you that we secured a grant of $12 million from an international organization called CEPI to develop a new pan-beta coronavirus vaccines along with industry, that is Panacea. That only shows the strength of this institution in developing vaccines. There is a division on non-communicable diseases where primary focus has been on fatty liver disease. And in this area, the work is focused on understanding the pathophysiology of the disease. And THSTI has established both cellular models of NFLD and animal models of NFLD. In fact, there are multiple models of animal models of NFLD where the pathophysiological processes are being studied and new molecular targets are being identified. In fact, there are many compounds that are being tested in these models to bring down the fatty liver disease, both the fat in the liver cells and the inflammatory milieu which accompanies it. So we thought that time is ripe that when THSTI should engage with more clinicians and stakeholders, and also industry, which is very important, because if we have to come up with a new drug, and we are very happy that actually one of the drugs which has been developed in India is now in clinical trials in US also. So this is a success story on which we can build upon our research program. So that is why we believe that it is very important for us to have multiple partners and stakeholders. In fact, one of the things that we have been talking for long is Ayurvedic medicines. And as allopathic doctors, of course, we have a little bit of a skepticism about the whole thing. But here at THSTI, there is an actual program on testing some of these Ayurvedic medicines in a very, very scientific manner. Not just that you give something and then say, okay, everybody improved. Not that way. So I think that is another aspect that will be highlighted today. So I once again welcome all the faculty and delegates and wish you all happy learning. And I'm thankful to the entire NCD team which has organized this one-day symposium. Thank you very much.
Thank you, sir, for your inspiring words and for formally opening the symposium. There will be 3 thematic sessions in our today's event, and each session will have 3 to 4 talks based on a common theme, metabolic associated fatty liver disease. Apart from this, there will be a poster presentation for students and young researchers.
We now begin with our first session, disease prevalence, risk factors, and pathophysiology. To chair this session, we have with us Dr. Subrat Acharya, who's joining us online. We also request Dr. Manoj Kumar to kindly come up on the stage to chair the session. It is an honor to have Dr. Subrat Acharya with us here today. Dr. Acharya is the recipient of India's prestigious Padma Shri Award. He is currently the Pro-Chancellor, KIIT University, Bhubaneswar, and the Executive Director, Gastroenterology Department, Fortis Hospital, New Delhi. He continues to serve as Professor Emeritus at AIIMS, New Delhi. Dr. Acharya specializes in the area of liver diseases and has published more than 300 research articles in reputed journals. He has received many prestigious awards, including J.C. Bose Fellowship. Sir, it's an absolute delight to have you here with us. Our second chair for this session, Dr. Manoj Kumar, is the head of the Hepatology Department at ILBS New Delhi. Dr. Kumar specializes in the area of hepatology, viral hepatitis, MAFLD, portal hypertension, liver failure, and hepatocellular carcinoma. He has published more than 150 research articles. Sir, thank you for joining us here. We request our audience to kindly reserve their questions until the second talk is completed. We now invite our first speaker of the session, Dr. Kaushal Madan, to please come up on the stage.
Well,
And we request Dr. Acharya to
begin the
kindly
session.
introduce him to the audience.
Can we begin the session? Hello? 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 Am I audible?
Dr. Kaushal Madan. Dr. Kaushal Madan is a
Hello.
gastroenterologist and a hepatologist with more than 28 years of experience. Okay. Sorry for the inconvenience.
Is it audible, Kausal?
There is, yes.
Is it
Sir,
audible?
Yes,
Kausal?
sir. Yes, sir.
You're audible, sir.
Am I audible?
Yes, sir.
Okay. So should we get going?
Sir, please introduce Dr. Kaushal Madan.
Good morning, ladies and gentlemen. I must congratulate the THSTI for organizing this very important symposium about which now whole globe is aware. There are no other diseases which has affected such a large number of people, and about a quarter of your population has fat in your liver. Unfortunately, some of them die of heart disease, cancer, and liver failure. But there are huge gaps in development of the biomarkers for prognosis, for the markers for progressions, and for therapeutic interventions. We are completely at dark. And therefore, more knowledge is necessary. Even there has been confusion between the term MFLD and NFLD. MFLD has been a term recently given by a group of Western people, whereas we have been from India contesting the term, had to keep it as non-alcoholic fatty liver disease, because as an Indian distinct ethnic group, we see patients without Western fatty liver disease, without Western definition of metabolic syndrome. We think there might be other mechanisms, including the genetic mechanism of having this disease. And it is very heartening to see that a group of very elegant basic scientists are interested in this. And to start the ball rolling, the subjects are excellent. And start the ball rolling, we have Dr. Kaushal Madan, who is one of the outstanding hepatologists the country has ever produced. And his knowledge, particularly on fatty liver disease, is immense. And he has been working on this subject since I remember somewhere late 90s, since 90s he has been working on this disease, and he has been very interested. There will be no better person than to speak on the disease burden of fatty liver disease and show the magnitude that how actually immense it is and how important to give a very high priority to crack these various unknown problems and gaps in the knowledge. Dr. Madan, please.
Introduction. And I must thank Dr. Garg also for inviting me to this particular meeting and to this institute, and I must congratulate him. There was a time when my teachers, when I was doing DM, they used to talk about translational research and we didn't understand what that means. But I am pleasantly surprised that there is an entire institute now working on this issue, where there's a collaboration between clinicians and basic scientists. And I'm also anxious talking to basic scientists, because sometimes you have to get down to the basics, and in order to make the basic scientists understand what we want to say or what we want to emphasize. So I've been asked to speak on burden on NAFLD and risk factors. And talking about risk factors, I think the topic per se, metabolic associated liver disease, associated fatty liver disease, suggests that it is possibly driven by the metabolic factors or metabolic risk factors or the metabolic syndrome. But I agree with Dr. Acharya when he says that we are contesting this change in nomenclature from NAFLD to metabolic associated fatty liver disease, and that is a debate in itself, and we'll not talk about that right now. So can I have my slides on the screen? Yeah, so burden of NAFLD and risk factors for the same. So let's first talk about the global burden. Can I have a pointer also? Okay, that's okay. Right. So this is a meta-analysis of 86 studies from 22 countries with more than 8.5 million subjects, and the global prevalence was 25%. So 1/4 of the world's population is suffering from NAFLD. If you look at this particular hall also, I'm sure at least 20-25% people would be having fatty liver disease. But since this is a younger lot, maybe the prevalence might be lower. So these are the country-based or continent-based prevalence. More the number of studies, lower is the prevalence. You have from Asia, where we form a part of, about 27% patients have non-alcoholic fatty liver disease. Looking at the age-specific prevalence, it starts rising in the 4th decade. And as the age goes on, the prevalence of NAFLD increases. The age and sex-specific prevalence, again, in males, the prevalence starts rising in the after the 30s and plateaus around 50 or 55 years of age and remains there. Same is the pattern with females, although the overall prevalence is slightly lower. When this disease was first described, people used to say that it's a disease of middle-aged females, but I think that has changed now. That concept has changed as more data has come in. Again, the risk factors from the same study: non-alcoholic fatty liver disease, obesity present in 51% patient, diabetes 23%, dyslipidemia 69%, and so on. So there are two forms of fatty liver disease: pure fatty liver, which is called non-alcoholic fatty liver disease, and the other is the severe form of fatty liver disease called non-alcoholic steatohepatitis, in which there is significant inflammation, fibrosis, and risk to progression to end-stage liver disease. So if somebody has to work on NAFLD, this is the group where you want to work on in order to prevent progression of liver disease. And when they looked at the prevalence of these risk factors, they were higher in patients with severe form of the disease, suggesting causality. So severe disease, more number of risk factors as compared to mild disease. What about epidemiology in India? We'll talk about different studies. This is a hospital-based studies. Obviously, there are some biases involved when we talk about a population collected from a hospital, because patients are presenting to a hospital for a particular reasons. So they may have a bias of having a higher prevalence. So this was a study from PGI Chandigarh. Dr. Duseja will soon join us here today. 986 male blood donors. 53% had NAFLD on ultrasound, which is much more than what we are talking about, 25% or 30%, possibly because of the affluent nature of the society which goes for blood donation there in Punjab. Maybe again, this is a biased data. Autopsy studies, less bias involved in this, because patients who are dying in road traffic accidents or other unrelated causes underwent autopsy, 103 consecutive victims of fatal road traffic accidents, and fatty liver diagnosed in 14%. Again, there may be some bias about the kind of patients who are involved in a fatal road traffic accident, about the kind of vehicles they are driving. So these are the most important ones, the population-based study, and this is the one which is oft-quoted study from India. This was from rural West Bengal, 7,200 subjects screened, 1,900 selected, and of them on ultrasound, 8.7% had fatty liver. So this was rural West Bengal. So in rural West Bengal, this was the prevalence of fatty liver disease. These 167 patients, 2.3% had raised NAFLD, and they suggested that possibly they are the ones who are having the severe form or NASH, and 36 of them underwent liver biopsy. 0.2% had cirrhosis. This is very significant. I've been quoting this for a very long time. 0.2% of a rural population has undiagnosed cirrhosis. So that is a huge burden when you extrapolate it to a urban population and then to the entire population of our country. Huge burden of undiagnosed cirrhosis, which are likely to decompensate in next 10 to 15 years and develop liver cancer. So these were the risk factors which they looked at, and very surprising, even a family income of $1 to $2 per day was associated with a higher risk of fatty liver disease as compared to a family income of less than $1 per day. Presence of abdominal obesity, any rise in blood sugar, even a sugar more than 100 was associated, that is pre-diabetes, was associated with increased risk of fatty liver disease, and a BMI of more than 18. So a lower BMI also, not necessarily a person who's looking obese would be at risk of having a fatty liver disease. This was one of the initial urban-based studies, the Chennai Urban Rural Epidemiological Study, in which the prevalence was 32%. So rural, 8.7%, urban, 32% patients had NAFLD. This was done, another study which was done in railway colony residents. Around 1,100 residents were screened, and younger patients, all patients 16%, and patients who were more than 20 years, 18.9% had NAFLD. Again, the risk factors were higher age, male sex, central obesity, higher BMI, raised sugars, and raised AST/ALT levels. Now, this is a very recent study which was done at AIIMS and Ballarkar, which compared urban and rural divide in these patients. Shalimar was one of the authors. So again, if you look at the composition of this rural population, again, this is almost similar to the urban population. Look at the prevalence of obesity even in the rural population, 50%. Overweight, 20%. Diabetes, 15% of these patients had diabetes, and they still had a BMI which was more than 25. So 25 is the cutoff to define obesity in the Asian population. So 25 was the mean BMI even of the rural population. And when they looked at the prevalence of NAFLD, 65% urban population, 61% rural population. But this is close to Delhi. Again, this has a bias. So that's why I talked about this composition of the rural population. And again, I talked about 0.2% in that rural population. F4 fibrosis detected on fibroscan, 2.8% in the urban population. So 2.8%, that was 0.2%, 2.8% had cirrhosis, 0.6% in the rural population had cirrhosis. What about prevalence in high risk groups? We have been talking about high risk like metabolic syndrome, diabetes, obesity, overweight. So this was patients who present with asymptomatic transaminisemia to hospitals. They come, they get an executive health checkup, their AST/ALT is raised, they come to a hepatologist or a gastroenterologist, and you find that 36 to 48% of these patients have non-alcoholic fatty liver disease. So in a population, if you have elevated ALT, the most common cause of elevated enzymes is non-alcoholic fatty liver disease. Among diabetics in India, these three studies suggesting that among diabetics, it is over and above 50%. So 50% of diabetes at least would have non-alcoholic fatty liver disease if looked for. So I'll talk about two of these studies. This particular study, 100 diabetics, 49% had fatty liver, 32 underwent liver biopsy. Again, this must be a bias because they must be selected to undergo a liver biopsy. But again, look at this, 21% patient already had fibrosis. So diabetes is not only a risk factor for fatty liver, it is also a risk factor for severe form of fatty liver and the form of fatty liver which progresses to end-stage liver disease. Another study, 90 of these 127 diabetics underwent liver biopsy, 37% had fibrosis. And the prevalence of NASH or the advanced form of fatty liver increased with the components of metabolic syndrome. Now, this is a more recent study, again, a bias study from a tertiary corporate hospital in India from Medanta. This was based on FibroScan. 531 consecutive patients with diabetes, FibroScan done, 84% had fatty liver, 28% had advanced fibrosis more than 8 kilopascals, and 7.2% had F4 fibrosis or cirrhosis. Again, there is a bias, but this does tell us that patients who have diabetes and fatty liver are likely to harbor advanced stages of fibrosis and likely to progress. What about those who have cirrhosis? This was a study from explant livers, patients who had cryptogenic cirrhosis. Of them, 63% patients had NAFLD-related cirrhosis. Now, this is a recent meta-analysis, again published by Shalimar, which looked at all the studies done so far among the Indian population, both the adults and children. Among more than 23,000 adults, the prevalence reported was 38%. Again, much more than what we have been thinking it would be. We've been thinking that 1/4 of the population, but almost 40% of the population may be having fatty liver. Among the average risk individuals, it was 28%. Among high risk individuals, 52%. Now, this is the more dangerous thing, and this is the something where we must concentrate on. Among children, 35% patients had fatty liver, and those who were obese, the fatty liver was 63%. What about time trends? We've seen what is among cross-sectional studies. What about time trends? So this is the data from US, 3 large NANE survey, National Health and Nutrition Evaluation Surveys. They have these surveys done periodically in their general population. 1998-94, 99-2004, 2005 to 2008. This is how NAFLD has increased, 5.5%, 9.8%, 11%. This was up to 2008, and now we are in 2022. And this has paralleled with the risk factors, that is the risk, the prevalence of diabetes, as well as the prevalence of obesity. That has risen parallelly with these risk factors. And there have been similar trends for hypertension and insulin resistance, both risk factors for NAFLD. What about time trend in cirrhosis? This is a percentage of incident diagnosis among compensated cirrhosis. So the cirrhosis due to chronic hepatitis C or alcohol coming down, and cirrhosis due to NAFLD rising. What about patients on transplant list? Chronic hepatitis C as a diagnosis for transplantation is coming down progressively, whereas that for NAFLD or NASH-related cirrhosis rising progressively, and that is true for our country also. And believe me, it has overtaken CHC and other causes of chronic liver disease for transplantation. What about HCC? This is data on HCC among more than 1.5 lakh liver transplant candidates, and proportion of NAFLD related HCC, 2002, 2.1%, 2006, 16.2%. And during the same time, this incidence decreased for patients with HBV related cirrhosis or cirrhosis for CHC or alcoholic related disease. So what about burden in years to come? What is the future? Now, please remember the feeder for future NAFLD is pediatric NAFLD, which is the one which is driving severe forms of liver disease. And these are the patients who have long-standing NAFLD over 30, 40 years. These are the ones who are likely to develop cirrhosis, decompensation, and liver cancer. So this is data from more than 2.4 lakh boys and girls between 17 to 13 years, follow-up over 39 years. The risk of NAFLD developing in adults was for per unit increase in BMI during this age group for males and females. Both the hazard ratio were high. Another study among developing severe liver disease among adulthood, 1.2 million men between 18 and 20 years. So adolescents and teenagers, 34,000 person years of follow-up, 5,000 developed severe liver disease, and the risk of developing severe liver disease in adulthood was associated with overweight in adolescents and obesity in adolescents. Look at the hazards ratio. What about HCC? 2.8 lakh boys and girls between 17 and 13 years of age, 438 later developed liver cancer. The BMI scores, the body mass index scores between 7 to 13 years were the independent risk factors for developing liver cancer, independent of their intake of alcohol, their exposure to viral hepatitis, or other causes of liver cirrhosis. So what about obesity in Indian children? Are we also facing a similar kind of trend? So prevalence data from 52 studies from Indian states, 2001, 2005, 2010, beyond 2010. This is how the prevalence of obesity in children has been increasing. And this was up till 2010, and I'm sure this would be higher. We are standing in 2022. So what about the future burden? We looked at the feeder, how this is going to pan out in future. So this was a study again from US using prevalence data of obesity and type 2 diabetes in the population. They used the estimates of NAFLD in these risk groups and found out the expected prevalence in general population, used it in Markov model to predict the outcomes in 2030. So the risk of or the incidence of NAFLD is bound to rise by 21% and that of NASH by 63%. And a steeper rise for complication, incident decompensated cirrhosis 168%, incident liver cancer 137%, incident liver related deaths 178%. So to summarize, ladies and gentlemen, the global prevalence of NAFLD is about 1/4 of the general population. In India, it ranges between 8 to 61% in rural population based on the various studies, 18 to 65% in the urban population. In special populations, it is upwards of 50% usually, and the risk factors are overweight, obesity, diabetes, dyslipidemia, and advanced age. The trends show a rising prevalence of NAFLD and its complication across the world. Over the next 10 years, there'll be a rise in prevalence of NAFLD and NASH and a steeper rise in complications. But please remember the major feeder for future NAFLD is pediatric obesity. So please say no to childhood obesity and work on it. Thank you.
That's a wonderful talk, Kausal, and I think you covered every aspect so well and so lucidly that I think we decided to take the question at the end. And can we request my co-chairman, Dr. Manoj Sharma, to invite the second speaker? Dr. Manoj?
Yeah. Our next speaker is Dr. Umang Garuda, who is a senior resident in gastroenterology department at All India Institute of Medical Sciences, New Delhi. He is a graduate and postgraduate both from AIIMS, and he has represented India at International Biology Olympiad in 2013 and 22 international publications in such a young age. Dr. Umang Garuda, please. And his topic of lecture is normal physiology and metabolic perturbations of carbohydrate and fat metabolism in the context of MAFLD.
Good morning, everybody. Thank you for having me today. I'm Dr. Umang Arora. As we have learned from Dr. Madan sir's talk, that the burden of NAFLD is progressively increasing and it's worrisome of what is to come ahead. So it's important for us to understand the pathophysiology of how NAFLD develops. So today I will be talking about the normal physiology and metabolic perturbations of carbohydrate and fat metabolism in the context of NAFLD and how all the metabolism carbohydrates of fats are interrelated. So we will be discussing the basics of normal carbohydrate and fat metabolism, how they're altered in patients who are obese, and the link between obesity, insulin resistance, and NAFLD. So a person with a normal physiology develops a metabolic derangement, which leads to development of diabetes, hypertension, NAFLD, and coronary artery disease, the amalgamation of which is called a metabolic syndrome or syndrome X. And the downstream consequences of NAFLD with NASH, cirrhosis, and HCC are consequent to that. So we will be understanding what are the metabolic derangements that are responsible for NAFLD. So the genetics and environmental factors, including diet and sedentary lifestyle, are the root cause of NAFLD, and the mediators of which are lipid excess or lipid lipotoxicity, glucose metabolism changes, pro-inflammatory cytokines, and gut microbiome, of which the first two will be discussed by me, and how they lead to NAFLD. How does one develop fatty liver, or how do we make an animal model for fatty liver? So the first step would be to gain weight. Second would be to develop insulin resistance or diabetes. Third would be the consequent hormone and cytokine imbalances. And fourth would be NAFLD. However, this is an oversimplified approach. So we, like the chicken and egg tail, we don't know what comes first, whether it's obesity, whether it's diabetes, whether it's insulin resistance or NAFLD. And there is ample literature to suggest that there's a bidirectional relationship, such that obesity can lead to insulin resistance can lead to diabetes, and the rest you can see on the screen. So we don't know what comes first, even though we have some clarity on the chicken and egg, but we don't have that clarity with NAFLD yet. A healthy body in this context is defined a person with normal fat distribution, healthy adipokine levels, no excess inflammation, and a healthy insulin glucose interaction. So a healthy fat distribution in this context would mean that a person even with a fixed amount of fat, it can be distributed in various ways. There can be more or less visceral fat, more or less subcutaneous abdominal or lower leg fat. It has been seen that people with more subcutaneous lower limb fat and a comparatively less amount of visceral fat are healthier in terms of their adipokines as well as cytokines. And these fat distributions are not fixed. It's important to know that they can be modified by diet, by exercise. And that's why these are what we considered modifiable factors. The carbohydrates and fats, we see that on the left, we can see meat, egg yolk, and butter as the source of fat in our normal diet. And roti, rice, and sugars are the source of carbohydrates. So we will try to understand what happens when we consume bread and how does it lead to NAFLD subsequently. So the step one of this would be to digest the carbohydrates. And the final step would be ATP synthesis so that this man can run with energy. However, the process is a little more complicated than that. And that's what we need to understand. So we start with simple sugar that we take with our tea or any sugary beverage. And it enters the stomach, from where it is digested and broken down into simple sugar molecules like fructose and glucose. And that reaches from the bloodstream to the liver after absorption. Once it reaches the liver, it enters via the GLUT2 receptors, and then it can have several consequences. Either the glucose molecule can be used to generate energy in the form of ATP. It can be used to generate glycogen for short-term energy storage, or it leads to generation of fat, which is the long capacity storage in our body, of which this system is regulated by insulin. And once the central molecule which dictates whether fat will be synthesized or not is acetyl-CoA, as we can see on the blue arrow. Acetyl-CoA can enter the Krebs cycle in the mitochondria after shuttling from pyruvate from the cytosol to yield either energy in the form of ATP, or it can come out of the cytosol and form triglycerides. And this is important to understand. How does the fat that we have seen being developed from glucose or other sources, how is this interrelated? So we will try to understand the fatty acid pool of the liver. So there's an intake via three sources. Importantly, the adipose tissue is the main source of hepatic triglycerides. So more than the diet, the metabolic changes in the form of different adiposity profiles that we can have, say more visceral obesity, the more amount of adipose tissue in the body, that is the main source of triglycerides and fatty acids that reach the liver. The second source we can see is when we consume this piece of butter, it gets digested by the pancreatic lipase. It forms chylomicrons, which are neatly packed by the intestinal cells to enter the lymphatics. And subsequently, once the adipose tissue and skeletal muscles choose what they want, whichever is remnant of it, whichever is left of it, that is taken up by the liver. And the third source is de novo lipogenesis. To briefly understand this, most of the fatty acids that reach the liver are from the adipose tissue already existing in the body, and a smaller proportion is contributed by diet and dietary excess of fats as well as dietary excess of sugars, which lead to de novo lipogenesis. Subsequently, the fatty acids that are already there in the liver, once they've reached, what happens to them? Are they utilized for beta oxidation or ketogenesis? Or do they get stored as lipid in the liver, which is what we call fatty liver? Or are they exported as VLDL molecules for the rest of the body? So this is dictated by the level of insulin. So if patient is insulin, when the insulin levels are low, which means that the person is having energy deficiency, so he will undergo fatty acid breakdown to yield oxidation and ketones for the body. However, in insulin excess state, as we will discuss in the hyperinsulinemia that occurs in patients with insulin resistance, there's a preferential development of liver steatosis. Another factor that dictates whether beta oxidation will be preferred or lipolysis will be preferred, whether fat will be broken down or stored, is the type of fat. So a saturated fatty acid, which only contains single bonds between the carbon molecules, will preferentially get synthesized into triglycerides and form lipid molecules, while unsaturated fatty acids, which have double bonds and is more prone to enzymatic reactions, will preferentially undergo beta oxidation. So this is the on the right side, we can see what happens to the liver molecule, the adipose tissue. Glucose from the blood enters the adipose tissue in the presence of insulin to form acetyl-CoA, which leads triglycerides. So the adipose tissue is able to take up glucose from the blood and form fat within it. In the absence of insulin or in the presence of insulin resistance, which yields the same mechanism, the triglycerides are broken down to yield free fatty acids, which are enter the blood and eventually reach the liver to form triglycerides there. So the last line I would like you to note, visceral fat lipolysis is the most important source of fatty acids for hepatic triglyceride synthesis and what results in non-alcoholic fatty liver disease. So, we need to understand that not just the liver, but there are several organs which have an interplay in this process. So for example, the pancreas is the source of insulin for this regulation. The adipose tissue is the warehouse where the adipose is, the lipids are stored. The skeletal muscles is the source from which insulin resistance results in decreased uptake of glucose and results in hyperglycemia. And intestine contains the gut microbiota, as well as the can affect the absorption of glucose and fat molecules, which leads to a combined 5-organ metabolic dysregulation. So we will also cover the journey of what happens to the extra sugars and fats we eat. So whenever we consume excess sugar in a patient who is not having any features of insulin, who is having energy surplus, that fat will not get broken, that sugar molecule will not get broken down to an acetyl-CoA, because that acetyl-CoA will get shunted to form saturated fatty acids. Secondly, the saturated fatty acids can have downstream consequences in the form of ceramides, which are important for cardiovascular adverse events of obesity-related inflammation. Third, the inflamed adipose tissue, excess of visceral adipose tissue, can directly lead to lipolysis of the peripheral visceral fat, which enters the liver to lead saturated fatty acids. And finally, the downstream consequences of this increased fat itself can lead to insulin resistance, mitochondrial dysfunction, and interference with the electron transport chain. As Sir has discussed, we live in an obesogenic world where there's a progressively increasing calorie intake of the general population. Over the 3 decades, there was at least 25% increase in calorie intake in the population. So we're all becoming more obese over time. Importantly to note is that the food items, when they mention the free or added sugar, they don't tell us about the consequences of it. A dose-response relationship has been seen with consumption of sugar beverages. A person who's consuming a sugar beverage even less than once a week has a 14% higher risk of developing non-alcoholic fatty liver disease than compared to somebody who never consumes sugar beverages. And this risk is as much as 53% who consume daily, which may include many of us here. Saturated fatty acids rich diet are more capable of leading to fatty liver and contribute to intrahepatic triglycerides than PUFAs or MUFAs. As I've said, that they're less prone to beta oxidation. Similarly, the total calorie restriction has been shown to reduce intrahepatic triglycerides. So the more amount of calories you take, regardless of whether you take carbohydrates or whether you take a fat predominant diet, as we can see on the bottom right, a hyper energetic diet, regardless of the composition, increases intrahepatic triglyceride concentration And a low energy diet, which means that you are able to reduce 500 kilocalories a day, leads to reduction in hepatic triglyceride content, regardless of the composition of what you're able to consume. We will briefly discuss the role of inflammation as well. A normal inflammation is able to protect us from the pathogens that commonly exist in our environment, in the gut microbiota, the skin, and outside. So an innate immune response is always present with us, and it protects us from pathogens. However, when this response becomes aberrant and extreme, it leads to chronic inflammation, which can have deleterious effects that we will be discussing. So the plasma-free fatty acid concentrations are increased in patients who are obese, and they have downstream effects with toll-like receptors, which I'm sure many of you are working with. Toll-like receptors are surface receptors which respond to pathogen and damage-associated patterns. So the toll-like receptors downstream produce TNF alpha and IL-6, which further contribute to insulin resistance. And we will be discussing that subsequently. Another factor that plays a role is the differentiation of macrophages. So macrophages can have two phenotypes. From a nascent macrophage, they can form an alternatively activated macrophage, which is the M2 or the anti-inflammatory type, or an M1 phenotype, which is pro-inflammatory. So a normal person with a lean adipose tissue will have a predominance of M2 macrophages, as we can see on the left, with no or negligible amount of dying adipocytes and no neutrophils or other features of inflammation. However, in an excessively obese person, the adipose tissue itself becomes inflamed. Will have dying adipocytes. As we can see, there will be clusters of activated M1 type of macrophages that lead to increased levels of free fatty acids, TNF alpha, interleukin 1 beta, and MCP1, which is the monocyte chemotactin protein. So all of these lead to a pro-inflammatory state in the setting of excess obesity. To summarize this slide, the increased inflammatory cells in adipose tissue develop in patients who are obese. There is an M2 to M1 switch in the macrophage phenotype, which indicates that an anti-inflammatory phenotype is being converted to a pro-inflammatory phenotype, and there production of cytokines. To understand the interrelationship, it's important to understand how obesity leads to NAFLD, and the central crux of this is insulin resistance. So what is insulin resistance? Normally, insulin acts on its receptor, which is a tyrosine kinase receptor, and after phosphorylation leads to production of insulin response substrates, which enable translocation of GLUT4. GLUT4 is a glucose transporter molecule that allows glucose uptake in tissues such as adipose and skeletal muscles. However, once a person is obese, the obesity leads to production of fatty acids, as well as on the bottom, we can see the obesity-induced cytokines, TNF alpha and IL-6, that leads to production of diacylglycerol. The diacylglycerol molecule is responsible for activation of protein kinase C epsilon, and that leads to serine phosphorylation instead of tyrosine phosphorylation. To simplify, the tyrosine phosphorylation is altered to form a serine phosphorylation, which prevents the insulin molecule from acting on its receptor functionally, and GLUT4 is not able to reach the surface. So in a normal insulin action in a patient who's fed, the insulin results in different effects in the liver and peripheral tissue. In the peripheral tissue, insulin mediates glucose uptake via the GLUT4 receptors and leads to lipid synthesis and decreases lipid breakdown. While in the liver, insulin is also increases lipid synthesis and decreases gluconeogenesis. However, in a person who has insulin resistance, insulin will not be able to act on the peripheral tissues, but still continues to act on the liver because GLUT2 receptor is not dependent on insulin. So there's a decreased glucose uptake by the peripheral tissues like adipose tissue and skeletal muscle, as well as increased fat breakdown in the periphery. So adipose tissue and skeletal muscles have an increased fat breakdown going on, and the fatty acids reach liver. And subsequently, because there is uninhibited lipogenesis going on, so a peripheral breakdown which has increased reaches the liver, which is also still active and leads to increased fatty acid deposition. So the GLUT4 receptors subsequently lead to a hyperinsulinemic state as well, and that further worsens the lipogenesis that occurs. So to simplify the orchestra behind it, the patient with a normal liver without steatosis and a normal appearance on ultrasound develops obesity due to excess intake of sugary beverages, burgers, and other food items. And this constitutes what we call a HIT, and it develops fatty liver that we see. So fatty liver, the hit can usually be in the form of obesity, diabetes, insulin resistance. However, there have been several theories that have come up that are beyond the scope of the discussion, which is called the multi-hit theory. And the multi-hit theory indicates that gut microbiome changes, increased obesity, diabetes, all of them constitute different number of hits to the liver, which progresses from NAFLD to NASH and eventually to cirrhosis. The take-home messages for this talk, to summarize, a positive energy balance contributes to weight gain. The weight gain itself contributes to development of visceral adiposity, and this visceral adiposity contributes to insulin resistance. And the insulin resistance and hyperinsulinemia, they promote adipose tissue lipolysis and hepatic lipogenesis. The key components of the deranged metabolism include excess adipose tissue output of free fatty acids, as well as chronic inflammation arising from the fat itself. Other components that we have not discussed today, macrophages, apoptosis, inflammasome, and mitochondrial dysfunction, also mediate the progression from a patient having NAFLD to NASH. But the initial step of steatosis requires primarily a metabolic dysfunction. I thank you for your time.
Thank you, Dr. Umang. And now the floor is open for questions, comments, discussions. Okay, I would like to start with Dr. Kaushal. About 10 years ago, it was believed that the natural history of NAFLD in India is quite benign. So is it still the same or something has changed?
So again, I'll talk about the time when I started working on NAFLD, and there were people who used to say that NAFLD is the IBS of hepatologists. That means it was considered a very benign disease, only a means to do research and earn money. But I think over last 10 years, people have realized that, like I shared data also, that NAFLD is fast becoming the most common cause of chronic liver disease in the community, the most common cause of cirrhosis, liver failure, as well as liver cancer. So it is not a benign disease. Only issue is that we have to find out that group of patients who are likely to progress. So if you talk about 100 alcoholics, 100 people who abuse alcohol, 15 to 20% will have a bad liver. Similarly, if you talk about 100 people at risk of fatty liver, only 15 to 20% will have a progressive form of fatty liver disease. So it is important to recognize this 15 to 20% of the population which are likely to progress and have bad outcomes.
Any questions from the floor?
Yeah, I wanted to, I needed a comment on this. What the sense I got was you consider polyunsaturated fatty acids healthier than saturated fatty acids, right? So there are multiple studies which say that polyunsaturated fatty acids, especially from plants, pro-inflammatory, and they increase the inflammatory profile. So how does that work?
So there is a discrepancy in the literature in the predominant description of saturated fatty acids and PUFAs is derived from literature on coronary artery disease, which has been studied more extensively than NAFLD as of now. So the guidelines have for the last 20-30 years suggest that the saturated fatty acid intake should be less than 10% for a healthy diet. And this is based on very small studies. So there's also going to be a discrepancy between what we find in the lab versus what we find in the diet, because dietary recall is always going to be a contentious issue. Right. So PUFAs and MUFAs with omega fatty acids, and the more unsaturated fatty acids considered, that it's going to be easily able to undergo beta oxidation. So the pro-inflammatory state, whether it yields to it, is difficult to prove, because the diet is going to be a very complex mechanism, the amount of which a person takes based on recall. So the lab experiments showing pro-inflammatory state will be difficult to confirm in a real life scenario.
Because animal studies have shown that they're more pro-inflammatory.
Yes.
The other question I wanted to ask is, how do you place time-restricted eating within a window of, let's say, 8 hours or 10 hours? Because that is known to reduce hyperinsulinemia and improve the insulin profile and lipogenesis.
So you're talking about intermittent
rather than
fasting?
Reducing the total number of calories, do you also consider the time-restricted eating as something that would help
So you're talking about intermittent fasting, I assume?
Yes.
So even though they have shown to have metabolic changes in the form of insulin levels, however, there's a recent study published in NEJM which suggested that over a course of a year, patients who had total calorie restriction with or without intermittent fasting, there was no reduction, there was no difference in the amount of weight loss that they were able to achieve. So it is possible that at least total calorie restriction is of prime importance, whether or not intermittent fasting is able to help on that we have one study which shows that it doesn't help, but we might have further literature coming up on that. But total calorie restriction seems to be of prime importance. Without that, intermittent fasting may not help.
Thank you.
Yeah. Please go ahead.
Now I heard that that there are 3 risk factors. Just now as explained that in versus genetics and the 2 are the.
Can I see
lifestyle
where
and
you're
the
sitting,
food.
please?
Sir?
Okay, sorry, please go ahead.
So as I heard, there is a reversibility can be happen when we change our lifestyle or any food habits. Can you please comment on the genetics? How play a role, and will there be any effect on the reversibility of NAFLDs or any such thing?
So genetics, essentially, there's been a few genes which have been implicated in the pathogenesis of NAFLD. These include TEMPRIS, they include PNPLA, and they have had a lipase-like action. Those, like for example, PNPLA has a lipase-like action in mouse models. Their exact role in humans is less clear, and it has been more so. The initial studies which detected PNPLA were able to detect that Hispanics have a higher proportion of PNPLA gene, and that correlated with the increased triglyceride concentration compared to African Americans and Caucasians. So, of course, with our diet and exercise, we not be able to affect our genetics, but we definitely can reverse some components of it. So it's a multi-hit hypothesis. We can reduce some of the hits in terms of affecting our visceral adiposity to peripheral adiposity ratio, and reducing the metabolic inflammation that occurs in the abnormal obese tissue. Weight loss, regardless of the genetics, would improve NAFLD, hypothetically at least.
Thank you.
So I think as the epidemiology suggests, so the prevalence increases with age. So definitely the duration of exposure. So duration of exposure to obesity, duration of exposure to all the negative hits during this course determines how things will go on. There was also a hypothesis that patients who have simple fatty liver and patients who have advanced fatty liver, from the beginning, they are destined to have advanced fatty liver, or from the beginning are destined to have pure fatty livers, and they will not progress. But I think more work needs to be done on that. So that is also a hypothesis that patients who do develop advanced disease, they were destined to have that, possibly by genetic influence.
Sir, I have a question for Dr. Madan. Sir, the data you presented, that was really very scary. So thank you for sharing this with us. My point here is like, is there any study that has been done either with the soldiers or the sport persons, and that presented the similar kind of prevalence or something?
You mean a population who is physically more active?
More active.
So there is data that patients or subjects who are physically more active are less likely to have fatty liver or have lower fat in the liver. There is data on that, but I'm not aware of any study in sports persons. But that data is there that patients who are indulging in more physical activity, may not necessarily be sports, are likely to have lower fat and lower insulin resistance.
And in this line, another point is like, is any information do we have about the sumos which, who are in Japanese who are obese? We all know that. So how they deal with this kind of situation?
So I think, like somebody raised this point, genetics also play a very important role. We've been seeing many international patients in our practice who come from Middle East, and if you look at their body profile, they are huge and they are very obese, but they have very good muscles also. So good muscle mass also appears to be protective against development of fatty liver. And when we look at their LFT profiles, they're all normal. So if you have a similar patient from India or Asia, you will have higher risk of having fatty liver and higher risk of liver injury.
And the last point is, sir, we understand like the prevention and cure, both are important in this situation. So is there anything we can do at policy level at for the, I would say the school kids or something like in that group, where we can, or the government, if we introduce this activity, that will help us to have the greater impact on saving those patients or minimizing the number of potential patients later on. So any point in this direction?
So that's why I ended my talk with that particular slide, that we have to say no to childhood obesity. As I mentioned earlier also, it is the years of exposure which leads to that. So if a person is obese or overweight from childhood and has visceral fat and abnormal fat since childhood, so when he reaches the middle age, he's had exposure to that kind of inflammation, that kind of fat, which is likely to progress. So start at the basics, start at, like you suggested, start at in schools, to educate the teachers, the parents, as well as the children about the healthy lifestyle which they should be leading.
Yeah, Kaushal, excellent presentation as usual. My question is, all the data which you have presented on the prevalence of NFLD is ultrasound based. Ultrasound will pick up fatty liver when more than 30% of the liver has fat. But by definition, if you look at histopathology, if you have 5% of the fat, it is NFLD. Is it that we are still underestimating it, or with ultrasound fat may not have any meaning, as Pramod said, you may have something additional to lead on to more onerous problems like NASH. Otherwise, if keep on picking 5% of the fat, then 99% of the population will be fatty liver.
Right. So I think in imaging, the most accurate or more specific method is by MRI PDFF, but obviously that cannot be taken to the periphery and cannot be available in all centers. But fibroscan is something which can be carried to periphery, and if we have a sprouting of those machines in the periphery, we will be able to pick up more fatty liver and more accurately than just an ultrasound.
And secondly, isn't the first hit the prerequisite for subsequent hits? Or can you just simply present with NASH and cirrhosis? Do you always have to go via that process?
I think we had this discussion and debate in the meeting which you had organized. And I think it's very important. And we had that discussion earlier also, that without basic fatty liver, the patient is less likely to progress. So hitting the first hit also makes sense, because nowadays people are only concentrating on targeting the second hits or the later hits or fibrosis, but targeting at the base when the fatty liver has not started or just started would be more apt.
Yeah, I'll agree with you. I think we always undervalue fatty liver, and we are looking for the factors which will produce a second hit, forgetting the first hit, which is so very important.
Hello, sir. I have a question. So this question is on the behalf of Professor Shri, but she's online. She wants to have you comment on the fatty liver during pregnancy and its effect on fetal growth.
I'm sorry, I have no experience on that, and how it affects fetal growth, I'm not aware.
So there is a question from my side also. So can you comment on lean phenotype in adult as well as in pediatric patients? So are you seeing lean fatty liver or NASH in pediatric patients?
So we don't see too much pediatrics because I'm an adult hepatologist, but yes, adolescents, we are seeing patients who are lean, or adults who are lean who have fatty liver and significant fatty liver, significant liver damage. But all studies suggest that all these lean individuals who, although look lean, but are not metabolically lean, they will have higher visceral fat. Like he said, that it is the distribution and the kind of fat which is responsible. So they will be metabolically obese. They will have higher visceral fat. They will have, if you look at, compare the lean individuals with NAFLD from normal individuals who do not have NAFLD and are lean, they will have higher risk of pre-diabetes, higher risk of hypertension, higher dyslipidemia, higher visceral fat. So they actually are earlier versions of patients who later on become obese and have advanced fatty liver.
Yeah.
So-
So you talked about the insulin resistance and the risk factor for NAFLD. So is there any correlation between type 1 diabetes and the development of NAFLD?
Type 1 diabetes.
Because insulin resistance mainly it is in type 2 diabetes. So I want to know that what is the chances of NAFLD in type 1 diabetic patients?
Type 1 diabetes can develop a small component of insulin resistance further down the course. It may not have it at diagnosis or at presentation, but can develop insulin resistance later. The prevalence of NASH and NASH or NAFLD in type 1 diabetes is definitely lower than that is in type 2 diabetes, and that may mimic the levels of NASH and NAFLD that we have in the general population with lean phenotype. So 10 to 15% in at least 10% of the general population, even those who are lean, may have NAFLD and NASH, and that may correlate with the type 1 diabetics. However, the prevalence is definitely lower than type 2 diabetics.
Thank you.
Sir, I have a question with Dr. Kaushal, sir. Sir, during your time, have you come across with any patients who are having HCC by knowing the AFP? That this is very high, so we say that the patient might be having HCC. That patient may have taken, it is a late onset, so this might have taken some time to develop. So other than that, the patient may have cirrhosis also. So what are the co-markers you check for that one? Are there any common markers?
Are you asking that patients of cirrhosis whom we follow up, during the follow-up they develop liver cancer, so how we detect them? Is it
So cirrhosis was undiagnosed, but HCC was diagnosed.
Yes. So in our clinical practice, I think all of us have come across such patients who present for the first time with liver cancer. Their cirrhosis was undiagnosed. They present to us with some symptoms. You investigate, it turns out to be liver cancer. That all of us have come across such patients. That's true. And yes, alpha fetoprotein is one of the markers which alerts us that they might be having liver cancer apart from imaging.
We are having a lively discussion, but in the interest of time, I would request Professor Acharya to give final comments and close this session. Professor Acharya, please.
No, obviously, from the discussion, you understand there are a huge amount of gaps and knowledges in this area, including the nomenclature about the debates. And a lot of data is needed from our nations, starting actually from prevalence. And as you see, the prevalence of various studies is widely differing, because the population representation in the prevalence study has to be thoroughly evaluated. Also, you don't have the questions Professor Arora was asking, and the cross-sectional patients we see NASH, cirrhosis, and fatty liver. But as a long-term follow-up, a small proportion of fatty liver develop progressive liver disease. And those progressive markers are not clear. And you have discussed about the genes or other ethnic factors which are being implicated, not very clear. And also you don't know how to treat them, except controlling diet and exercise, which is the basic weakness of human beings. So obviously there is no doubt it's a disease of human behavior and risk factor associated with human mind. Now, to manipulate the pathogenesis because of this risk factor of behavior and human mind will be extremely complex, very difficult. While we are providing our attention to the physical part or system biology of it and trying to intervene, there had been a huge neglect on the mental health issue of this group of people, and which will be the primordial prevention. And I think that is a very important aspect, what I find. And I must congratulate both the speaker who were very knowledgeable and who have done very well. I thank you, my co-chairperson, Dr. Manoj Sharma, and very thank you, sir. And I must thank PHSTI and its director, Professor Pramod Garg, to have remembered and make us learn from this very important session. Thank you very much.
Dr. Manoj Kumar and Dr. Kaushal Madan, I would request you to kindly stay back for the felicitation. I would request Dr. Manoj Kumar to kindly felicitate our session speakers, Dr. Kaushal Madan and Dr. Umang Arora. Thank you, everyone. We now request Professor Garg to kindly come up on the stage and felicitate our session chairs, Dr. Subrat Acharya and Dr. Manoj Kumar. We will now break for tea. The volunteers are requested to kindly escort the session chairs and speakers. We appeal the audience to disperse smoothly and reconvene for talk 3 and 4 by 11:30 a.m. The participants for poster presentations can meanwhile mount their posters, as their posters will get evaluated during the lunch break. Thank you. We request all the delegates present to kindly be seated so that we can start our second session now.
We request everyone to please settle down as we will be resuming our session shortly. We also request you to kindly keep your cellular devices on silent mode. Welcome back. Let's take up again with our ongoing session on disease prevalence, risk factors, and pathophysiology. We would like to request Dr. Ajay Kumar and Dr. Anup Sarai to kindly come up on the stage and chair this session. Dr. Ajay Kumar is the chairman and head of department at BLK Max Institute of Digestive and Liver Diseases, New Delhi. He was the president of the Indian Society of Gastroenterology and an eminent member of Central Council of Health and Family Welfare. He has a special interest in MAFL and microbiome. Thank you, sir. It's an honor to have you here. As second chair, Dr. Sarai is the professor and the head of gastroenterology department at AIIMS, New Delhi. He specializes in hepatopancreatobiliary diseases and has published more than 200 research articles. He also co-authored 4 books on public health and national food security. Sir, thank you for joining us today. The question and answer segment will be taken up after talk 4. We now invite our next speaker of the session, Dr. Shalimar, to please come up on the stage. We request Dr. Ajay Kumar to kindly introduce Dr. Shalimar to the audience.
Thanks to Dr. Pramod Garg for organizing such a wonderful meeting in such a wonderful place and a wonderful audience. Really impressed with the morning question answer discussion part, which actually shows the depth of the audience involved here. Well, friends, we have talked more in the morning lots about NFLD, obesity, metabolic syndrome. And interestingly, questions were raised and partly debated that is there a role of genetics? Is there a role of a microbiome? So do you have anything other than non-obesity? And to address those questions, we are the next topic's heading like, is there an inherent predisposition to NFLD, particularly in non-obese individuals, the so-called lean NASH? We have none else but Dr. Shalimar from All India Institute Medical Sciences, New Delhi. He is additional professor there. And Shalimar, I know from a long number of years. He's a keen research worker, deeply dedicated to the research in liver diseases. He has more than 12 years of experience and his total commitment is to the research in the liver. And of course, like his senior Dr. Acharya, his interest is liver failure and non-alcoholic fatty liver disease. And he has published more than 70 publications in the field of hepatology. And we're looking forward to listen to you, Shalimar. Over to you. Thank you very much.
Thank you, sir, for the kind invitation. At the outset, I'd like to thank the THSTI team for the kind invitation. Okay, can I have my slides, please? So my task is to take you through, is there any inherent predisposition to NAFLD? Now I've added the term MAFLD. Now we're not debating today what is the difference between NAFLD and MAFLD over here, particularly non-obese individuals. So let me ask the audience out here, how many of you think you're non-obese or obese? Keep that in mind, we'll come back to it. How do we define obese and non-obese? So it is very important to understand that these terms have been defined on the basis of body mass index. For the Europeans, it's a cutoff of 25. Above that, we consider them as between 25 and 30. We consider them as overweight, and obesity is more than 30. In contrast, data from Asians suggest that a lower BMI cutoff should be kept in mind. To simplify things, BMI is defined as weight divided by height in meters square. So I would request that each one of you should calculate this BMI right now, and then we'll see that are you at risk of developing non-alcoholic fatty liver disease at the end of the talk. So Asians, its cutoffs are 18.5 to 22.9. Overweight is up to 25, and obesity is 25. In contrast, Europeans are above 30. You heard about this. I've given you this cartoon which shows you 3 distinct phenotypes. You can think, where do you fit? Just on the basis of BMI, you calculated your BMI and see, are you lean with NAFLD, and obese with NAFLD? As you progress from these 3 distinct phenotypes, there is a change in the distribution of adiposity as highlighted by Umang in his talk. So there is, as you move from the left to right, there is more visceral adiposity, there is decreased peripheral adiposity, there is impaired glucose tolerance and increased lipogenesis. It becomes even more worse as you become obese NAFLD. So keep this in mind. You've heard about this prevalence study. So the debate came in on this lean NAFLD thing with this, one of the initial studies from West Bengal by Professor Abhijit Chaudhary and his group showed that the NAFLD prevalence in a rural population was around 8.7%. Important point to highlight from this study was that 75% of these individuals had a BMI of less than 25. So even with lower BMI, you can develop non-alcoholic fatty liver disease. So each one of you who's calculated your BMI, even if you are lean, which you classically think you are healthy, you may still be having non-alcoholic fatty liver disease. And this was also pointed by Dr. Kaushal, is that as the BMI increased, the risk of non-alcoholic fatty liver disease increased in this population. But this is an extreme example of disease phenotype in the community. This is what not you would see in the whole of India. So in order to interpret these findings, the authors should have looked at multiple other causes of non-alcoholic fatty liver disease, which they didn't look at in this study. Dr. Kaushal highlighted. Important thing which I want to highlight from this slide by showing you again is the recent updated meta-analysis suggests global prevalence of NAFLD is 29%. It's gone up from 25%, as was shown in the International Liver Congress day before yesterday. So the authors initially reported 25%, 2022, it is 29%. And NAFLD is present across the globe. Coming to our topic of interest, lean NAFLD. I talked to you about lean NAFLD is defined by different BMI cutoffs in the Western and Asians. Important to state out here is that the lean NAFLD constitutes from almost like 10% to 60% of the total burden of non-alcoholic fatty liver disease. Coming to what's important to us is in the Indian context, it's around 25 to 40% of our patients, what we see could have, that is would of the all NAFLD, almost like 25 to 40% would have lean NAFLD. Looking at the global prevalence of MAFLD, so now is the term which is MAFLD. Similarly, it's reported to be the prevalence to be around between 10 to 60%. And coming to India, it would be somewhere around 25% prevalence of MAFLD in India. This you've heard, so NAFLD is quite prevalent. You heard the study data from Ballavgarh showing a prevalence of 55%. So I bet we constitute the same belt of that area, and half of the people sitting out here in this auditorium have non-alcoholic fatty liver disease. It's that we tend to ignore it, but it's there. Coming to the pathogenesis, you heard about this from Umang. Important to state out here the various players in the development of non-alcoholic fatty liver disease. We've moved to more of a Western diet. There is increased consumption of dietary sugars. We do not tend to exercise these days. What fraction of you, if I may ask, do any kind of exercise? You can raise your hands. How many of you are regular with exercise? I'll say it's around 20% of the audience have raised it. That means 80% of our sedentary, and feel very happy that we do our job from 9 to 9 sitting in the office, but we are not doing any kind of exercise. So our muscles are a problem. Muscles play a role in the pathogenesis of non-alcoholic fatty liver disease. The liver, the workhorse, takes up lipids and moves out the lipids through VLDL, and this is the work of the liver. In addition, we've got white adipose tissue, and you heard about insulin resistance. So these all factors play a role in the pathogenesis of NAFLD. What about in lean NAFLD? Not very different from what I had discussed, but important to state some of the factors which play an important role in the pathogenesis of lean NAFLD include higher prevalence of insulin resistance, muscles, which I have already talked about, resistance at the level of the peripheral adipose tissue, gut microbiome, which you would be hearing in the next talk, which I'll also discuss in the later part of the slides, and I'll address to a couple of pertinent questions which were asked in the previous talks about the role of genetics. And then is the role of IUGR and something to do with the intrauterine growth retardation, which happens during pregnancy. How do these factors play a role in the development of non-alcoholic fatty liver disease? Lean MAFLD, again, a similar kind of interaction between the genetics, epigenome, environmental factors, pancreas, muscle, adipose tissue, all leading on to the development of lean NAFLD. Okay, let's come to the important points. Which are the risk factors for non-alcoholic fatty liver disease in non-obese? You've all calculated your BMI. So how many of you are overweight, BMI above 23? Please raise your hands. So I think quite a significant fraction of you are overweight as per the Asian cutoffs. You don't know your sugars because you've never been evaluated. You don't know your diabetes status. Body fat distribution. Now there are simple machines which are available to look at your body composition. You can easily measure your bicep skin fold thickness, waist circumference, insulin resistance, and gene polymorphisms. The reasons why I've highlighted all these points I'll discuss in the next couple of slides. You think you're immune to development of diabetes? Look at this data. Comparison of Asian Indians with the whites. Look at these different cutoffs for BMI: underweight, normal weight, overweight, obese. In patients who are in Asian Indians who are normal weight, 22% of these individuals will have diabetes. This is in stark contrast to the Westerners. Both in men and women, this stands true. We are at higher risk of development of diabetes. India is the diabetes hub of the world. The number of diabetics are expected to be around 81 million this year, or it's already beyond. The number is much, much higher than what's written over here. Insulin resistance. You heard about its role in the pathogenesis or development of NAFLD. Interesting study from United States. Comparison of different ethnicities of individuals who were non-obese, who were sedentary, similar kind of lifestyle. Look at this. The insulin resistance among Asian Indians is much higher than what you see in Eastern Asians, Blacks, Caucasians, Hispanics, almost twofold. We have higher insulin resistance as compared to other ethnicities across the globe. When they looked at the amount of fat in the liver, which is meant by liver triglyceride levels, look at that in the Asian Indian groups, much higher than the Caucasians. And even after adjustment of other factors, it was much higher. So we per se are more predisposed to develop insulin resistance, increased fat in the liver, despite having other phenotypic characteristics which are similar. That is, despite being lean, non-diabetic, non-smokers, we have more fat in our livers. Dyslipidemia. Another interesting factor which is correlated with the pathogenesis of non-alcoholic fatty liver disease. Normal BMI group, at least 20% will have abnormality in either of the 5 different lipid profile parameters. So these things exist in us. We need to evaluate, detect, and diagnose it. It's there, but it's not detected. What we saw in the question which I asked, almost only 20% of you do some kind of exercise. Look at this data, which is published from India. Among those who got BMI, which is between normal and overweight, almost like 60% of those with normal BMI are not doing any kind of physical activity. We're becoming more sedentary. This would be even more worse in the post-COVID era, when people are working from home, not even going to the office, traveling is less, social interactions are less, children are paying less. This is what we are going to see its effect in the decade to come. Another interesting hypothesis is this thrifty genotype or the thrifty phenotype hypothesis, which has been raised for the development of non-alcoholic fatty liver disease, or more so for the development of diabetes. Our ancestors were hunters. So a hunter needs what? It needs food, and when you get food, you need to store it. Then there would be a period when you were not going to get food, and there would be starvation. So you would need these body stores of fats to move. So these kind of genotypes would definitely help in survival during that time, and probably they have got chosen or not chosen with time. Similarly, another hypothesis which has been proposed is a thrifty phenotype. So this states that when there is maternal starvation, which leads on to the selection of particular, say, genes or a development of phenotype in the fetus, which is because of associated and leads to an insulin resistant phenotype, which in turn leads to an increased risk of dyslipidemia, diabetes, non-alcoholic fatty liver disease, and hypertension in the child as he grows. So this is another concept which has been raised, though it has not many takers, but this hypothesis also does explain why we are seeing an increase in risk of non-alcoholic fatty liver disease and more so of type 2 diabetes in the population. Coming to the genetics of non-alcoholic fatty liver disease. So what the liver does, takes up lipids, metabolizes, assembles, excretes out. All these processes which occur are a complex interplay of different organelles within the cells. That includes the ER, Golgi, mitochondria. You heard about all these toxicities in the prior lecture. There are the various steps in this pathway are controlled by the various genes. Among these, the PNPLA3, which encodes for a lipase, its role is mobilize fats out of the liver. So if it's not done, you got more fat in the liver. So a problem in this gene will lead to more accumulation of fat in the liver. Similarly, there are other genes like MBOT7, TM6S2, which have been all associated with the development of fatty liver disease. This is an interesting gene which has been shown to be protective. I think the genetics in NAFLD is still at its infancy. We still need more data. Important translational point which I want to highlight out here is now there are these genes can be targeted. And it's coming. There is some amount of literature to show that siRNAs can be used to target these genes and can influence the outcome of NAFLD in these patients. But we still need more data regarding how this pans out in the future. The role of PNPLA3 first came from the Dallas Heart Study. Its effect was shown to be more prominent in those who had obesity. So with a BMI of above 30, 35, the presence of these genotypes led to higher fat in the liver, higher ALT, and the presence of cirrhosis. This was the data from Caucasians. The data from the Asians suggest that the effect of PNPLA3 probably is more in the lean group, which has a BMI of less than 23, as compared to the overweight and the obese. And the PNPLA3 genotype is more prevalent in the Asians as compared to the Caucasians. That's why it's been implicated that it may play a more important role in the pathogenesis of NAFLD in the Asians. A study close to India, Sri Lanka, again suggests the role of PNPLA3 gene polymorphisms in the development of NAFLD, especially in the lean. There are lots of studies on the various genotype polymorphisms. I'll not go into the detail, but this review summarizes what is the role of each of these. Important to say is that some of these genes have been shown to be protective, some have been shown to be harmful for the development of NAFLD, and these have been correlated with the development of accumulation of fat in the liver, non-alcoholic steatohepatitis, fibrosis, development of HCC, and some have even correlated with mortality. Even these genes have been correlated with alcoholic liver disease, outcomes, HCC, and multiple other issues in the liver. In Indian population, yes, we've got some data to suggest PNPLA3 may be associated with the development of non-alcoholic fatty liver disease in Indians. So apart from genotype, these gene polymorphisms is the role of the gut microbiome. This interesting study from Japan showed that the HLA polymorphism was associated with the development of non-alcoholic fatty liver disease. They went on to look at the gut microbiome in these patients And what they showed is that the Valenciella were increased as compared to the other groups. And this probably was related to this HLA allele, which led the authors to conclude possibly these gene polymorphisms may be correlated with the gut microbiome. But still, again, the gut microbiome is also still in the infancy states in the development of, in its role in the development of non-alcoholic fatty liver disease. Moving on to the gut microbiome. There is data to suggest that individuals with lean non-alcoholic steatohepatitis have threefold lower abundance of Faecalibacterium and Ruminicoccus. And as compared to the overweight and obese NASH, and the obese and overweight NASH have enriched lactobacilli and reduced bifidobacterium, highlighting that gut microbiome may be playing a role in the development of lean non-alcoholic steatohepatitis. Another study, this is from an Asian cohort, showing that the differences in the gut microbiome between those who have lean versus obese, in addition, the metabolites, these all can be combined and probably correlate with more advanced disease state, that is a higher fibrosis in patients with who are particularly non-obese. So we've talked about gut microbiome. What about people have even looked at the hepatic microbiome? Liver biopsies used to look at the microbiome, and these also show that there is a difference in the gut microbiome in the liver tissue itself in the patients who are lean as compared to those who are obese. So in a nutshell, what I have shown you the data is that there is a difference in the adipose tissue in the visceral as compared to the peripheral in patients who got non-lean, or say who got lean non-alcoholic fatty liver disease. There are differences in the anthropometry. There is a higher prevalence of diabetes. There's a higher prevalence of dyslipidemia. There is a difference in the gut microbiome, and there are genetics. So it's a complex interplay of all these things which lead on to a development of non-alcoholic fatty liver disease in this lean population. So the take-home messages include lean NAFLD defined as the presence of NAFLD in subjects with a BMI of less than 25 in Caucasians, less than 23 in Asians. The prevalence is significant, 5 to 26% in Asians as compared to 7 to 20% in the Westerners. A presence of high insulin resistance, diabetes, dyslipidemia, sedentary lifestyle, Western diet predispose a lean individual to develop non-alcoholic fatty liver disease. Though still the exact pathogenesis is not known, possibly multifactorial, and a combination of factors would be involved. These individuals with lean NAFLD may have a full spectrum, what you see of the abnormalities on the liver tissue as seen in an obese NAFLD. So it's not very different. Though we do not know in the long run, how do they do clinically? Do they get more worse outcomes or they have better outcomes? But important to suffice to say that this is not a benign disease. This can progress and individuals will have complications. As it's a slow progressive disease, you see complications after decades. It's not years what we are talking about. And management is healthy lifestyle. Thank you for your patient hearing.
Thank you, Dr. Salimar. Please take your seat here. And the next talk in this session is on geospecific signatures of gut microbiome associated with NAFLD. And the speaker is Bhavatosh Das. I think he doesn't need any introduction to this audience. He's from this institute. He's an associate professor at THSTI, and his major research focus is oriented to understand composition, diversity, and dynamics of human microbiome in health and disease, and role of human gut microbiome in the emergence of antimicrobial resistant bacterial pathogens. So over to Dr. Bhabatosh Das.
This is wonderful. Thank you, sir, for your kind introduction. So first, I would like to really thank the organizing committee and Professor Garg for giving me this opportunity to present our work. So from the morning, we are mainly listening the disease, non-alcoholic fatty liver disease, and we know there are a lot of these factors. So in my talk, I'm just going to focus in one of the most important risk factors that coming, at least from the current literature, play important role in the progression of the non-alcoholic fatty liver disease. So this is the gut microbiome part. But before we start gut microbiome part, as a non-clinician, when we talk the non-alcoholic fatty liver disease, what we mean? So it's the excess amount of fat in the liver. But what does that mean? We exactly need to know what amount of the fat you can consider that this is a fatty liver disease. So when we talk that non-alcoholic fatty liver disease, that the more than 5% of the fats in the hepatic cells, and what types of fat? It's mainly in the form of the triglyceride lipids. Other than the fat, what else we can use to characterize the non-alcoholic fatty liver disease? That is the liver steatosis, the most important phenotypes. In addition, balloon hepatocytes, inflammatory infiltrate, and the fibrosis. So these are the major factors that you can use to categorize non-alcoholic fatty liver disease. And non-alcoholic fatty liver disease is an umbrella. It's not only one disease. You can think that non-alcoholic fatty disease could be the NASH, could be the cirrhosis, and the HCC. And 25% of the people, if it is the NASH, then you can think that within these 25% people, at least 25% of them are NASH, and then 25% of them are the cirrhosis. So this is the way disease progress, and this progression is also quite variable. Sometimes it may take 2 years, or sometimes it may take 8 to 10 years. And the prevalence part, what Dr. Saliman said, that it's present across the globe. And even if you look to the India, and if you look to different parts of the India, everywhere, it's not any specific geography, it's everywhere. It's quite prevalent, although the prevalence is the vary. And this is the major risk factor. So the diet, lifestyle, genetics, and gut microbiome. And I'm just going to talk about the gut microbiome today, and how basically gut microbiome contribute in the progression of the non-alcoholic fatty liver disease. So before we start gut microbiome, just this is the recent work that we published. It is coming in the Progress in Molecular Biology and Translational Science. If you look to the human microbiome, it's not only gut, almost each and every disease, if you look that they are somehow associated with the human microbiomes. We know that the normal microbiomes, when we have, they produce the different functions that play very important role to protect from the disease development, and also play important roles in the normal physiology. But there are metabolites that do also produce by the same microbes that can play important role in the development as well as the progression of the disease. And the gut, particularly the most important, when they produce this metabolite, majorly 3 major functions those gut microbiome contribute in the disease development. One is the metabolic functions. If you took the metabolic functions, particularly the short chain fatty acid, phenolics, dopamine, and tyrosine, other than this metabolic function, they do also play important role by producing some of the molecules that modulate our immune systems. And the third one is the signatory part. So when we are talking the non-alcoholic fatty liver disease, so instead of considering microbiome from the oral microbiota or the skin or the respiratory microbiota, why do we need to consider only the gut microbiota? So if you go to our next slide, that will give the idea what is the relevance of the gut microbiota in the liver diseases. So this is a liver gut axis. And if you think that liver and gut, this is a bidirectional axis. So the metabolites or that basically gut basically absorb from your nutrient, and the metabolites that produced by the gut, they can go to the liver through the portal vein. And the same way, the liver synthesizes molecules, particularly the bile acids, in addition the antimicrobial peptides that can come to the gut. This is the bidirectional interaction, so both are very important. But it's not bidirectional interaction. If you go to the next slide, that the interaction is the multidirectional. You have definitely the portal veins and the binary vein. In addition, when these molecules produced by the gut, it go to the systemic circulation. Same thing from the liver, it also go to the systemic circulation and it can affect the gut. So this is very important interactions. That's why we have selected that we must concentrate more easily to the gut microbiota and how do they contribute. And within the gut microbiota, the major molecules that basically people reported that play important roles in the what called the microbially associated molecular patterns. So there are molecules that produced by the microbes that play very important roles in the metabolisms, that play in the important roles in immunity, also in the signaling systems. And how do exactly this molecule works? So when we are talking the microbial metabolites, molecular pattern, what are those molecules? If you look, the most important molecules that play important role in the LPS, mostly produced by the gram-negative bacteria, peptidoglycan that produced both by the gram-negative as well as your gram-positive bacteria, short-chain fatty acids, ethanol, phenyl acetates, and short-chain allyl proteases. So these are the molecules, they have the cell surface receptors, mainly they interact with the hepatocytes in terms of the metabolism. In addition, the metabolites also play important roles in terms of the copper cells of the liver. So the copper cells and the hepatocytes in the liver are very important to recognize the molecules that produced by the gut and ultimately do the physiology. And there are reports, there are a lot of reports is coming across the globe that the microbiota play important roles, particularly the dysbiotic microbiota in the gut. So these are the microbiota at least reported from the several groups from the European study and from the US also. There are two bacteria, particularly the Coprococcus and Faecalibacterium that belong to the Firmicutes. Their abundance is reduced in the non-alcoholic fatty liver disease patients, but the abundance of the Klebsiella, Streptococcus, and Influenza, their abundance is increased. Once this abundance is increased or the abundance of the bacteria is decreased, they basically ultimately affect the functions of those microbes. And this function, particularly the function that involves in the ethanol productions, detoxification, and oxidative damage, they get increased, and ultimately it affects. But the microbiota is not the unique. If you look across the globe, there are several factors that basically affect the microbial diversity and compositions, including the geography, age, disease, lifestyle, drugs, and alcohol. So if you have done the microbiomes, if you could find a microbiota that present in the European population, obviously that may not be the universal signatures of the non-alcoholic fatty liver disease across the population. Since the microbiota vary depending on the geography, depending on the lifestyle, depending on the types of drugs and alcohol use, for us, we believe that the microbial signature could be also geospecific. So that is the way we have started the microbiome study in the Indian context. So how this microbiota vary, I'm just giving two examples from our labs that we developed. So one, the important roles of ethnicity, the microbial diversity, that we did the gut microbiota, healthy gut microbiota of the Indian and Japanese subjects. If you look that simply the microbiota that present in the gut of the Indian, it's mostly dominated by the Prevotella, whether the microbiota that present in Japanese gut that is mostly populated by the Bacteroidetes. So it's entirely different, even within the Asian country. And in terms of even if you go to the higher taxonomy, you could find that the bacterial species, particularly Prevotella copri, Carcoria, and Prevotella species, they are quite abundant in the Indian context, but not in the Japanese context. Accept some water. So this is the one component of the gut microbiota. People always talk about. So this is the bacterial component, but other than bacterial component, there is a second component that also play important role, that is the fungi. So we also look at the fungal population in the healthy Japanese and healthy Indian, and you could find that like bacteria, the fungal population is also different. So the gut of the Japanese population, particularly the healthy Japanese, this is mostly dominated by the Saccharomyces, whether the gut of the Indian population that is mostly dominated by the Candida species. So if the microbe itself differs between the ethnicity, then how can you have a universal signatures of the microbiota for the same disease? So another one study that we did, not only the healthy subjects, we also did the gut microbiome of the people, those are suffering from the type 2 diabetes. This is a Indo-Danish study where we have analyzed close to 1,000 subjects from both the country. And what we observe that even in the pre-diabetic subject, the microbiota, those are specific to the Indian populations, they are not to the Danish population. You just look that the Indian populations, particularly the lactobacillus and megaspora, this is the signatory bacteria that their abundance is quite increased, while the bacteria that present in the Danish population, the Alestips and the parabacteria. This is also true for the type 2 diabetes. In the type 2 diabetes, what we observe when we analyze the entire microbial population, we could find that some of the bacterial species, they do are common signature both in the Indian and Danish populations, but you do also find the bacterial species that only change in one population, the Danish populations. In the type 2 diabetes, we could not find any bacterial signature in the Indian population specific microbial signatures. So this is the way, so that's why we selected that, okay, we should also go for the gut microbiome study from the Indian population. What we basically asked the question, first thing, whether the multi-omics profiling of the microbiome, particularly in the NAFLD patients, provide a geospecific bacterial and fungal signatures. Second thing, also whether if we analyze more details about the functional content of the microbiota, whether that can give the insight of the disease progressions or the disease development. And if we could find a microbiota, whether it's possible to develop a synthetic microbial community as a live therapeutic agents to at least reduce the rate of progression of the non-alcoholic fatty liver disease. So in my labs mostly work on the human microbiome. We work microbiomes, particularly general microbiota, gut microbiota, stomach microbiota, breast milk microbiota. But today just we are focusing on the gut microbiota of the NFLD populations. So this study we initiated with Dr. Salimar in AIMS. So we had around 10 NAS patients. Those are all biopsy proven. In addition, we have selected 17 patients. Those are obese. And then we have the exactly match control subject. This is it, around 21. And finally, we also compare the healthy one with the other parts of the country. And we did definitely it's by the metagenomic study. The bacterial component we did simply by the amplifying the 16S RNA, and the fungal component we did by the ITS1. So in addition, what we did, once we identified a bacterial signatures, we isolated that specific bacteria, did their individual genome sequence to identify functions that could contribute to the development, and then that specific functions we also validated in the animal models. So the first thing, so once we did the microbiome, what we check the microbial richness. That means what is the total numbers of bacterial OTU you can detect in your healthy subject versus the people suffering in the obesity as well as the NAS. We could find that the total microbial richness, that means the number of bacterial species present in the gut of the NAS population is significantly low compared to the healthy subjects. We also look on the diversity level where we consider not only the richness, but also their distribution pattern. So when you consider the distribution pattern of the abundance and richness, still you could find that the NAS, the diversity index is quite low compared to the healthy as well as the obese one. And what are the most dominant bacteria that we need to identify? Once you know that, okay, the microbiota have more than 500 OTU in the gut, and if you need to know what are the most significant or abundant bacteria, when we analyze individually those bacterial taxa, we could find that the Collinsella, Cubacterium, Streptococcus, Methylobacterium, and Prevotella is most abundant. Out of those, the Collinsella we found, their abundance is significantly increased, or we call this significantly differ compared to the healthy subjects. So you can look that when we analyze Collinsella further to the species level, we could find that the Collinsella aerophaciens and Collinsella buccedorsonsis, those are the two bacterial Collinsella species. Those are significantly, their abundance is significantly increased in the NAS populations. So now we know the diversity is low. We also know the microbial species that present in the NAS population, then how to identify what functions of these Collinsella could contribute in the disease development. For that, what we did, so first we analyze what exactly Collinsella is. So Collinsella, it's the gram-positive bacteria, it's the facultative anaerobes that present almost more than 90% of the human intestine. It's present, but the number is always limited. But it's create problem only once the number get increased. And they play very important role in the metabolism, particularly for the productions of the ethanol, formate, hydrogen, and the short-chain fatty acids. So before we start this study, what we did when we try to understand what are the normal microbiota of the human gut, those are living in the India, we isolated all those abundant bacteria, did their individual genome sequencing. At that time, we also isolated Collinsella because Collinsella is widely present. And when we analyzed the Collinsella, first thing we did the complete genome sequencing. So till now, this is the only complete genome sequencing from any Indian isolates that available in the database. We look more details. So instead of having only the healthy subject, if we could isolate Collinsella from the NASH patient, so the samples we received from Dr. Salimar, we isolated Collinsella from the fecal sample of the NASH populations, confirmed them by the 16S sequencing, and then we first analyze their subsystems. So once we analyze the subsystem, the most important functions, those are linked with the fatty acid metabolism and the inflammations. We mainly consider the fatty acid synthesis and the inflammations. The another important things that also we need to consider, the Collinsella is present across the globes, whether the Collinsella that present in the India, do they have the similar functional repertory with the other Collinsella or not? We did the global analysis that the Collinsella isolated from the multiple country in the different periods of times, and then we analyzed their systemic position and functional repertory. You could find that the Collinsella that isolated from the Indian NASH population, they have a very unique structure. They basically cluster the Pacific, and that is the Collinsella isolated from the India from the healthy subject. So the genomic repertory analysis itself indicate that they might have either lost or acquired some specific function, those are specifically linked to the non-alcoholic fatty liver disease. The one important function that we identified that link with the alcohol production, the Collinsella aeroquations that isolated, particularly from the NASH population, what we observed that they have lost one function that basically reduce the ethanol level in the blood. So if the specific enzymes is not active, then the ethanol level is quite increased. So that might be one possibility, that ethanol level, endogenous ethanol level is also high in the non-alcoholic fatty liver disease. Now to understand whether this Collinsella and the functional repertory is real, what we try to understand whether we can reproduce that thing in the animal model. So what we did, we have taken the animals, fed these animals with normal diet and choline deficient high fat, high fructose diet. And in one cases, we supplemented with the Collinsella and other cases without Collinsella. And first things we look in the steatosis. What we observe that there is no significant difference in terms of the steatosis, liver steatosis, whether you have the Collinsella with normal diet or without diet, they have the similar pattern. So it seems that possibly Collinsella may not be directly involved in the fatty acid biosynthesis of the host. But the second important things, what we observe that the inflammations. So if you give this Collinsella, so their inflammatory parameter is significantly increased. So we measure the TNF kappa beta, TNF alpha, IL-6 and IL-10. In all the cases, you could find that the ones mice that are supplemented with Collinsella that could significantly increase their inflammatory cytokine levels. So this work is mainly done by the IOC. So if this is the inflammation, so we know the microbes that present in the gut, they do have both types of function. If one group of microbes is produce the inflammatory molecules, there are microbes that present in the gut, they also neutralize those inflammation. That's why the homeostasis condition maintained. So we identified a bacteria that from the IBD study with Dr. Gnit Ahuja, their abundance is significantly decreased in the IBD patient. So, and when we analyze the genomes of this bacteria, that is the Collinsella, that is the Faecalibacterium prausnitzii, what we observe that the Collinsella prausnitzii, they do synthesize a specific protein that reduce the inflammation. We try to use this Faecalibacterium prausnitzii to supplement, but Faecalibacterium prausnitzii is extremely sensitive to oxygen. Even 10-second exposure to oxygen kill this bacteria. So we cannot supplement with the Picalibacterium pausniae. So then we try to explore another alternative possibility, whether that specific functions that basically reduce the inflammation, if we could engineer into a probiotic bacteria, and if we can give the same bacteria to this Collinsella with Collinsella, whether they can reduce the inflammations or not. We exactly do this. We take this complete genome of the Picalibacterium and then basically supplemented those Picalibacterium pausniae encoded, microbially encoded anti-inflammatory molecules. And what we observe that if you give this MAM with the E. coli, and after that, if you give the Collinsella, that can substantially reduce the inflammation. So because of the time constant, I have not presented this data, but my student in this IOC is presenting a poster. So if you are interested regarding this data, you can visit and she can very well explore it. So this is the take-home message from this microbiome study till now with the limited number of patients, what we have done, that the patients with the NAS, at least in the Indian context, we observe that they have the significant lower diversity and also the lower richness. Second thing, that the increased abundance of Collinsella patients in the gut of Indian patient is very unique. If you look to the data that presented from the European population, it's mainly the Streptococcus viburnella. Even the people presented a recent study that is the Klebsiella, but we are reporting that the Collinsella is one of the most important contributing microbiota, and this is the endogenous bacteria. It's across present across the world, and Indian, at least 90% of the India, they do have the Collinsella patients. And the Collinsella mediated effect, what we suspect that may not be directly linked with the steatosis. Most possibly, it's through the inflammation that can increase the progression of the NAFL. With that, I'd like to introduce my lab member. So this microbiome work actually initially initiated by the Dr. Nayars, and most of the works for this gut microbiome study of the non-alcoholic fatty liver disease is done by the IOC. IOC is one of my PhD students. And then Shokti and the Agila, they help a lot to analyze the genomic as well as the metagenomic data. And for the sequencing, I really like to thank the Prodipto who has done all the sequencing. This is my collaborator, Dr. Salimar, from where we received the sample and all the clinical inputs. The animal study is majorly help us, Dr. Sanjay Banerjee. In addition, we have Jasbant and Dinesh for the multiomics. And this is my funding support. I really like to acknowledge my national as well as the international funding agency. And thank you for your attention.
I think both the talks were quite stimulating, and there may be a lot of questions in your mind. So both the talks are open for discussion now. Yes, Dr. Anil.
Hello. Hello. Can you hear me, Dr. Das?
Yes, I can hear you.
Excellent presentation. My question is, when you talk of gut microbiome, which has so many variables, diet, personality, alcohol, drugs, smoking, genetics, how do you try to implicate a particular bacteria out of the billions of the bacteria present in the gut to a specific disease pathology? Is it not time that, as a clinician, we should know as a gene signature? It is like an executive health checkup. You know whether this is abnormal lipid or a normal lipid. So far as we do not even know what is a normal microbiota. And then when you take the fecal sample, it is a culmination of everything, starting from the stomach to the duodenum, to the jejunum, to the ileum, to the large bowel. Every single aspect of genomic diversity will have different implications. So just by taking one single fecal sample, how can you just implicate it in the pathogens of a specific disease process when there are so many confounding variables?
So I completely agree that when we study the gut microbiome, one of the major confounding factor that we consider fecal sample actually represent the gut microbiota. But this is absolutely true that fecal samples don't represent properly, but it can represent more than 90% of the microbiota. And that is the only sample could easily be available. Rest of the things, if you want to through the biopsy, it's invasive. It's very difficult to have sample. Even if you have sample from the NASH population, extremely difficult to have sample from the healthy controls. The ethical people will definitely allow you to get your sample for your research purpose. So this is the sample only available. That's why we select the fecal sample. And in terms of the confounding factor, so that's basically depends when you are selecting your subject, what is the filtration criteria you included. So in our inclusion and exclusion criteria, we tried to exclude all the confounding factor. That's why instead of having 368 our subject, only 27 subject we consider for the comparative study. So the confounding factor is not the major issue, but definitely we do not have the exact sample. So when we are talking about the gut microbiota, there are two types of the microbiota present in the gut. So one types of microbes that do not colonize in the gut. They basically colonize with your food particles. Okay, what types of food you are taking based on the colonize. And second types of microbes, they colonize with the mucins. So when you are taking the fecal sample, the bacteria that colonize in the mucin, they're not properly represented. But since we are working with the DNA sample, even the bacteria that present in the mucus, some of the bacteria always die. And those DNA also come to the fecal sample, and if possible, it's not abundance wise, it may not be true, but in terms of the OTU richness, it's true. So if you look that the people when did the colonoscopy and did the microbiome, the total number of OTU is not get exceeded. So total number of OTU is always restricted is close to the 500. Where you are taking the fecal sample, while you are taking the colonoscopy or mucus, or even from the epithelial cells. So exactly, we cannot answer that the numbers that we detected in the fecal sample exactly reflect in the mucus or not. That one of the confounding factor, I completely agree.
And secondly, we do not have a clarity. Do we have good men or bad men? Like a Hindi film, either you are a hero or a villain.
No.
So do you have any set of bacteria which are always bad or always good, or they keep on changing their trend depending on what they eat or what they smoke or what they drink?
One thing I can comment here, there is no good, no bad things in your gut. So good and bad, everything depends on the numbers. We have all the bacteria in the gut. If you could maintain their optimal numbers, they will not create any problem to you. Once this number basically exceed, once you have, that's why we'll call in scientific language the dysbiosis. So dysbiosis is the major issue. If you took the Colinella, 90% of the people do they have Colinella. You do not get any problems when their number is restricted. But if the number get increased, there's another one very interesting study that we did with the Calcutta SLAM population. Even if you go to the SLAM, if you take the gut microbiota, you could find that almost all types of bacterial pathogen, Vibrio cholerae, Salmonella, Shigella, they do also present in the gut, but they do not manifest any disease because their number is always restricted. So whenever talking a bacteria is always good if you keep their number restricted. But if any bacteria, whether it's Faecalibacterium or Colinella, if their number exceeds, it can always create problem because they basically interrupt the homeostasis.
Dr. Ajay Useja.
Thank you. Very nice talk and very impressive work, I would say. Just few thoughts and maybe a question to you. When we talk about the role of gut microbiota in fatty liver disease, there are two kinds of, people look at. One is what you have largely shown is what we call it as the qualitative difference. There are difference in different kind of species and bacteria and all. But there's also a thought of about quantitative difference also. And we did a work on this, I think, a few years back, and we published that we took the duodenal fluid samples, cultured them, and showed that the SIBO, or the small intestinal bacterial overgrowth, was much higher in patients with fatty liver disease. In compared, that was a quantitative difference. So to make the cycle complete, what we did was we looked at their endotoxin levels, then we looked at their livers, took their liver biopsies, look at the TLR receptors there, both the protein and the gene expression. And we showed that the TLR gets upregulated there, which actually causes a downward signaling and, release of various cytokines, and which adds on to the liver injury. So that's the kind of, LPS, TLR and that kind of cycle, and maybe dependent on, as I said, quantitative difference, SIBO, and also maybe on a qualitative difference. The second part is, there's a lot of therapeutics which is happening in this area. People are modulating the gut, by fecal microbiota transplantation, antibiotics. We did a work on probiotic, and that was a dual study again, PGI and AIMS Delhi. And what we showed was a probiotic, high probiotic. That time it was a hypertensive, we call it as a probiotic. It was a VSL, which showed to be effective in not only improving, the metabolic factors, but also in improving the liver histology. So there's a lot of work, happening in that area. So linking your talk with Dr. Shalimar's talk on the lean versus obese, and that's my question to you. We have looked at our lean patients, close to 1,000 published recently, and showed that though there are 10-15% people are lean and they do not have the kind of metabolic dysfunction, so we don't know what really is happening in these patients. Genetics and gut microbiota could also play a role. And we also showed that even the severity may not be different from obese, which is usually the literature says. So my question to you is that for all the work which you have done, did you divide your patients into obese and lean and looked at their gut microbiota differently? And did you find any difference in that?
Yes, that's we proposed with Dr. Salimar. So now actually this is the initial phase of study. If you look, the subject number is only 10. We have not divided the NAS population. Only criteria we included that it should be the biopsy proven NAS. So we should not have any confusion that will NAS. But since we had only 10 numbers of subjects, we have not divided them. But now we propose to the ICMR with Dr. Salimar, with the at least 50 numbers of patients with obesity and 50 numbers of NFLD in the lean phenotypes, and do their microbiome. And this microbiome we divided already into component, not only bacterial component. We did the bacterial component as well as fungal component. And what data is coming that although we ignore, but the fungi population that reside in the gut also play very important role, particularly in terms of the inflammations. So this study actually bit funded already. So we have just initiated, but since the number of subjects, it take a lot of time to get the biopsy proven patient. So we are in the preliminary stage.
Shalimar, I'd like to add because running short of time.
So I think, sir, you made a very important point. So I think we're doing it prospectively. We still are collecting samples. Once it's done, I think we can give the results, but it's going to take some time. So it's already in process.
I think there's one question from that side before I pass it on to, that will be the last one. I have I'm not sure whether, I mean, it's not necessary to respond to that. I'm just doing a loud thinking. See, what we have all listened since morning, that the disease has a high prevalence, and as a clinician, we can vouch for that, that the incidence of the amount of NASH patient that we are seeing is risen disproportionately. People claim that, yes, it's a same epidemiology as you see in diabetes. Now, all the factors that we have counted since morning, like obesity, diabetes, and now we're talking about microbiota or a genetic, they have not shown much epidemiological shift over the last 2 or 3 decades. There may be variable factors, maybe the diets have changed, but we also see that the younger generation is more conscious about the exercise and so on than we were. I mean, that's my observation. I can be. So my question here that comes to mind, that what is that variable which is shifting onto this, changing the epidemiology? Are we dealing with what Dr. Arora showed, is that some sort of an inflammatory factor which is pushing tilting the balance towards and causing a like epidemic proportion of this? I've just raised this thought process. I'm sure it's in their mind, but if somebody wants to respond, it's okay. But I think before that.
Very nice. Just when you, after the clinical data, when you went to the mice experiment, why you went only with the one bacteria? Because one bacteria is not going to do such a and the inflammation what you are showing in the liver, that might be because of any other bacteria, because you have not used any other bacteria as a control.
right? So in the mice experiment, I don't think it is going to work with a single bacteria. And the second point is, yeah, this is the main point, and I can talk later.
So selecting the Collinsella, we analyze all these bacteria. Okay, when we analyze the healthy versus obese and NAS population, we could identify there are 4 bacteria. Their abundance is significantly increased. Okay, then we try to identify what could be the most potential function. So we identify a potential function in the Collinsella aeropatients that directly link with the ethanol production. And we know that ethanol production is one of the important criteria in the gut permeability and the inflammation. That's why we try to understand that. Okay. That could be another option, definitely. We can ask.
Dr. Shinjini Bhatnagar, you have a question. That's the last question.
Can you hear me? Okay. That was an excellent presentation. See, this is the question. I mean, I don't have answers. Are we actually getting to the problem too late? Because what we are seeing in our pregnancy cohort and what is available now to some extent is that the way the mothers are putting on weight, first preconception, the BMI at the time they conceive, and then when they go across pregnancy, go through pregnancy, the BMIs itself are influencing fetal growth patterns as well as the birth outcomes. So if you look at the Dohard hypothesis, that is basically you don't feed these, it's the same thing that you said, the IUDRs are more prone to this, but this is actually beginning much earlier. So I think the answer too is that we're doing too much cross-sectional evaluation of the disease. What we really need is cohorts which will pick up associations, but at least there'll be associations with a lot of power. And coming to your question, Anil, when you're saying as an executive, as a clinician, you want to know an answer, that can only come from cause-effect studies. You cannot have associations giving you that answer. And mostly a lot of this is associations.
I would completely agree with you, ma'am, that we need more longitudinal studies, and your cohort definitely would give much more answers, because what data we have is just as cross-sectional. Cross-sectionals have their own issues and limitations. Yeah, we've got something more in the literature also. It's there, like all these TRP3 genotype, phenotype. There are other multiple hypotheses, but they have their own positives and negatives. So it's not that that hypothesis per se explains everything, but these are concepts which need still more clarity.
So we know that there are many unanswered questions, and this field will keep on evolving over a period of time. So with that, I will thank both the speakers for excellent presentation, audience for participating in the discussion, and my co-chair, Dr. Ajay Kumar. Thank you all.
I request Dr. Das to please stay back on the stage for the felicitation. We request our session chairs to kindly felicitate Dr. Shalimar and Dr. Das. Thank you, everyone. We now request Professor Shinjini Bhatnagar to kindly come up on the stage and felicitate the session chairs, Dr. Ajay Kumar and Dr. Anup Sarai. Thank you, ma'am. We now break for the lunch. Let us all assemble back by 1:35 p.m. Volunteers are requested to escort all our session chairs and speakers. Participants for the poster presentation are requested to quickly have their lunch and reach near their poster boards. Thank you. We request Dr. Yogesh Chawla, Dr. Anil Arora, and Dr. Madhu Dixit to kindly chair the session. We invite Dr. Chawla and Dr. Anil Arora to kindly come up on the stage. Dr. Dixit is joining us online. It is an honor to have Dr. Yogesh Chawla with us here today. Dr. Chawla is the recipient of the prestigious Padma Shri Award. He is the former director and emeritus professor at PGMR, Chandigarh. With an experience of more than 39 years, his expertise lies in hepatology and gastroenterology. From starting a successful organ donation program to establishing the first liver intensive care unit in a government hospital, Dr. Chawla has made a significant contribution in the healthcare sector. Sir, it's an absolute delight to have you here with us. Dr. Anil Arora is the chairman of the Department of Gastroenterology at Gangaram Hospital, New Delhi. He is an astute clinician and researcher. He has special interest in MAFL. Thank you, sir. It's an honor to have you here with us. Our third chair, Dr. Madhu Dixit, is a former director, Central Drug Research Institute, Lucknow, and a former national chair, THSTI. Dr. Dixit has made significant contributions to the general area of molecular pharmacology with special emphasis on redox biology and metabolism. Her interest is in the role of Ayurvedic medicine in NAFLD. Thank you, ma'am. It's an honor to have you here. We request our audience to kindly reserve their questions until the third talk is completed. We now invite our first speaker, Dr. Ajay Duseja, to please come up on the stage. We request Dr. Anil Arora to kindly introduce Dr. Duseja to the audience.
Thank you, ma'am. At the outset, I'm extremely grateful to Professor Pramod Garg for having given us this opportunity of seeing the sprawling bungalow of THSTI. I hope we have more frequent interaction with the basic scientists here. The next speaker is none other than the NAFLD man of India, the Iron Man of hepatology in India, Professor Ajay Duseja, who is also incidentally the Secretary General of Indian National Association of Study of the Liver Disease, one of the most celebrated researchers in hepatology. He is presently almost going to head the Department of Hepatology at prestigious PGI Chandigarh. His area of interest has been in almost all aspects of liver disease, with special interest in fatty liver disease, in which he is a pioneer. I'm also pleased to inform you that he has been on most of the international societies which tend to form Asia-specific guidelines in trying to define and redefine the definition of obesity, as well as the BMI, which is specific, geo-specific to Indian region. He has more than 300 publications to his credit and at least 25 chapters in the hepatology books. So I have a pleasure and honor of inviting Dr. Ajay Duseja for his talk.
Thank you, Professor Arora, for those kind words. And at the outset, my sincere thanks to the Institute, Thirsty, Professor Garg, the director, the organizing team, Professor Mahajan, Dr. Saraswati, Dr. Ruchi Tandon, and everybody in the organizing committee for giving me this opportunity to be, part of this, I would say, a very wonderful and an educative symposium on fatty liver disease. Can I have my slides, please? Yes. So I've been asked to, cover the aspects on the current and the future pharmacological treatment of fatty liver disease. And I'll try to finish maybe in around 20 minutes or so. I don't know whether it was discussed in the morning because I missed a part of the morning sessions, but then I saw on the Twitter and everywhere the name of the symposium written was MAFLD, or Metabolic Associated Fatty Liver Disease. The better term, they call it as Metabolic Dysfunction Associated Fatty Liver Disease. But let me just give you a message here that there's still an ongoing debate between NAFLD and MAFLD Most of the patients with fatty liver disease would have associated metabolic dysfunction. That's why there's a suggestion that this should be renamed as MEFR. But as I said, there's an ongoing debate, but all patients of fatty liver disease will not have metabolic dysfunction, and there are lots of other issues. So a lot of rebuttal has happened on this, change in nomenclature, including from our group and the international group. And to tell you the truth, the EASL, the European Association of Study of Liver, and ASLD, the American Association for Study of Liver Disease, they are meeting on 8th and 9th of July next month to sort this out. Until this is sorted out, I think we should stick to NAFLD or non-alcoholic fatty liver disease, and that's what I'm going to do in my presentation as well. So when we talk about, the treatment of fatty liver disease, we do understand that this is a lifestyle disease. As I said, most patients would have associated metabolic risk factors, and the most common risk factor we know is nothing but overweight or obesity, followed by maybe diabetes, hypertension, dyslipidemia. But then 15-20% of the patients are without these metabolic risk factors, even without obesity. And you heard in the morning, we call them as lean NAFLD. So irrespective whether it's a lean NAFLD with metabolic dysfunction, without metabolic dysfunction, the crux in this situation, is always the pathogenesis, which is thought to be is the insulin resistance. So the aim is, to control these metabolic risk factors, improve the insulin sensitivity, and then drugs have a very, very specific role in this particular disease. So even if I'm talking of, pharmacological treatment, mind it, there is no shortcut to lifestyle interventions in patients with fatty liver disease. The lifestyle interventions have to improve, and you have to take care of, all the metabolic risk factors, whether you're overweight or obese, diabetes, hypertension, dyslipidemia. And even if you're not there, we always recommend a kind of physical exercise, even in those with metabolic risk factors, because exercise, even without weight reduction, has been shown to improve insulin sensitivity, and which I said is the crux in this particular situation. So I think, as I said, I will not elaborate on this because it's a topic by itself. But as I said, the message I would like to give is that there is no shortcut. Whatever stage of disease or fatty liver disease you have, I think you have to control these metabolic risk factors and exercise for everyone, irrespective of the metabolic risk factors. Now, if that is the kind of standard of care, then why pharmacotherapy? The first question is why pharmacotherapy, which we're discussing today. The pharmacotherapy is that the largest studies, on lifestyle interventions which are available, especially on weight reduction, have come from the Spanish group. And they have shown that if you lose around 5% of body weight by lifestyle interventions, your liver fat improves. Your inflammation can improve if you lose, say, 5 to 7% of body weight. And if you lose 7 to 10% of body weight, you can even improve hepatic fibrosis. So if that is the case, and the question I'm again asking is why pharmacotherapy? The problem is that kind of weight reduction, I'm quoting the same study, the 5% weight reduction in that particular study was shown to be achieved only in 30%. And 10% weight reduction was shown to be achieved only in 10%. So the question is, it is not really achievable by lifestyle interventions. And even if you achieve it, you're not able to sustain it because people tend to regain weight, and that's known as, weight recidivism. Something like we call it as an alcohol recidivism in some time. So you can have that. So people may not be motivated, may not be able to achieve the target. They may not be able to exercise. Somebody has osteoarthritis, has cardiac issues. He cannot do those aerobic exercises which are normally recommended, or even anaerobic exercises are now recommended for improvement in fatty liver disease. So they may not be able to do that. So that could be another problem. And then if you've already reached a stage of NASH, what we call, which is a severe form of fatty liver disease, or if you already have significant fibrosis or advanced fibrosis, you would definitely need the help of drugs in addition to lifestyle intervention. So that's why there's role of pharmacotherapy. Now, the next question is, who needs pharmacotherapy? Everybody, as I said, will not pharmacotherapy. Every patient of fatty liver disease, you have to categorize. All patients with fatty liver disease are not same. You can just have fat in the liver. I'm sure you must have heard it in the morning, which is known as only NFL, or you can have inflammation with or without fibrosis called NASH. Then you can progress on to significant fibrosis, advanced fibrosis, cirrhosis, and even liver cancer. So everybody doesn't need pharmacotherapy. So to cut it short, if you're only fat in the liver with or without minimal inflammation, not amounting to NASH, or not amounting to significant fibrosis or advanced fibrosis, you do not need pharmacological interventions, because there alone exercise and lifestyle interventions may be good enough. But if the patient has already progressed on to NASH with F2 or more fibrosis, what we call significant fibrosis, there I think you need to take the help of pharmacotherapy in addition to lifestyle interventions. So mind it, today what I'm talking of non-cirrhotic fatty liver disease. We are not touching the NASH cirrhosis and NASH HCC, which is, again, as I said, a topic by itself. And there, the kind of interventions which are required may be entirely different. The pharmacological interventions may be entirely different, so we will not be touching. So we're talking today only of non-cirrhotic NAFLD. So now when we say that you must have significant fibrosis, you must have NASH, only then you can use drugs. So what is the quantum, or what is the kind of magnitude of this kind of fatty liver disease in this country? Again, to give you a snapshot on this, we have a consortium in India called Indian Consortium on NAFLD. We call it as ICON-D, and we have 44 centers in the country who actively participate in contributing an online, kind of a registry data, which we do for fatty liver disease. And till date, and this is a three-year-old, kind of consortium, and till date, we have collected close to around 6,500 patients' data. So this is our interim analysis, which we published, this year. And this was, was a data close to around 4,000 patients. We wanted to look at, the severity of fatty liver disease in this country, which, 10 years back or 20 years back, we always thought that the fatty liver disease in this country is kind of benign, is not very severe, doesn't have significant fibrosis, doesn't have NASH. But to our surprise, when we looked at our data with non-invasive assessment and even with liver histology, what we found that around 20% of our patients, those are presenting to the hepatologists as incidental fatty liver or incidental rise in transaminases, they already had, significant fibrosis as assessed by, APRI, FIF4, these are all, kind of non-invasive markers for the assessment of hepatic fibrosis. We also did transient elastography, so-called FibroScan, in around 3,000 of our patients, and more than 8 kilopascal, which is the definition, for the significant fibrosis, was seen in around 30%. And cirrhosis, which was defined as more than 13, was seen in 10%. So can you imagine 10% of the patients with fatty liver disease do not know, just have incidental detection of fatty liver, coming to liver clinic and is found to have cirrhosis. It's a huge quantum. When you look at, you must have heard the figures in the morning of, the magnitude of fatty liver disease in this country and in globally, 25 to 50% in India. And the meta-analysis done by Dr. Shalimar shows 40% of Indian population has fatty liver. And out of that 40%, even if 10% have cirrhosis, I think that's a huge number. So I think we probably need, I think, as I said, we need, not only lifestyle interventions, but yes, there's a role of, drugs which needs to be done. Now, coming to the drugs, which I said, first I'll cover the current pharmacological treatment, and then I will go briefly on to the future pharmacological treatment, which is the topic for me today. So current pharmacological treatment, I think, again, to give you the message, if you ask me any particular drug which is approved by, say, FDA, Food and Drug Authority in the US, or by EMA, the European Medical Association, the answer is no. No single drug has been approved by FDA or EMA for use in patients with fatty liver disease till date. But we in India are lucky, and Dr. Jain is here. I think you're going to hear about saroglitazar, the next talk. So saroglitazar is the only molecule in the world, or in the globe, I would say, where India is the only country where we have, the regulatory approval by the DCGI of usage of saroglitazar in patients with fatty liver disease with F1 to F3 fibrosis. Again, I'm saying it is not F4, not non-cirrhotics we are talking here. So I think, so that's the only drug. So why how these, but then when we say that none of the drugs is approved by FDA and EMA, there are, scientific societies, including EASL, which I said, ASLD, INASL, the Indian National Association. These societies, based on the data, do recommend certain kind of drugs. So out of that, as I said, vitamin E and pioglitazone are two drugs which are routinely recommended by these institutes. And then, as I said, we have the saroglitazar. So now what is the data? Why, how are these, drugs kind of recommended? So data is based on a lot of clinical trials. I think as postgraduates, if you need to know, I think, this was one of the landmark studies, so-called the PIVENS trial by Dr. Arun Sarnyal's group, where they did a randomized controlled trial between placebo, pioglitazone, and vitamin E, and showed that both vitamin E and pioglitazone were better than, placebo in improving the NASH. But then none of these drugs, two drugs, were found to be effective in improving the hepatic fibrosis. Thereafter, there have been large number of studies. The time doesn't permit me to get into the details, but this is the meta-analysis which I picked up. And, we have large number of studies where vitamin E has been shown to be effective in patients with NASH. Predominantly, even in the PIVENS trial and the other studies, the predominantly on vitamin E, the data on vitamin E is in non-diabetic patients. We do have some data in diabetic patients also, but majority of the data is in non-diabetic patients. Hence, the approval by EASL, ASLD, and INASL for vitamin E is patients with NASH, preferably biopsy proven, which we are now trying to change in the nasal recommendation, that even in non-invasive assessment, if somebody is found to have, say, predicted to have NASH or predicted to have, high fibrosis, you can take the help of these drugs. But then, as I said, vitamin E predominantly for non-diabetic patients. About pioglitazone, there are certain issues, because this drug is not free of side effects. I'll show you some maybe data on that. But again, large number of studies on this glitazones, what we call drugs which are available. Again, the initial PIVENS trial was in non-diabetic patients. But thereafter, for glitazone, we have large number of studies where glitazones have been shown to be effective in patients with NASH, both in diabetic and non-diabetic patient. So most of the societies would recommend pioglitazone as a drug both in diabetic and non-diabetic. Vitamin E, only non-diabetic. Pioglitazone, both diabetic and non-diabetic. This drug, I'm sure, will be spoken in detail by Dr. Jain after this. This is the drug, saroglitazar, which I said is, approved by DCGI in India. This is a PPAR agonist. PPAR are, the proliferator activated, receptors, peroxisome proliferator activated receptors. There are different kinds. Alpha, you have beta or delta, and you have gamma. So there are individual drugs. So pioglitazone is a PPAR gamma agonist. And the prototype for PPAR alpha are the fibrates. You must have heard clofebrate, fenofibrate. These are the drugs, which are PPAR alpha. So there is data on PPAR alpha. I showed you data on PPAR gamma, which is pioglitazone. Then came, the era of what they call the dual PPAR agonist. Dual means alpha delta, alpha gamma. So saroglitazar is an alpha gamma dual. Now you also have a data I'll show you on pan PPAR, agonist. So, these people are trying to, and these drugs, these are the nuclear receptors, and these are very importantly involved in the glucose and the lipid metabolism, and have been shown to have anti-inflammatory and anti-fibrotic drugs. So that's why, initial data on Saro, came for usage in patients with diabetic dyslipidemia. This was approved for that indication. And during that time, they found that it is causing improvement in liver enzymes. And then the studies on fatty liver disease happened. And I'm just showing you maybe two studies. One is this Evidence is 4 study, which was done in US, phase 2 study, small group of patients, 25 patients in each arm, 1 milligram, 2 milligram, and 4 milligram, and compared with placebo. And they looked at the improvement in hepatic fat as seen on MR-PDFF, the MR, to look at the liver fat, and also looked at other things like ALT, hepatic, the insulin resistance, and dyslipidemia, and they found it to be useful or better than the placebo. And then was this study, which was done in India, which was a multi-center study of around 100 patients, biopsy proven 10-center data, and then the saroglitazar was given in 2:1 ratio. And again, look at this data, the improvement in NAFLD activity score, which we commonly use in assessing the liver histology in patients with fatty liver disease, was more than double in saroglitazar arm, 52% versus 23%. And because of, and then there's a lot of real life data and more data, experimental data, animal data, which I said Dr. Jan will show you. Based on all this, saroglitazar was approved. Now coming to, before I go into, a few minutes on the future pharmacotherapy, I think why are we, still struggling for these drugs? What are the issues with current drugs? So the answer is, again, there are many issues. The pioglitazone is a drug which actually is not free of side effects. And to tell you the truth, in clinical practice, we hardly use pioglitazone. Because it has been associated with pedal edema, weight gain, which can be, counterproductive. In fatty liver disease, you're trying to lose weight. So this drug is causing weight gain. So this could be sometimes, counterproductive. It is also not free of, sometimes it can have cardiac, effects, can be associated with carcinoma, urinary bladder, bone loss, so many issues. So that's why it's not really, very frequently used. Vitamin E, again, can have issues with CA prostate, especially in elderly men, associated with hemorrhagic stroke. There was even data which showed that it increases the all-time kind of mortality, but then thereafter there were studies which refuted that. And then we don't know about this, whether it really improves hepatic fibrosis, which I said. Same is the story with pioglitazone. The problem with SARO is, even though it is approved, we do not still have any peer-reviewed publication. The data which I showed you, except the phase 2 data, the US data has now been published in hepatology as full paper, but phase 3 data and the larger human data, which, which was done in India, is still, under publication. It has not been published. And still we do not know its effect on hepatic fibrosis. Even though it is recommended for F1 to F3 fibrosis, but it's really, what the data which showed was NAFLD activity score improvement. NAFLD activity score takes into account fat, lobular inflammation, and ballooning. It doesn't talk about fibrosis. And the paper or the abstract was silent about its effect on fibrosis. So I think we probably need more data on this. So that is the reason, people are targeting various, kinds of, targets in fatty liver disease, which are involved in pathogenesis. And I saw some beautiful posters now where people have working on, say, ASK1 inhibitors, gut microbiota, and all these things, people. But in nutshell, the target, and there's so many, trials which are going on, so it's maybe difficult for me to cover everything. But people are predominantly targeting, the metabolic pathways, the inflammatory pathways, so the anti-inflammatory drugs, and the fibrotic pathways with anti-fibrotic drugs. But the problem is that, the testing these drugs in patients with fatty liver disease in general, or in particular any other, disease also, is a long drawn process, and it's a difficult process. It has to go from phase 1 to phase 2A, 2B, 3A, 3B, post-marketing, all those kind requires a lot of time. And the other problem with fatty liver disease is that most of the clinical trials would ask for what they call the histological improvement, which means that there has to be improvement in the histological NASH, with or without, improvement in fibrosis, or improvement in hepatic fibrosis, with or without, improvement in NASH. So that kind of, process will take very, very long. So I think that's why there's a problem which is happening with the approval of drugs. But the new trials are now working on the usage of, NITs, or non-invasive, markers or biomarkers, or non-invasive tests are coming in, where people are now looking at that as a utility of, in these clinical trials. So I'll briefly tell you maybe the names and maybe how they work on this, and what's happening in the future pharmacotherapy of NASH. So there are a lot of drugs in phase 2. I can't show you data on all, but maybe you can just remember one or two names. Lanifibranor is a very promising drug, and a recent study has been published at NEJM, which is a pan-PPAR agonist. Pan-PPAR means alpha, delta, and a gamma agonist. SARO, I told you, is a dual PPAR, alpha and gamma, right? And there's a, pamafibrate is another alpha, but this is a, a different form of alpha. So this is another data which is coming in. Whenever, the drugs are being tested, as I said initially, they go to phase 2. And if they are found to be useful in phase 2, then they will go to phase 3. So there were some drugs which were actually found to be very effective in phase 2 studies. And one of them was elafibranor, which was a PPAR alpha delta agonist. But when it went to phase 3, it failed, right? Similarly, selonsertib, I saw some posters on ASK1 inhibitors. So we were asking that guy, that, are you aware of these trials? These trials were known as Stellar trials, Stellar 3, Stellar 4, where, the selonsertib is an ASK1 inhibitor. ASK1 is the apoptosis signal kinase inhibitor. Apoptosis is involved in the pathogenesis of fatty liver disease. So these drugs again were found to be useful in phase 2, but when these Stellar 3 and 4, which were large phase 3 trials which happened, they failed. Same was the story with, Sinicriviroc. Sinicriviroc is a chemokine 2 and 5 inhibitor. Again, it was found to be useful in phase 2, but when the SEN2 trial happened, which was a large, phase 3 study, it again failed. So you can have, a success in phase 2, but can fail in phase 3. So that's, is a problem which can happen. But then I'll show you some data which have had success both in phase 2 and phase 3 also. So there are some ongoing clinical trials. Maybe I'll briefly touch on this: Resmetirom, Aramcol, and semaglutide. And there's one success story which has happened where it was shown to be, useful in phase 2, and the interim analysis of phase 3 is also kind of effective, is this molecule called obeticholic acid, which is an FXR agonist. FXR, the farnesoid X receptors, which are so importantly involved in the bile acid metabolism. These are intestinal receptors, but they're also involved in, in the insulin, in the glucose and in the lipid metabolism. And then there's a lot of combination of drugs which is happening. So as I said, this is a study which I think probably you should be knowing. Lanifibranor is published last year in NEJM, and this is a pan-PAR agonist. And in comparison to placebo, when they looked at this, is, again, as NAFLD researcher, you should know the histological, the evaluations which is done, which one we said is the NAS, or the NAFLD activity score. There's another score which is known as SAF. SAF is steatosis, activity, and fibrosis score given by the French group. So this particular study, used the SAF score, and they found that the lanifibranor was effective. So this was a phase 2 data, but then, as I said, I think we would await the results of, the phase 3 data. So now coming to the ongoing phase 3 clinical trial, Resmetirom. Now, what is Resmetirom? Resmetirom is a, thyroid hormone receptor beta agonist. So what are these thyroid hormone receptor, which are there? Thyroid, this, if you know about the clinical story, there's more prevalence of fatty liver disease in patients, those who have clinical or subclinical hypothyroidism. There's also a concept of what is known as hepatic hypothyroidism and fatty liver disease. The people have shown that. But the question is, if you start using this systemic thyroxine in these patients to improve that subclinical, hypothyroidism, you are going to have the systemic side effects or the general side effects also. So this thyroid hormone receptor beta agonist, and there are receptors in the liver, this drug Resmetirom has a liver specific, action. It doesn't have, these actions all over the body. So you will not get those side effects. So this was, a phase 2 study where they used, Resmetirom in comparison to placebo, and they thought shown on MRPDFF again that there's a reduction in, fat in these patients. So this particular drug, which is from the company called Madrigal, is now undergoing a phase 3 study, and this is known as a Mastro-NASH trial, where they're looking at, this molecule Resmetirom in a very large number of patients, and the results of this phase 3 will decide whether the results which were shown in phase 2 are actually, being replicated in phase 3 or not. The other drug which I said is the Aramcol, which is again going in phase 3 studies. So what is Aramcol? If you look at the, synthesis of, triglycerides or fatty acids, if you look at this, various kinds of, these enzymes are involved. From acetyl-CoA to melancholy-CoA, acetyl carboxylase is involved, and this is known as ACC. And there are no drugs which are known as ACC inhibitors. So maybe I'll not show you data on that. But when this palmitate to melancholy is formed, this is a molecule, this enzyme called SCD1 is involved. What is SCD1? Is steroyl coenzyme desaturase 1. So, just to inhibit this molecule Aramcol is a compound which will inhibit this SCD1 enzyme. And that's why in phase 2, studies, this was found to be again useful. And now this company called GalMAD is conducting this large, RMOR study, which is a phase 3 study looking at the utility of Aramcol in patients with fatty liver disease. The last but not the least is, the phase 3 which is going on is the GLP-1 agonist. So what are GLP-1? The glucagon-like peptide 1, you all understand glucagon-like peptide are the hormones which are secreted from the L cells of the intestine, and they are very important in improving your lipid and glucose metabolism. They will increase the insulin level, they will decrease the glucose level, they will increase the satiety, they will delay the gastric emptying time, thereby trying to improve in general the glucose and the lipid metabolism. But the problem is the naturally acting GLP-1 hormone has a very short half-life. So that's why the synthetic GLP-1 agonists are being formed, and the initial molecule was called the liraglutide, and the trial which happened with liraglutide in NASH was known as the LEAN trial, and it was found to be very effective. But the company is now Novo Nordisk is basically working on this molecule called semaglutide, and this was the phase 2 data which was published in NEGM 2 years back and was found to be effective in improving the liver histology around 59% versus maybe 17%. But then now the company is conducting a trial, phase 3, which is known as the Ascens trial, which is going on globally. And we happily are part of all these ongoing clinical trials, which is going on. And I think the results of this will decide the fate of this very important molecule. This has been shown to not only reduce weight, anti-inflammatory, but then again, I think it didn't have a good antifibrotic action. The last molecule, which I said, which has shown some promise, is the farnesoid X receptor, which is the obeticholic acid. And the phase 2 study was known as the Flint trial, which was published in Lancet in 2015. But the interim analysis of this molecule, which is a regenerate trial, was published in Lancet. And this where they compared this OCA or obeticholic acid of 25 milligram with 10 milligram and with placebo. And what they found in this interim analysis was that both on per protocol and intention to treat analysis, this was found to be superior than placebo in improving the hepatic fibrosis, though they did not find it to be, in this particular analysis to be better than placebo in improving the inflammation or steatohepatitis. But then when they did the, larger analysis, they found that yes, it was effective even in improving the steatohepatitis. So then, they also found that this drug was improving, the biochemistry and the lipids and everything. But the problem with the farnesoid X receptor as a class of drugs is that its side effect. It's a bile acid. So it produces a lot of pruritus in these patients. It also causes dyslipidemia. The LDL levels goes up, HDL comes down. So that's the problem. So there are a lot of, trials which are happening, and a lot of people are now combining the drugs, this one study, which is again going on multi-center, we're part of this, licogliflozin and propifexor, so-called the Elevate study. Licogliflozin are, some kind of, SGLT2 inhibitors, and propifexor is again an FXR agonist. So a lot of trials, going on, which I said on ACC inhibitor also, as a combination where people are trying to target, multiple targets. I think if you know about this molecule, this study is published, last week at NEGM. The tirzepatide is a once weekly, molecule. This is again a combination of GLP-1 and GIP-1 agonist. And it was found to be, so useful in improving the obesity in patients. And I'm pretty sure, I think tomorrow we are going to have a clinical trial on this molecule in patients with NASH as well. So having said that, let me start from where I started. There is no shortcut to lifestyle. All these drugs, which I remember, are good to talk, it's fine. Sometimes even difficult to remember their names and the pathogen, where they act and how they act and all the clinical trials. But then there's no shortcut to lifestyle, which I said. And the important thing, and a very important thing, which has happened in this country, India has taken lead in, some of the issues in regarding fatty liver disease. And I said saroglitazar was the first molecule approved in India. But the other lead where India has taken is integration of fatty liver disease into this national program. There are so many national programs in this country, the malaria control program, the tuberculosis control program. So this is a national program, which is the NPCDCS, and this is the National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Disease, and Stroke, which is already going on. And with the efforts of some of the mentors and some of the senior people, I think this program the NAFLD has now been included in this national program in this country. And I'm pretty sure this will get a lot of boost in this country. control of fatty liver disease at the community level, at the level of the society, patients, everything. And I think probably we should be able to control this ongoing modern pandemic. So ladies and gentlemen, let me summarize with what I said in last few minutes is that there's no shortcut, as I said, to control of these metabolic risk factors. If somebody has, it's a lifestyle disease. We cannot get away. Even if you're applying drugs or giving drugs to these patients, the lifestyle interventions have to continue with those drugs. There's no shortcut to that. Yes, if you want to use drugs, where to use, what drugs to use, I've spoken about that. And if you want to choose that, ideally, they have to be in biopsy-proven NASH. But yes, as I said, even if there's no biopsy-proven NASH, in some individuals where you think that they have significant fibrosis or inflammation, you can use them even on non-invasive testing also. The drugs recommended are 3, vitamin E, pioglitazone, which I said we don't use much often, and saroglitazar. These are the basket of the current drugs. When we talk of the future drugs, a lot of clinical trials, as I said, some drugs have failed. If you just want to remember the names, the elafibranor, selonsertib, siniclivroc. Some drugs are undergoing phase 3 clinical trials, and the 3 drugs which you need to remember, resmetirom, Ramcol, and semaglutide. But the drug which has been found to be effective both in phase 2 and phase 3 is this drug called obeticholic acid, which is an FXR agonist. As I said, large number of phase 2 trials are going on. The promising looks like lanifibranor, which is a pan-PPAR agonist. And the people are now working on different kind of combinations and Atlas trial and various trials. So, and if you're more interested in liver disease, fatty liver disease, or in general liver disease, this is my open invitation to all of you to join us for our national meeting, the annual conference of the Indian National Association for Study of Liver, which is happening in the month of August in Delhi at Andaz House. This thing, unfortunately, I don't know whether the information reached here. We already closed for the abstract submission. 15 June was the last date for submission of abstracts, but you can still join us and I think have the hepatology academic feast, I would say. So thank you very much for your kind attention. Thank you.
Thank you, Ajay, for a masterly presentation as always. Can you join us on the dais? I think we may have one more chair. I think question answers will be at the end of the 2 more talks.
After that wonderful talk, I just want to say thanks to Prabodh for getting me involved, he and his team. The next speaker is Dr. Mukul Jain. And my hat's off to him because saroglitazar is one of the most promising drugs. And whenever we fail the therapy in patients with NASH, saroglitazar always comes into our rescue. So Dr. Mukul Jain is a president at the Zydus Research Center, Ahmedabad, and is responsible for the new drug discovery and development. He has been the key person responsible for discovery and development of saroglitazar and desidustat. Both of these drugs have come from an Indian pharmaceutical company and has got approved for use in human patients. This is highly creditable, sir. Dr. Jain has over 31 years of professional experience and has more than 170 publications. Welcome, Dr. Jain, for your talk on saroglitazar.
Don't matter to change slide, and this is
Thank you very much for introducing me. Thank you, Dr. Ajay, for talking about saroglitazar already. So everybody's introduced about the molecule. Thanks to THISTI for organizing this important symposium on a topic which is very important for our country, not only our country, but also I think the entire world is suffering from this disease spreading probably much more than COVID. So it should get more attention, in my opinion. I think you're doing the right thing by organizing this event. So today I will obviously talk about saroglitazar, particularly about its profile in NAFLD and NASH. When we started working on this program that's developing a PPAR agonist, the NAFLD NASH was not in the horizon. It was probably there, but we were not really aware of the importance at that time. I'm talking about early, I think in around 2000. So we were focusing on developing saroglitazar for treating diabetes and dyslipidemia, and primarily for dyslipidemia with additional benefits in diabetes. But then later on, we found that it has an interesting profile in liver disease. So today I'll talk more about the NAFLD NASH. So 2013, with our effort, it got launched as Lipaglyn. It was really a proud moment for us as a pharma company. It was the first from an Indian pharma company that came up and designed, developed, discovered, developed by us, and really great thing for us. As you already heard, it's a dual PPAR alpha gamma agonist with predominant alpha effect. And when it got approved, I think it was the first glitazar class drug approved anywhere in the world, and first-in-class drug to treat diabetic dyslipidemia. I mean, you have drugs approved for treating dyslipidemia, you have drugs approved for treating diabetes. I think we were lucky that when we got approval, it was for an indication that's diabetic dyslipidemia. So it's a subclass, but also hypertriglyceridemia, because it was a primarily working on lipids. Eventually, it got also approved as a treatment of type 2 diabetes. So it got 3 approval in the diabetes-related disease. With the novel mechanism, novel means combining the 2 alpha and gamma receptor with a differentiated profile and non-renal route of elimination, which was an advantage for us because most of the patients we were treating was diabetics and who have some kidney dysfunction. Interestingly, it was very safe on cardiovascular system, liver, kidney, and no muscle toxicity. So all the profile looked very interesting for exploring further. And most importantly, there was no edema, weight gain observed, unlike the glitazones which were in the market those days, pioglitazone and also rosiglitazone. As you heard, I think there are 3 different PPAR receptors, and they have different distribution in the body, different organs, and they are alpha, beta, gamma are same, beta, delta are same, and then you have gamma. And in different receptor, they do different organs, they do different things. If you see in this cartoon, there are a lot of effects or role in the liver, and I think liver is the main playground for PPARs, particularly the PPAR alpha. So based on that, I think knowing that it's an important player in the metabolic space and present in liver and affects a lot of liver function, we were wondering, would it be beneficial in managing NAFLD and NASH? Because when it got approved in 2013, NAFLD NASH had already become very popular, and everybody was talking about identifying a drug for treating these conditions. So we started exploring, and interestingly, our first initial exploratory studies showed promise. So we started continuing that. So you already heard, I think this is a NAFLD NASH symposium. So obviously, you know, you've heard a lot since morning, so I don't want to elaborate. If I had given a talk, only me giving talk, I would have covered what is NAFLD NASH. So I think you already heard that. It's a progressive disease, starting with fatty liver and then progressing to NASH and then cirrhosis. You also must have heard the prevalence, and you know, in India, you see the dark spots are obviously highly prevalent in India, and particularly in different segments like diabetics and dyslipidemia and obese patients. They are, most of them, they have NAFLD NASH. And you also heard from Dr. Duseja that, you know, what is the current armamentarium? I think before saroglitazar are approved, nothing was approved here. Everything is right. But I mean, since doctors need to treat patients, so obviously they have to try something which is available. And as you also heard from him, the best treatment is the lifestyle modification. So it does everything what a best drug can do. But unfortunately, people don't try lifestyle modification, or if they try, it's not really full-hearted efforts. So we have to take medication, and you have the best top two, which Dr. Desai also recommended, that try vitamin A and pioglitazone. And if you see what all they do on NFL NASH, I think they do have some benefits. And the only drug that showed some improvement in fibrosis was pioglitazone. I think that's another distinct effect of pioglitazone. But it increased weight. And so although these patients are, most of them are obese and they are worried about weight gain. So I think it's not that popular, and it never got approved because the company developing pioglitazone never wanted to take it forward and do a large clinical trials and get it formally approved by the regulatory agencies. So it is never approved for treatment of NFL NASH, although it is still a very good drug and useful, globally. Yeah. So the need of finding new drug is really very high, and particularly looking at the trends and scenario. I mean, there's a data presented in JP Morgan meeting. So I just captured that, from 2015 to 2030, if you move, not only the disease will become more and more prevalent, but more and more patients will be sicker. Sicker means if they are in F1, they will become F2, F3. So the number of patients who will be in F3 and F4 stage, real sick, they are going to increase. So I think it's really important for us to, as a pharma company, to find something that can stop the progression of the disease. And the reversal is always the most desirable thing, but that's a very challenging thing. But I think considering the unmet need and the importance of NAFL NASH, and the fact that it can not only cause liver failure, but most of the people having NAFL NASH also die because of cardiovascular complications, which we don't really talk much. But I think that's a fact that most NAFL NASH people actually die of cardiovascular disease. So a lot of pharma company understood that need and started working on it. And this is it was a competitive landscape in 2019. A lot of companies are working and different molecules in different stages of development. But when we started wondering what could be the ideal molecule, we thought, let's start from the scratch. Let's understand what causes NAFL NASH, and then see what our molecules can do if we have to find an ideal drug. So I mean, this is a classical two-hit hypothesis for NAFL NASH, and obviously you have healthy liver, but then it all starts with insulin resistance. And because of this insulin resistance, you have lipolysis, and then you have fat accumulation in the liver. It causes steatosis. And then the second hit, because of oxidative stress, liver toxicity, you have mitochondrial dysfunction, your Kupffer cells get activated, cells get activated. And then you have ballooning fibrosis. And then you have all the histological manifestations that you see in NASH. And if you don't control it, then obviously some of the patients will progress into cirrhotic stage. And then the only thing left is to try a transplantation. So if we have to find an ideal drug, we have to see how do we stop it. Can we work on drug that can reduce insulin resistance or improve sensitization? Can we reduce the load on liver from the lipids that are coming so that the steatosis does not develop? Can we have a drug that can stop or treat the oxidative stress or the oxidative damage, free radical damage, inflammation, and lipotoxicity, and improve mitochondrial function, and then reverse, have a beneficial effects on the this thing. And why we thought so? Because we know from the history, from the ancient, from the more mythological things, from the Roman history, Roman stories about Prometheus. I don't know how many of you have heard this story, that Prometheus was used to steal fire and then give to the poor people, and then he was punished by Zeus, and then he was chained, and an eagle was released, and this eagle will eat the liver every day, right? And the next morning, the liver will regenerate and become normal, right? And this continued for years, right? And eagle was eating liver, and liver continued to regenerate next day, and then it continued for a year, and then until somebody, Heracles, talked to Zeus and then killed the eagle and then released Prometheus. So the liver has enormous regenerative capacity and power, but what happens when it fails? Because of the other factors which I just talked about. Can we take care of them so that liver can function on its own? I think pharmaceutical companies have been trying with different approaches. You heard PPAR, FXR, THR, thyrodoxine receptor, FGF, GLP-1s, lot of RNA-based therapy, inflammatory, anti-inflammatory therapies for fibrosis, lipids, and all this. These are the various approaches that companies have tried, but most of them have failed. Some looks promising, and I think they may come in the future. But then we had faith in saroglitazar, But then why saroglitazar with a dual alpha gamma agonist, we thought could be the ideal option for NAFL and NASH. You heard of it, it's a dual agonist. It's a different, distinct chemical entity with a distinct mechanism of action, and that is a predominant alpha effect. It's a chemically differentiated, so it doesn't have any toxicophore. So it's actually, in last 9 years of actual clinical experience, we have not come across any major serious adverse events. Pretty safe. Differentiated from glitazars. Glitazar in one day, and these were the best or the most interesting class, but all these molecules have gone to the graveyard, and nothing is there, They all failed except saroglitazar. So why? Saroglitazar is a distinct compound. We designed it differently, and it was a very potent PPR alpha agonist. And if you see, the potency is in the low picomolar or actually femtomole, on alpha. And then still, if you look at the gamma effects, also more potent than the available gamma specific agonists like pioglitazone and rosiglitazone, but still has a dual effect, because the way the dose response works, if you give enough dose, you can have a full alpha effect and a partial gamma effect. So it can still drive insulin sensitization with a very strong effect on the lipids. But having seen, we call it a dual alpha gamma effect. Somebody may say, just add fenofibrate and pioglitazone and treat NAFL NASH. But that never happens. You cannot treat NAFL NASH by combining fenofibrate with pioglitazone, and people have tried and it didn't work. Why saroglitazar work is because it's not really a combination of alpha and gamma. It's a really distinct molecule, and this is by nature of the receptor. Each PPAR receptor, each PPAR agonist is a class of its own, because it engages receptor and the cofactors in a manner that results in a different signature pattern of the genes that are activated or inhibited, and hence the net outcome is very different. And that's what we have proven here in the microarray study, where we have tried alone fenofibrate or pioglitazone or combined them. Still, the signature pattern of saroglitazar was different. Now, the big question is, if it's a different molecule, whether it will really do all that I listed as the wish list for a pharmaceutical company for managing NAFL NASH. And this is what I said. Can we treat insulin resistance? Can we reduce circulating lipid? Can we improve lipid clearance? Can we stop oxidative stress, inflammation, lipotoxicity, and improve mitochondrial function and all these things? And ultimately show histological improvement. So I just put my data and then see how does it behave. So first, let's look at what happens to insulin resistance. So we have, fortunately, models for insulin resistance. These are DBDB mice and Zucker fatty rats. These are mutant, they have mutations because of which they develop diabetes and insulin resistance. And we have seen the surrogates are reduce the glucose, improve insulin resistance by reducing glucose and insulin. And in fact, here, Zucker fatty rat, we have done a hyperinsulinic euglycemic clamp, and we have seen that it improves the glucose infusion rate, indicating insulin sensitization. The next question is what happens to lipids? Across animal models, it reduced lipids. And I think you saw some clinical data also. Every model, every species, it reduced triglyceride. Not only that, it reduced cholesterol. I think we have to use humanized mice, because normal mice, the cholesterol is reversed as compared to humans. So humanized mice reduce cholesterol. Also, in cholesterol fat animals reduce that. We also saw that it improves lipid clearance if the animals are treated with surrogatasar for 14 days. And if you challenge this with the intravenous infusion of lipids, then lipids get cleared extremely rapidly. So it disappears from the circulation. And that's the kind of activation the surrogatasar do. Based on that, we wondered what happens if patients eat a lot of fatty meal, and if they are on surrogatasar, would this fat come to liver, or would the fat come to circulation and cause the steatosis? So we did a study where we have treated animals with surrogatasar, and then we gave a labeled palmitate. So we should be able to distinguish what is coming from the diet and what is present in the body. A labeled palmitic acid we gave so that we can monitor the labeled species, and we did a complete proteomic analysis. And forget this, because these are all known effects of surrogatasar. It does that. Here, when you give the meal containing palmitic acid, if you look at the controls, it increases. Obviously, when you eat something, the lipid will increase in the blood, and phenofibrate worsen it. Although it reduces circulating triglyceride, but it worsens the meal, the lipid coming from the meal. Whereas surrogatasar, nothing happens. So you eat meal containing lipids, and lipid doesn't come to your circulation. So basically, your lipid clearing system get activated, and I think that's a good thing, so that the liver doesn't get lipid load coming from the diet. Then we have to show effects on the inflammatory marker, and I think we did studies in HepG2 cells, and of course, eventually we did animal studies to look at the mechanism and the molecular pathways. So, and it has anti-inflammatory effect. It has antioxidant effect. It improves mitochondrial biogenesis. So what you see here, 3 bars, one with the control, one with the palmitic acid as a lipotoxic insult, and then palmitic acid with surrogatasar, and surrogatasar is able to reverse the negative or the adverse consequence of the lipotoxicity. And here we are seeing the ROS generation and the NF-kappa B activation. Everything is reversed by surrogatasar. What happens to the stellate cell activation and stellate cell function? And I think we did this study with the co-cultured the LX2 cell with the HepG2, and then we found that all the markers of fibrosis, they were also reversed by surrogatasar treatment. And the phalloidin and the epi stain to look at the reorganization of actin to see whether the fibrosis is also, or the cellular cell activation leading to the actin filament restructuring is also affected, and did that. So eventually we had to show the benefits in the NASH models, and I think we did several. We got data from now, not only the ones that we have generated, but published by independent the groups, and I think in different models we have seen beneficial effects. It improves the liver function, so all the biomarkers of liver damage are improved significantly. Lipids are also significantly improved as compared to the choline deficient high fat diet animals. This all reversed. And by the way, in this study, we had pioglitazone and fenofibrate as a comparator, and some of the parameters they also show improvement. But if you look at the liver lipids, everything doesn't work except surrogatasar, which significantly reduce specifically the liver lipids. And we have seen that in the histology. Uh, these are obviously the normal animals. And this is here you see a lot of oil redo stain indicating fat deposit in the diseased animal. And the third row, you see Saroglitazar has cleared the lipid. So obviously there's nothing left. And then you have pioglitazone and fenofibrate, which have obviously we have seen in the biomarkers that there was no effect. Not only the lipids, but we also look at the various components of NASH. So steatosis, ballooning, inflammation, and fibrosis. All the scores were improved with Saroglitazar in this animal model. Now, having seen this, obviously CDHFD is not a very strong, is a not the best model for fibrosis. It could be good because if you take the longer duration, but I think we wanted to quickly see what happens to fibrosis. So we chose a carbon tetrachloride induced model, and we saw a good fibrotic streaks with the CCL4. And Saro didn't work in the low dose, but in the 4 milligram, the dose which is equivalent to the human dose, we have seen a significant effect on fibrosis. And PO and obviously phenofibrate did not do that. It was accompanied by changes in the biomarkers. So all the liver function biomarkers got altered favorably. All the other biomarker, collagen 1 alpha, SMA, and TGF beta also got affected by Saroglitazar. So while we did this study, we we were talking to Dr. Arun Sanyal, and he said, I have a more interesting model, which is like, what typically a human mimicking human condition. He said it's like a cafeteria diet, or something like a Western diet model, which he called diamond mice model. He said, let's try in that model also whether it does all these things what you have seen in CDHFT. So in this model, we have again compared with pioglitazone, and I think the data is almost similar. So we have seen these are just to see what happens to the other biological functions. So insulin resistance is significantly improved. I think adiponectin is increased. So those are the first hit, as I said, insulin resistance is demonstrated here, significant improvement. AST, ALT is all Saroglitazar causes significant effect. TNF alpha is inhibited. Then we have cholesterol and triglyceride, obviously expected to be benefited. In this model also, if you look at the diet, you have a lot of lipids here. And if you look at Saroglitazar, I think you can clearly see the remarkable improvement in the lipid in the liver. So there's no lipid left. And we also saw improvement in the serous red stain, which indicate the improvement in the fibrosis. And those are reflected in the scoring system. So steatosis, significant reversal with Saroglitazar, and pioglitazone didn't do much. Lobular inflammation, again, significant effect with Saroglitazar. Ballooning, almost normalized. Fibrosis, some improvement. Of course, this is not a best model for fibrosis. And overall NAS score got significant improvement. So I think we have seen animal model also, it does a good thing. And a lot of gene and protein expression biomarker for again correlated with the histological changes. Now the final thing is whether Saroglitazar affect only the first stages or the second stage, or does it also affect the hepatocellular carcinoma development? Because I think PFAS were notorious that they could cause tumors. So we did this study where we specifically look at what happens to the carcinoma. So in this model, we have used DAN to induce this tumor subsequently in the later part of the life, the CDHFD. And we have seen improvement in the insulin sensitization and lipids, and liver, this free radicals are also inhibited. Most importantly, if you look at this, this is the figure 3 where we have the tumor incidences. The number of animal, the percentage of animals with the tumors were very high with this DAN treated animals, and it got reversed with Saroglitazar. So Saroglitazar is the next two columns. And number of tumors on liver is also significantly reduced by Saroglitazar, and it was accompanied by reflected in the histological changes as well. And this study also we looked at the fibrosis, and fibrosis showed a significant improvement. So although it's not normalized totally, but it's a significant improvement. So we have seen in all the animal model in vitro studies, what all we wanted to see in my wish list, we were able to demonstrate in the in vitro and in vivo models. And we have done a complete ADME profile and safety talks, etc., which is needed for any drug. So I don't want to talk about it. But what is interesting from ADME, other than there's a non-renal route of elimination, when we did a autoradiography after using a radio-labeled saroglitazar, we found that it is disproportionately it is present in the liver. So if you look at where all it's present in the body, the amount of saroglitazar present in liver stands out. Well, we didn't. We were surprised that it's so much saroglitazar is present in liver, and obviously it gets eliminated in 24 hours. But liver is something that it has a specific preference for, and that's accumulated there. So it's like fortunately, it is the right place where it has to work. So I think this is a summary. I have already mentioned that we could see everything that we put as a wish list. And it is also reflected here. So we saw insulin sensitization, reduced triglyceride in synthesis, secretion, and absorption, and release and accumulation in the liver. Significant effect on oxidative stress, inflammation, lipotoxicity, and mitochondrial function, and effect on Cooper cell and stellate cell activation. And also ultimately we saw HCC also is also reversed with the saroglitazar. So I think we believe that it can definitely reverse the progression to reverse pathway can get activated by saroglitazar. It's all based on our non-clinical work. And the big question, as most of you are doctors or working on translational aspect, would it be safe and effective in human NAFLD-NASH? So I think we have already done the phase 1 safety, and 4 milligram is the approved dose, but we have gone up to 128 milligram to demonstrate safety, and it was safe and well tolerated up to 128, very high doses also. And this data got published. Dr. Desai also mentioned that we have this saroglitazar for treatment of NASH. It actually came as an editorial in the same issue where the paper got published in hepatology. So this was basically a data which was also presented at ASLD by Dr. Samir, and he's from the Indianapolis. And we had the primary endpoint was ALT, and then exploratory endpoints were all the the fibrosis and biomarkers for all the NAFLD-NASH. I think what's interesting is in the 16-week, much smaller duration trial, we could see a significant improvement in the liver enzyme score. So ALT got significantly reduced, AST reduced, ALP got reduced, GGT got reduced. We also saw, I think you also saw the data in Dr. Ajay's presentation, something on CK18 got favorably reduced. APRI score got improved. Liver ELF test showed a significant improvement, and the fibrosis showed a significant improvement in stiffness score. So if we think of the liver fat content in humans, we were able to show the significant improvement. And I think if you think of more than 30% reduction in about 40% patient, I think it's a significant translation of what we have seen in the animal model. And the overall lipid profile got favorably altered by saroglitazar. And I think I saw some metabolomic data in posters, and I think this was also attempted in the clinical trial. So we have seen the metabolomic shift towards improvement. So primarily the diacylglycerol and triglycerol and DAPC and the LPC and the ceramide and those pathways are really are favorably affected by saroglitazar. I think so. What we expect in an ideal molecule in terms of reversal of the metabolic shift that happens in NAFLD-NASH, I think we are seeing that. He did mention about the evidence trial. I think So we have seen in this biopsy proven NASH patients that significant improvement in NASH score, significant improvement in steatosis, lobular inflammation, and hepatocyte ballooning. So overall, I think it met our primary endpoint. I think there are two ways of getting a drug approved for NAFL-NASH. One is, resolution of NASH without worsening of fibrosis or improvement in fibrosis. So I think we got a significant resolution of NASH. So it got approved in 2013. And not only that, or 2020. Not only that, but it showed significant improvement in the all other biomarkers, as we have seen in this US trial also. And the lipid profile was also favorably altered. All the lipids got benefited by saroglitazar, and all this significantly reduced. So 2000 March 20, I think it got approved for treatment of NASH, and it became, I think this was in coverage in the press, that Zydus saroglitazar become the first NASH drug approved globally, and nowhere else any drug got approved. We were fortunate that it met the pre-decided endpoints, and based on the favorable non-clinical data. I think we are developing it further. I think it's already in use in India, and we are now thinking of a global development for NASH, but we are also looking at additional this primary biliary cholangitis, a very interesting indication for US, and I think our data showed good promise. So that's a future prospect. So I want to thank the management of Zydus and scientists who contributed to this work, Dr. Charles Buran, who collaborated with us on some other studies, Dr. Shiv Shankar from ICB, Dr. Arun Sanyal and Naga Chasan, who have been really doing the trials and supporting us and guiding us on the development, and all the investigators in India and outside who were involved in the clinical development. Thank you very much.
Thank you, Dr. Jain. Could you join us over here on the dais, taking us through the journey of saroglitazar? Over to the third chairperson.
So thank you so much. I hope I'm audible. Hello? Hello? Hello, am I audible to? Hello?
Yes, ma'am, you're audible.
Okay, thank you. So, good afternoon, everyone, and to my co-chairs, Dr. Anil Arora and Dr. Yogesh Chavla. I wish to congratulate Professor Garg, NCD team, and THSTI for organizing such a wonderful one-day symposium on fatty liver disease, and also thanks for inviting me. So before I invite Dr. Rajiv Rai, I would like to share the initial efforts which went into initiate the NCD program at THSTI. Actually, I remember my early discussions with Dr. Gagandeep Kang in 2018 to initiate a drug discovery program in the area of NCD. So we had good discussions, and we decided that we can initiate a program for treatment for the therapeutics of NASH, because there is at that time there was no approved drug to treat NASH. And I'm thankful to the members of NCD team and for their full-hearted support and the efforts which went into initiate this program. And it is very satisfying that the program is progressing well. With the help of Dr. Shalimar, we also initiated a program on search of biomarkers to identify NASH and differentiate it from the early stages of fatty liver disease. During that time, we also had good discussions with Vaidya JLN Shastri, who was at Dabur at that time, and with Dr. Rajiv Rai and their team members to initiate a discovery program for the treatment of fatty liver. And we selected herbal extracts, which were actually known for the hepatoprotective activity. And with this active discussion, we initiated a program. And as was mentioned by Professor Garg during the inaugural talk that this program is now running successfully. And I'm very thankful for the leadership of Professor Garg, who's providing and leading this program at the currently. Now it is my privilege to introduce Dr. Rajiv Rai, the next speaker. Dr. Rajiv Rai is Head Healthcare Research, Dabur India Limited. He has 26 years of research experience and is involved actively with Pharmacopoeia Commission for India, Medicine and Homeopathy, Council of Research in Ayurvedic Sciences, and in other research organizations for research, development, standardization, and quality control of Ayurvedic medicine. Dr. Rajiv Rai has more than 30 publications, so may I invite Dr. Rajiv Rai to deliver his talk.
Introduction, and I would also like to thank Professor Pramod and Dr. Dinesh for giving me the opportunity to present the Ayurvedic perspective, which is all there in the ancient Ayurvedic literature. And I hope that there may be some leads to further take up the scientific research on these leads, which are there in the literature since 3000 years earlier till 16th century of this era. So we have a good detailed description there in the Ayurvedic literature for the liver disorder, and some scattered description is available for fatty liver also. So I would like to present my presentation and will emphasize more on the Ayurvedic part. So we have already discussed a lot on the modern part, and we all know the modern science about the fatty liver right now. So I'm just going to skip the modern part and I will go straight directly to the Ayurvedic part, what we think about it in Ayurveda. So just to have the little better understanding about the Ayurveda, I will give some fundamental concept of the Ayurveda, how Ayurveda thinks about the body and various other things. So Ayurveda thinks that the body is fundamentally composed of Panch Mahabhut, Akash, Vayu, Agni, Jal and Prithvi. These are the 5 basic elemental things which are the basic structure of each and everything of the universe. So these are the basic fundamental structural units of the body also. So having the help of these structural units, basic fundamental structural units, various dosas, and these are specifically 3 numbers, Vata, Pitta and Kapha. Dosas are there in the body. Vata dosas take care for the movement and nervous functions of the body. It also takes care for the circulatory, ambulatory, breathing and thinking part of the body and mind. Pitta dosa takes care for the metabolism, digestion, absorption, assimilation, nutrition and thermostasis part of the body. Kapha dosa is there to take care for the proper movement, lubrication of the joints, moisturization of the skin, and for the taking care of the immunity part of the body. So the balance of, or you can say equilibrium state of the dosas is there. If in the body, there will be a healthy state. And if there is any imbalance in these dosas, certainly there will be a disease. Ayurveda also consider that the genotype and phenotype of each and every person is different. And as per his phenotype, he is certainly going to have some positive and negatives for the health. So Ayurveda always advises that before starting the treatment, assess the phenotype of the individual, and that one is known as Prakriti Pariksha. So Ayurveda take every individual as a separate man, and it advises to do proper evaluation of his Prakriti and accordingly take care for the treatment. So along with dosa, other things which are very much important. So you can say the dosas are the physiological structural unit of the body, and the dhatus, these are the anatomical structural units of the body. 7 types of dhatus, you can say the tissues and the fluids are there in the body. These are known as ras, rakt, mans, med, asthi, majja, and sukra. So here I am going to emphasize more on the med dhatu, because mostly the fatty liver is going to be taken care, and every imbalance and loss of equilibrium position will be there in the med dhatu only. So meda dhatu is going to be very much important here in case of fatty liver disease. So what is liver in Ayurveda? So liver in Ayurveda considered that during the embryonic development, the liver have the maternal traits. It is having the development and nutrition from the blood tissues, and it is one of the important part in the circulatory system, and it is also very much relevant in the generation of connective tissue, or you can say the blood part. So how many types and how many kinds of liver diseases are there, and where there any specific description of the fatty liver is there in the Ayurveda or not? So liver disorders are very vaguely described there in the Ayurveda, and somewhere they were captured in the Udar Roga, and somewhere they are described separately also. So in ancient classics like Charak Samhita, there is no significant description of fatty liver disease is there, and some conditions which can be correlated as hepatocellular carcinoma is there, and for this Yakrudodar term is there. But in case of Bhav Prakash, which is written in the 16th century, we can see the description of 4 liver disorders, and these are mentioned as Yakrit Vriddhi, means enlargement of liver, and these are having very appropriate description for the fatty liver, and we can consider them that these are which can be considered as a synonym for the fatty liver. So what are the etiological functions, etiological causes mentioned there in the Ayurveda for the generation of fatty liver or liver diseases? So we can see here that the unhealthy food habits and lifestyles are the main reason for the fatty liver and liver disorders. So here you can see the description of saline, alkaline, and especially the junk food, you can say sour and slow poison kind of food, which are having this kind of nature. And this kind of unhealthy food habits are the prime important food factors which may play a role in the development of fatty liver. Earlier, the one of the known therapy part is there in the Ayurveda, which is known as Panchkarma, and it was very much prevalent earlier and practiced widely in India. So during Panchkarma, the digestion and metabolism part of body goes very much deteriorated. So to regain the normal equilibrium of the digestion and metabolism of body, some Sansarjan activity is advised in the Ayurveda. So if we are not going to properly follow the Sansarjan activity, some deformity, or you can say the proper equilibrium position of the digestion and metabolism cannot be regained, and this also going to lead for the fatty liver or liver disorders. And as per the body phenotype of your body, if you are not going to take the food who are going to be acceptable to your body, and if you are going to take the unhygienic food, certainly this is going to lead the liver disorder and fatty liver disorder. If your phenotype is having some weak traits in your body, and you are not having the proper liver function, so you are automatically a case for the development of liver disorders. If you are not taking the natural calls on the time and you are going to hold them, certainly this may be one of the reasons for the development of liver disorders. And if you are having the poor digestion and metabolism power, certainly the proper digestion of the food is not there, and some byproduct is going to be generated in the body, which modern scientists can interpret better. But in Ayurveda, it is known as ama, and it is supposed to be major cause of many of the diseases. Body channels. If body channels which are going to transport and distribute different nourishment parts and excretory part material inside the body and going to remove the excretory material from the body, if they are not having the proper functioning, certainly this is also going to one of the reasons for the development of liver disorder and fatty liver disorder. Overeating, one of the main important cause. So we can see here that overeating is one of the causes mentioned there in Ayurveda for liver disorder and fatty liver disorder. Poor digestion and metabolism is also one of the reasons mentioned in the Ayurveda. So for hypothetical assessment of the development of fatty liver, I have just drawn this slide. But I would like to emphasize here that in Ayurveda, to lead a proper healthy lifestyle, we have a detailed description of Dincharya and Ritucharya, daily regime and seasonal regime. It is very methodical, and step-by-step description in different classical Ayurvedic literature is there, just from waking up early in the morning and till going to the bed in the night. A very detailed description is there, how to lead the life daily and in every season. Which kind of things we can eat, which kind of things we can drink, which kind of clothes we have to wear, and which kind of things we have to avoid. A very detailed description is there. Which kind of cereals, which kind of vegetables we have to take daily, and in which diet and in which season. So this can be a very good lead here, because this disease is mainly metabolic disorder, and it is not classified in a communicable disease, and it very rarely has other factors in the etiology. So Ayurvedic fundamental part which is there in the Ritucharya and Dincharya, and that is to lead a very healthy lifestyle, can be very much important and helpful for the dealing of this disorder and management of this disorder. So you can see here in this slide that just by having the dearrangement or there in imbalance in the digestive parts and some metabolism part, there is accumulation of fat is going to be there in the liver, and that accumulation of fat is mainly by the meda dhatu. Meda dhatu means adipose tissue. So meda dhatu is going to be deposited in the liver, and meda dhatu is mainly dealt and metabolized in the liver as per the Ayurvedic fundamentals. So what is meda dhatu? So as I have already told you that 7 main dhatus, you can say the tissues and the liquids are there, which are the anatomical part of the body, you can say ras, rakt, mans, med, asti, majja, and so these all get nourishment from each and every one in sequential order. Means rasa nourishes the rakta, rakta nourishes the mans, mans nourishes the meda, meda nourishes the asti, asti nourishes the majja, and majja nourishes the sucrose. So this sequential order of nourishment is there in this 7 dhatus, and mans dhatu nourishes the asti dhatu, and meda is metabolized by the medo agni. For individual, each and every dhatu, we have some metabolic factors, or you can say metabolic enzymes, which Ayurveda was not able to narrate very precisely at that time, because these ancient literatures were written 2000, 3000 years earlier. So it is written there that some metabolic factor or metabolic enzymes were there for the metabolism of medo agni, and some derangement or some problem was there in the pathway of the metabolism of meda dhatu, and meda dhatu, and the proper metabolism after getting disturbed, there was a generation of durmeda. You can say that free fatty acid is getting generated more in quantity due to the improper metabolism of the adipose tissues. And for better clarity, you can say that Meda dhatu is not only the adipose tissue, it also have the adipose tissue along with the fatty part, which is there in the blood. So Meda dhatu is there as a fixed adipose tissue, circulating fatty part. You can say the triglyceride lipid profile, the various factors of the lipid profile which are there in the blood, and durmeda, which is free fatty acid available in the blood due to the poor metabolism of the adipose tissues or meda dhatu, including the lipids. So this durmeda and the circulating fats, which are part of the meda dhatu, are getting deposited in different parts of the body. And one of the important site for the deposition of this durmeda, free fatty acid, and circulating lipids is liver. So there they are getting deposited and they are generating the fatty liver disorders. So why meda is getting deposited in the yakrit only? So Ayurveda considers that the yakrit is the main and important a vital part of the body who take cares for the metabolism of the adipose tissue and the fatty material, lipid material available in the body, which is also under the part of meda. So this is the reason, that is why meda is getting deposited in the yakrit only, because yakrit is the primary site for the deposition of the lipids, and it is taking care for the metabolism of the lipid and other fatty material. So what is the etiopathogenesis as per the Ayurveda for the fatty liver? So we can see here that if we are going to take the improper diet, you can say the unhealthy diet, and other disease associating factors are there. Means your digestive power is not proper and your metabolism is not proper. You are obese, you are having the diabetes mellitus conditions, then certainly there will be digestion will be hampered more. And apakvanaras means ama will get generated. This ama is certainly going to have a lot of ill impact on our body. So Agni-mand will be there because digestive power is impaired and ama is going to generate. And with the generation of ama, certain durmed and abadami. Abadami means circulating lipid and free fatty acid will also get generated and will be there in the circulation through blood. And this excessive quantity of lipid in the form of free fatty acid and lipids will get accumulated in any preferable site of the body. And the most preferable site of the body is liver only. So this is getting deposited in the liver, and the sneha guda in the liver is going to increase. So this lipid part and free fatty acid gets deposited in the liver, and this condition is known as Mendaj Yakridaludar. So this is a very precise condition for the fatty liver in the Ayurveda. So Mendaj Yakridaludar is the term for the you can say fatty liver, and this is due to the deposition of lipid and fat material in the liver. So after getting deposition of lipid material in the liver, the normal function of the liver gets disturbed, and there is deregulation of pitta production and further advancement of disease in the form of fibrosis and cirrhosis and HCC is there. So there is one more term in Ayurveda which is known as dosh, dushya. How dosh is going to affect the dushya. So how the physiological factors are going to affect the anatomical factors. So dosh initially kapha dosa is there, and later when the pitta production is going to be hampered, pitta is also going to be involved in this pathology, and vata, which is having the role to transfer the material from this each and every location to other location in the body, is also going to involve. So vata, pitta and kapha, initially from the kapha, pitta will get involved, and in the final stage vata will get involved. So all the three dosas are going to be involved in this fatty liver disease, and the dush, the tissue part which is going to be there involved in this pathology will be mostly Meda Dhatu, but later Rakta and Mans are also going to be involved because the nourishment is in sequential order. So if Meda is going to be involved, so more production of Meda is there, and further nourishment to other tissues which are there in the higher order is not proper. So the ultimate effect is there on the body, and the main affected tissue will be Meda Dhatu. Srotodushti means the channels which are going to have the role in this pathology, but I'm not going to narrate very much about this Srotodushti, Sthan, Agni and Veda, because the audience available here will, they will not appreciate these kind of things, and perhaps they will not be able to understand also. So what are the types of liver disorders and diseases are mentioned there in the Ayurveda? So we can see here that Yakrit Vriddhi means enlarged liver is mentioned there in the Bhav Prakash, and it has 4 types: Raktaj, Vataj, Pittaj, Kafaj. Yakrudal Udar, Ashtang Sangra. This is also one of the ancient Ayurvedic literature, and it has 3 types: Vataj, Pittaj and Kafaj. Yakrutodar, Charak Samhita, one of the most ancient Ayurvedic literature of the Ayurveda, and it has the description of liver disorder as Yakrutodar. Yakrit Vriddhi is there in the Susrut Samhita. This Ayurvedic literature is known more relevant for the surgical intervention in the pathologies, but it also has the description of Yakrit Vriddhi, means liver abscess. So how we are going to interpret that Yakrit Vriddhi can be correlated as fatty liver? So what are the description available in the Ayurvedic literature for the Yakrit Vriddhi? So as I have already told you that Pitta, Kapha and Pitta dosa are going to involve, and other signs symptoms which are mentioned there are like that the patient will have the mild fever, diminished digestive process, will have weakness and have anemia.
Professor Rai, I think you will have to shorten up.
Yeah. Certainly, sir. Certainly, sir. And Bhav Prakash has described other types of Yakrit Vriddhi and Raktaj Vriddhi, Yakrit Vriddhi, Pittaj Yakrit Vriddhi, Kapha Yakrit Vriddhi, and Vata Yakrit Vriddhi. So these are the liver enlargement, and these are the sign symptoms which are there in the Ayurveda. So how Ayurveda is going to manage the fatty liver disorder? So as I have already told that AMA is the major part there available in the pathology, and this is going to play a major role. So we have to remove the AMA part from the body. So a proper digestion and improving the metabolism there in the body, we just go for the AMA pachan, and by taking care of the AMA removal from the body and restriction of the further AMA generation in the body is the first step of this management of this disease. And the sodhan of the rakta, since there is a lot of circulating fat and lipid is there in the blood, so we have to remove this circulating lipids from the blood, and we have to clean and clear this circulating fat from the blood. Tikta Rasha Sevan. So perhaps earlier time the Ayurvedic acharyas were not able to properly identify the secondary metabolites and phytopharmaceuticals available in the phytochemist. You can say the phytochemical parts available in the Ayurvedic jadi booties. So they have described that Tikta Rasa. So they have described that the Tikta Rasa Sevan should be there, and Tikta Rasa is going to take care for the proper improvement of digestion, metabolism, and it will also take care for the lesser generation of Meda, which is mainly responsible for the development of this fatty liver disorder. So this kind of description is available, and by using these 3 steps, we can manage the liver disorder as per the Ayurvedic fundamentals. So certain jadi booties, you can say herbs having the predominantly the bitter taste are advised, because as I have already told you that they were not having the facility of modern and analytical tools, so that they were not able to identify the actual chemistry part available in these herbal materials. So they have advised that on the basis of predominance of bitter taste, we can use the herbs like Kumari, Apamark, Erand, Punarnava, Kaliyak, Nimb, Daru Haridra, and Damanak, Indrivara, Dipyak. So, sorry. So these are the herbs which are described there in the Ayurveda, and especially Bhumiyamalki, Kirat, Katuka, Kalmek. These are the herbs which are very much in practice, and different formulation in the market are available having these drugs having these drugs in their composition part. So we can see here that Kutki is most important herbal material which is available in the different formulation in Ayurvedic formulation, and it is very much acceptable by the Ayurvedic fraternity, and a lot of Ayurvedic products like Hipano of the Dabur and various other products of different companies are having Kutki, one of the important herbal material. Kalmeg is also there, and it is predominantly having the bitter taste. And in modern, with the help of modern analytical science, we can say that Kutki is having the picroside and Kalmeg is having endographolites. But earlier days, they were not able to have the analysis part of the phytochemistry available in the herbal material. So they have described that Tiktarasa material should be consumed. In Chirata, we know that chiratin and suercine are available right now. And Bhumi Amalki, Phyllanthus niruri is there. So these kind of raw materials are very much described. Certain other formulations are described and very much advised for the use in the fatty liver and liver disorders. These are, you can say, Bhringraj, Asav, Sarpunka, Kalk, Chara Gutika, Yavadi Gutika, Lasna Tel. So these kind of formulations are also there. Even herbo-mineral formulations are also advised, but these are not very much in practice right now. So some advice is also there for the which kind of ahar bihar, means which kind of food habit and exercise should be done. So you can see here in this slide that they have advised to take the honey, they have advised to consume fruits and salads, milk, and you have to have the soups of different legumes, vegetables like spinach, carrot, and bottle gourds. And they have advised for different vegetables also. Bihar, in case of healthy lifestyle, they have advised for the exercises, and various asanas are there advised in the Ayurvedic literature. And these are certainly going to help for leading the healthy lifestyle. And the things which should be avoided by the patients which are going to have the liver disorder or the fatty liver disorders, they must avoid the milk, buttermilk, ghee, coffee, tea, smoking, tobacco, chewing pan masala, alcohol. So these are factors which are going to aggravate this disease further. So this kind of description is there, available there in the Ayurveda, where what kind of things should be taken by the patient to successfully take care of the disease, and what kind of things should be avoided so that we can not going to have this kind of problem. So these are the things which are there. And what Dabur is doing right now. So we are in collaboration with the TISTI right now, doing some study on the fatty liver disorder, NFLD, and we have done some in vivo and in vitro trial, in vitro and in vivo trials, and we have selected some drugs. And the primary results for the prevention of hepatotoxicity, lipid accumulation, fibrosis, and various other factors which are there in the FNLD. So we have got the very promising results with the use of these herbs, which are already advised in the Ayurveda. And further round of studies are planned, and they are going to be happen very soon. So we have selected Kutki, Mustak, Bhumi Amalki, Chirayata, Haritki, Pipali, Gurchi, Haridra, Sarpunkha, and Kalmoik for the in vitro study, and results are very promising for prevention of lipid accumulation and hepatoprotection. And in vivo study we have also conducted with the collaboration with TISTI, and we have selected the Mustak, Bhumi Amalki, Chirayata, Haritki, Pipli, and Sarpunkha for the lipotoxicity study and steatosis assay, and results are very promising. And further rounds of studies are planned and in process. So here with these kind of Ayurvedic approach, I can say that we have a well description of leading healthy life in Ayurveda, and we can adopt an integrated approach by adopting the modern pharmaceutical science for the development of new drugs. And if certain modern pharmaceutical compounds are available there, we can take an integrated approach. We can also use the Ayurvedic pharmaceutical material which is already available, and we can take an approach for the development of new phytopharmaceutical material with the lead of already material which is there in the Ayurvedic literature. But in an integrated approach with the help of Ayurveda, Dincharya, Richarya, which is very much useful for the metabolic disorders, is certainly going to provide us better results. So with these words, I would like to finish my presentation here, but with an integrated approach, we can get the better results. So thank you for patience and kind hearing.
Thank you very much, sir, for an exhaustive lecture on the role of Ayurveda. The three talks are now open for discussion. We've already crossed our time, but few burning points can be brought up by the audience. Yeah.
Okay. I have a question for Dr. Jain. This was a very good presentation, sir. My question is, the drug that you presented.
You're not very clear on the mic. Speak
Hello?
a little loud.
Yeah. So my question is, the drug that you presented, is there any study to suggest that it might influence how the body responds to a pathogenic infection? So the drug that you presented, is there any study to suggest that it might influence how the body responds to a pathogenic infection? I mean, it's
Infection?
NAFLD, but how somebody who is taking it might respond to a pathogenic infection, or let's say bacterial or a virus infection.
With this mechanism, I don't think it will affect the pathogenic infection. And we have never studied that aspect also, yeah. PEPA are metabolic drugs. So basically the natural ligands are our fatty acids and prostaglandin pathways.
Yeah, because it is suppressing, for example, NRF2 activity and many of the inflammatory pathways,
yes,
which are necessary for pathogen clearance.
Yeah.
So I was just wondering if there has been any.
It suppresses inflammation. All the PEPA agonists, they suppress inflammation through NF-kappa pathway. Basically, they inhibit that. But whether they would influence bacterial infection, we have no idea.
Okay. Thank you so much.
So I have a question for Professor Duseja. So, sir, your take on obeticholic acid and its off-label use in India?
I think that's a very valid question. I would say after the drug became available in India for PBC, primary biliary cholangitis, another liver disease, where OCA or obeticholic acid has been approved globally and also in India. So when it came to India last year, there was a lot of enthusiasm, and most of the Indian pharmaceutical companies came with this, the generic form of obeticholic acid and became in the market and even started, promoting it not only for PBC, but also for NASH. But then at that time, the FDA meeting was still pending and we were still waiting. And if you know the story, the FDA has still not cleared the OCA for use in NASH. And the issue is, one is the side effects, and other is we don't have the clinical outcome data yet. It's only the interim analysis which shows its efficacy only in, say, improvement in fibrosis. So off-label, if you ask me, people are using it. Personally, if you ask me, we don't use it because this is using a drug which is, bothering you with a lot of pruritus and, causing a lot of dyslipidemia for a disease which is kind of clinically silent. I think probably it's not worth it. So if you have to use it only for a very specific indication where F3 patient has F3 fibrosis, nothing else is working, You can still use it, but still not approved. That will be my take on this. Yeah.
Thank you.
I have a question, please, Dr. Jain. Saroglitazar. So, can you tell me? Can you put some light on the side effects of saroglitazar, if anything?
Yeah. So I think the only side effects we have seen are GI related, which are also, I think they are, because they are more than certain numbers, so we have to report those as the side effects. Otherwise, we have not come across any major side effect. So I think asthenia, some GI disturbances are the only ones are on our label here. It's pretty safe drug. Yeah.
Did anyone do the neurological studies in some neuronal parameters effect on?
No,
neuronal
we have
parameters?
not done any neurological studies on saroglitazar.
Thank you.
Hello, my question with Dr. Duseja. So actually, this related to obeticholic acid, or another clinical trial candidate is tropifexor, which is not non-steroidal, but both are the full agonist of FXR. So I want to know your comment about full agonism is associated with the direct associated with cardiovascular complications. So recent some papers are coming that full agonism is not better for the associated with cardiovascular complication. Partial agonism might be better when disease move towards NASH direction. So what is your comment on that?
As I said, OCA, when they found that it is associated with a lot of side effects and predominant being dyslipidemia and pruritus, then they started looking at, other FXR agonists. And some of them, is the tropifexor and the other, and they also started looking at the other molecules which are known as non-bile acid FXR agonists, thinking that they will take care of these side effects. But when they found that whatever, FXR agonists they were using, whether it was tropifexor or fenofexor or OCA or anything, the pruritus continued to remain as what they call it as a class effect. So any kind of FXR you use, I think the pruritus still continued. Yes, it varied in the degree or the severity. Tropifexor has probably less of pruritus in comparison to obeticholic acid, but it's a class effect. Now, coming to your second question about the cardiovascular and the dyslipidemia effect, yes, there are variations between that, but I think we don't still have good clinical data to choose one over the other. Probably, I think we'll need more data on that. Yeah. I have a small question. I mean, just not a question, but a comment on the herbal products on NASH. Just to give our take on this, we just completed one, clinical study on usage of phylantine in a mice model of NASH. So we made a MCDDD, the methylene and choline deficient diet model of NASH in mice. And then we use different dosages of phylantine. When we use the crude form of phylantine and also the commercial form of phylantine in different dosages. And we showed that, yes, it did improve the liver histology and lots of other, cytokine profile and the other thing. This paper is still under publication, and we'll be presenting this in our annual NASL meeting, if selected for any of the oral or the poster sessions. And we already presented that in some of the other meetings. So I think a lot needs to be done on these products since we don't have any approved drug. But the problem in these kind of studies would be that whether these animal results would really turn into the human, results would be another major question. But this is our small experience on the herbal product we had.
Sir, just want to know that there is a disease called autoimmune hepatitis or drug-induced hepatitis. So whether the drug saroglitazar is effective in the same disease or not? Whether the saroglitazar is effective in NFLD only, or it can be used for AIH like autoimmune hepatitis or liver-induced hepatitis.
Yeah. So I think there was previously there was one question about the neurological. Have we explored neurological? I think immediately in my mind it was pure neurological diseases, but I realized we had done some studies in the EAE model, And we did see a good effect. That's a neuroimmune condition model. So it does work in that. So I think wherever there is a immunological component or inflammatory component, saroglitazar would show benefit. Now, in autoimmune hepatitis, those things, just because it's a very strong influencer on the immune function and inflammation and immune function, it might show some benefit. We have not done that, but yes, we have evaluated in the EAE model for the neuroimmune function, and it did work. Yeah.
Thank you, sir. But you are still, I mean, you have a clinical trial going on in PBC, saroglitazar. So primary biliary cholangitis, there's an ongoing study for saroglitazar.
Just a simple question to Ajay. Ajay, all of us agree that it is a lifestyle disease. How the hell on earth is 6 months or 1 year of pharmacotherapy will ever correct the disease? That is number one. Secondly, there is a changing paradigm in trying to treat fibrosis and not the inflammation in today's management of NAFLD. So what you want to undo is the fibrosis, not the NASH. And majority of the NASH will die of cardiovascular disease rather than the liver. So is our focus not still on inflammation when it should be changing to fibrosis?
I think taking you all the three questions one by one. First, the last question. If you look at the morbidity and the mortality which happens in fatty liver disease, patients, if they are in early stage, whether it is NAFL without fibrosis or inflammation, they die more of cardiovascular and other diseases. But when you have NASH with significant fibrosis or cirrhosis or HCC, they will die of liver disease. So till the time you don't have fibrosis, yes, cardiovascular disease is the major cause of death. But then once you have liver disease, which is significant advanced fibrosis, then I think liver disease takes over others. So that actually brings us to the second question of yours, that we need to tackle these patients, those who have already gone into significant fibrosis and advanced fibrosis, where lifestyle interventions alone may not be sufficing. We need drugs to reduce this fibrosis and inflammation, try to, cause what we call the regression of fibrosis or reversal of fibrosis. That's the aim. As you rightly said, we can't give them for years. So maybe 1 year or 18 months or 24 months, you bring down the fibrosis, continue with the lifestyle interventions. So that's the whole idea, so that the liver disease doesn't progress. The fibrosis doesn't progress. Where there is no fibrosis, no inflammation, the drugs in any way are not recommended. They are recommended only once you have fibrosis, and the idea is to bring that down so that your liver disease or the liver morbidity and the mortality doesn't go up.
Ajay, just as a continuation, does it mean that these drugs change from a rapid progressive state to a slow progressive state? You don't totally disappear the inflammation or fibrosis. I think that is one. And just the last question to Dr. Jain, how long can you give saroglitazar? Now, we've been using these drugs for so many years. So what is the maximum extent that you can give? And is there a place for 2 milligrams of saroglitazar once the enzymes become normal and lipids become normal? Just the last comment.
Good question. How long it can be given? Unfortunately, all the clinical trials required for approvals are about 1 year duration. So we have done the control clinical trials for 1 year, but we know for sure that in actual clinical practice, since the drug got approved in 2013, many patients are continuing the therapy. And we also know that, it's a very strong drug. So initially it was approved for dyslipidemia. So people started taking, and then in a month, the lipids came to bottom, and then they stopped. And then once they stopped, after some time, it went again. So they again started. So this is like on-off phenomena that we have heard from clinicians, that the patient stopped taking, and then they take it, and they again stop. So I think we know that it has been used for a very long time. That's one thing from clinical point of view. Now, from my non-clinical study, as for any regulatory approval, the regulatory agency asks for a carcinogenicity study to be done for a molecule. Now, that duration is about 2 years. For a rodents, 2 years is about 2/3 of their life, because their entire lifespan is about 2.5 years. So it's about 2.5 to 3 years. So about 2/3 of their life we have given without seeing any major effect, a major adverse effect. So the drug is safe and it can be really used for a long time. Although we don't have a clinical data to claim that, of course, we have always been talking about doing outcome studies. And I think once those studies are there and then the data comes, then we will know what happens to the cardiovascular endpoints and the other things, which I think those are large studies. So we have been planning those studies. But it's a
So if
safe
I
drug. So
may-
far, I think it can certainly be taken for a long time.
So if I may ask one question to Dr. Ajay.
Yes, ma'am, please.
Yes. Actually, I wanted to have your comment on the selection of the models one should use for the drug discovery programs. Because as we know, this is a multifactorial as well as a very complex disease. And while we are trying to treat, we actually do not want to treat steatosis. We are trying to treat inflammation and the fibrosis component, which is in fact, I don't know how the patients are going to be selected and only included in such trials. So our clinical trial designs as well as the discovery program, this type of conflict is always there. So I just wanted to have your comment.
Ma'am, I think you're absolutely right. That's why I said the animal studies cannot be, kind of converted into human data, because in animals, we try to use either, as I said, MCDD models, say methylene choline deficient. People have used high fat diets. People have used other models, right? So, but then this doesn't happen in humans. It's a multifactorial disease, as you rightly said. So there is a metabolic issues going on. There are genetic issues which are going on, the gut microbiota. And that's why now the hypothesis in fatty liver disease has moved from what we call 2-hit to a multi-hit hypothesis.
Yes.
So there's an oxidative stress going on. There's a gut milieu, which is a problem. So I think it's very, very difficult disease, and to have a single model, animal model, and then to design a drug is a very, very difficult. So ultimately it has to be human studies and the human data ultimately. But then, as I said in my talk, the human studies are very, very difficult to do, again, for the reasons which I said. And then the endpoints are also very difficult, histological endpoints and the clinical outcome endpoints. And you are using a drug which is actually acting on one pathway again, or maybe at the most 2 pathways. There's so many pathways, working this. So ultimately it boils down to lifestyle interventions only, and maybe control of the metabolic risk factors.
Thank you. I feel that metabolic enhancers will be the best option.
I think, thank you. And I think it's time for us to close this session.
Yeah.
I would like to thank all the 3 speakers for the wonderful talk, and my co-chairs, Dr. Anil Arora and Dr. Dixit. Thank you very much. Thanks to THST.
We request session chairs to kindly felicitate Dr. Ajay Doseja, Dr. Mukul Jain, and Dr. Rajiv Rai. We request Dr. Rajiv Rai to please come up on the stage. Thank you, everyone. We now request Professor Garg to kindly come up on the stage and felicitate the session chairs, Dr. Yogesh Chawla, Dr. Anil Arora, and Dr. Madhu Dixit. Thank you, sir. We now proceed for a tea break. The volunteers are requested to kindly disperse the audience smoothly, and we request everyone to kindly reconvene for session 3 by 4:05 p.m.
Welcome back, everyone. Please be seated. We are now commencing our final session for the evening, Drug Discovery Research at THSTI. We request Professor Sudhanshu Vrati, Dr. Anil Pandey, and Dr. Mukul Jain to kindly come up on the stage and chair this session. Professor Sudhanshu Vrati is the Director of Regional Center for Biotechnology, Faridabad. His expertise lies in the fields of RNA virus replication and vaccine development. Professor Vrati is an elected fellow of the Indian Academy of Sciences, National Academy of Sciences, Indian National Science Academy, and J.C. Bose National Fellow. In the year 2003, he was awarded the National Bioscience Award for Career Development by the Department of Biotechnology, Government of India, for his contributions in biosciences. Thank you, sir. It's an honor to have you here with us. Dr. Anil Pandey is the professor and the head of the physiology department at ESI Medical College and Hospital, Faridabad. Dr. Pandey is the recipient of 6 national and 1 international award and has published more than 40 research articles in reputed journals. Thank you, sir. We are glad to have you here. We request the audience to kindly reserve their questions until the 4th talk is completed. We request the speakers, since we are running behind the schedule, to keep their presentations brief.
Thank you very much, and welcome back to the last session for the day on drug discovery research at THSTI. We have 4 speakers in this session. Although initially they were allocated 20 minutes each, but considering that we are really running short of time, I would request them to restrict their talk to say about 15 minutes. I'm sure they would cooperate with us. So I would like to invite the first speaker for the day, Dr. Dinesh Mahajan, who will talk about efforts on therapeutic development at THSTI. Dr. Mahajan is a medicinal chemist and a drug discovery scientist at THSTI. Before joining THSTI, he was associated with new drug discovery unit of Ranbaxy and Sphera Pharma. 2 of his identified leads are under phase 2 clinical development and 2 drug leads are under IND. He's an inventor in 25 patent applications and has authored more than 35 research publications. Dinesh, please go ahead.
Thank you, sir. Thank you for the kind information. So without spending much time on the disease background, just to bring the context in place for drug discovery discussion. So NASH is a hepatic manifestation of NAFL. NAFL is a excessive fat accumulation in liver. NAFL patient can progress to cardiovascular complications and other complications also, but a limited pool of patients can have hepatic manifestation, which is known as NASH. There are 3 key hallmarks of NASH. One is lipid accumulation, the other is inflammation, and third is ballooning. So the research questions that we are trying to address at THSTI are these. So most of us are focused on these research questions. The one is how to distinguish NAFL and NASH with high confidence, with minimum invasive tool. What are the factors which dictate progression of NAFL to NASH? How sign of efficacy could be determined early in clinical trials? How to develop safe and effective pharmacological intervention for NASH with or without fibrosis? And is there a therapeutic role of herbal extracts in management or cure of NAFLD or NASH? So collectively, these research questions are in the domain of either prognosis or treatment. So my lab and my group is focused on therapeutic development. So for today's talk, I will stay focused on therapeutic development efforts that we are pursuing at THSTI. To start with the therapeutic effort, so we have 3 major approaches that we are focused here. The first is phenotypic screening for small molecule hit identification. So when I said phenotypic, so we have screening assays and screening models based on disease phenotype, which revolves around fat accumulation, inflammation, and fibrosis. So we use those study models based on these three key hallmarks of the disease phenotype for identification of new drug leads. The second approach is development of herbal extract. So once we have, standardized our models based on the disease phenotype, we thought why we should restrict only to small molecule. And let's start also exploring the traditional information available in Ayush literature on herbal plants and use their that information to bring new formulation based on modern drug discovery approaches. So, and the third approach is, which is target-based approach, where the idea is you already have various known targets available in literature. You have enough understanding based on their successful and failed clinical trials. Then why not to start a new drug discovery effort based on existing intellectual understanding of those targets? And let's have a quickly new drug lead generated in the lab. So for today's talk, I will stay focused on these two first approaches. But before going into detail on these two approaches, let's have a small understanding on these different kind of clinical trials and the understanding that we have from these clinical trials. So if you review the different kind of clinical trials, you will get to understand that the most of these trials are focused on three major key disease hallmark. One is lipid metabolism, other is inflammation, and third is fibrosis. And there is only one drug approved, as we learned from the today's speaker, saraglitazar, and all other drugs are either showed some effect in phase 2 clinical trial, or they are under evaluation in phase 3 clinical trial. So, and the endpoint that one needs for regulatory approval is NASH resolution without worsening of liver fibrosis and or histological regression of liver fibrosis at least one stage without worsening of NASH. So this is a tricky situation. So NASH is a multifactorial disease and is also a slow progressing disease. And the phenotype is not well defined even in human. And once you don't know the exact phenotype, it's very hard to translate that phenotype in your research labs and to do drug discovery. So the main challenge in preclinical drug discovery for fatty liver or NASH is to have suitable model for preclinical drug development screening efforts. So the labs at THSTI focused on in vitro phenotypic assay development and fat-rich diet-based animal models and their characterization in context to disease, human disease phenotype. So I will not speak about in vitro phenotypic assays. My fellow colleagues will talk on this in subsequent talks, but I will briefly touch on fat-rich diet-based animal models that we have at THSTI. So we learned from today's speaker that animal models and the phenotype is very complex in NASH. So there are certain key challenges, but there are some kind of understanding what kind of ideal model, animal model could be for non-alcoholic fatty liver or NASH. So we have now understanding that a suitable model should have a pathophysiological, a histological and physiological characteristic matching to human disease. So when I said histological character matching to human disease, the statuses should be macrovesical statuses. Inflammation should be lobular inflammation. And not only histological or physiological, we should have matching transcriptomic and metabolic profile also. And not only this omic profile, the model should be able to replicate the molecular pathway dysregulation, which is very similar to human disease phenotype. So most in humans, these are the pathways which are mostly dysregulated. So the combination of this complete profile would lead to an ideal preclinical animal model, but that is not easy to have. So if you look for the literature summary on the existing animal data, you will broadly categorize animal models in two clauses. One is diet-induced animal model, and other is genetically mutated animals with or without high-fat diet. So all these have some benefits and some disadvantages, but if you go into deep literature search, you will identify that choline deficient high fat diet, it replicates very closely with the human disease, and also the diamond mice model, which is a proprietary model developed by Dr. Sanyal with high fat and high fructose diet, is a closely matched model to human disease. So among these two models, the choline deficient diet and diamond mice with high fat, high fructose replicate transcriptomic and metabolomic profile of human disease also. So if you ask me, the diamond mice with the high fat diet will be an ideal model, and second to that would be the choline deficient high fat diet model. So choline deficiency actually impairs hepatic VLDL secretion, which lead to liver steatosis very quickly. And liver steatosis is supposed to be the first hit leading to NASH pathogenesis. So we replicated this model in our labs in black 6 mice. We fed mice with choline deficient high fat diet and monitor these animals for 10 and 20 weeks. This is the phenotype that we got. So we got increase in body weight, we got increase in liver triglycerides, both at 10 weeks and 20 weeks. We also got a very decent NAFLD score or NAS score. We also end up with significant increase in absolute and relative liver weight, and we also saw insulin resistance at 10 and 20 weeks both. But compared to mice in rat, we have a very limited phenotype where we could only see high triglyceride in liver. There was no insulin resistance and there was no body weight gain in rat. Based on this understanding, so we are also running a study where we are using three different kind of high fat diets with normal chow, and we have a plan to monitor the disease progression and phenotype at different time points of 4 week, 8 week, 12, 16, and 20 weeks. And we are planning to physiological characterization and other biochemical, histological, and transcript and metabolite profiling of this disease progression at different time points. So we are hopeful that this will be a kind of study which not only will give us understanding about the disease progression, but will also help us in defining a better animal model based on the kind of drug discovery program that we want to run. Either it's a small molecule or a herbal extract. So going back to the approaches that we have pursuing at THSTI, I will start with first phenotypic screening. As I said, phenotypic screening is a kind of screening where you have phenotype-based your screening assays, and you either screen random library of molecules, or you have some kind of rationale to start your screening efforts to identify a hit. So we have both the approaches that we are pursuing. So I will talk only about the rational approach. The other approach, my colleague, Dr. Ajay, will talk about. So in rational approach, we started with the question that, is there a role of autophagy inducers in fatty liver? And there was enough preclinical and clinical evidence. I will focus on clinical evidence. There are studies where people showed that patients with NAFLD, they have lower level of autophagy in their tissues and serum samples. And also caffeine-induced autophagy flux can have decreased risk of fatty liver, hepatic steatosis, and fibrosis. In preclinical study, rapamycin, which is a well-known mTOR inhibitor and autophagy inducer, showed various effect in various NASH models. So based on this rationale, we started a program of drug discovery at THSTI. So we started with a literature lead. We build on that lead. We started with medicinal chemistry effort. We synthesized few analogs and first screen those analogs on autophagy induction assays. And the potent molecule that we found out of autophagy induction assay, we put on phenotypic screening. For phenotypic screening, we use HBG2 cells insulted with free fatty acid. The idea was the treatment with your drug lead should manage to decrease the intracellular fat load in these HBG2 assays. And the potent molecules coming out of phenotypic assays, we also characterize their potency in various kind of cell health assays like mitochondria membrane potential, mitochondrial integrity, oxygen consumption rate, and also antifibrotic effect in TGF beta and FFA induced in vitro models, again in HBG2 and LX2 cell lines. So we identified a lead DR62, and based on our initial ADMPK efforts, we screened 5 molecules in microsomal stability, identified 3 molecules, then identified DR62, which was orally bioavailable. We synthesized a gram scale of 62, and we did rat and mice efficacy study at 2 different doses, but equivalent doses, 10 mpk rat and 20 mpk mice. So this was the study designed for rat study. We initially started with rat, as I mentioned, rat showed limited phenotype in CDHF-induced model. So upon treatment, so we saw significant reduction in liver triglyceride load in DR62 treatment. We have pioglitazone as a standard arm here. And we also did a kind of limited gene expression study in rat liver tissue. We found that upregulation of PPR alpha, which is a regulator of lipid metabolism in the treatment arm, in both the treatment arm in pioglitazone as well as DR62. We also see upregulation of ATG7, which is a autophagy marker in both the treatment arm. So we did efficacy experiment with same molecule in mice model also, and the mice, as we know, we have a better phenotype. Here we saw effect not only in liver triglyceride, but also on glucose tolerance. So those 2 effects were significant. It was a 10-week study. The mice were treated, were on CDHF diet for 10 weeks, and the treatment was started after 7th week for 3 weeks. So total 10-week study. Even in short duration of the model and short duration of the treatment, we were managed to significant effect on liver triglyceride as well as on glucose tolerance. So future plan, we don't know the exact mechanism, although we do have some understanding on the mechanism of DR62. The idea is we will do a better chronic model study, at least 20-week study, and then we will use tissue to do transcriptomic analysis. We will identify different molecule pathways involved in through that transcriptomic, and then we will try to validate those pathways with siRNA study to identify at least 1 target or 2 target. So the kind of studies that we have already done with 62, we are quite convinced it's not a single target molecule. We have a kind of polypharmacology that involved in mode of action of DR62. So moving to second approach, that is development of herbal extract for the therapeutic application. So here the idea is you use the existing Ayush information available in traditional books and try to validate that information using modern drug discovery assays and tools. So we started this program in collaboration with Dabur. So on the set of the program, we kind of decided on what kind of target product profile that we need to have for final formulation. So we decided that it should be a known traditional literature. The herbal plant should be known in literature. That means there will be safety known for human, and there will be a safe dose known for human. So, and we also decided that it should be able to lower TG, liver TG. It should not increase body weight. It should have positive effect on glucose metabolism, and it should be amenable to form solid doses, tablet, capsule, or chewable. So, and another important parameter, it should not induce any liver toxicity on chronic dosing. So with this target product profile, we started with our efforts. We selected a pool of herbs based on traditional knowledge and discussion with practitioner. Those herbs are well characterized, not only genotypically, but chemotypically also. So we know at what geographical area you need to cultivate those herbs. We know at what season you need to pluck those leaves, or you have to extract the bark from those plants. So that kind of characterization is already done by Dabur, and that was the uniqueness of this project. So we are at this step, we are evaluating efficacy and safety in our various animal models at THSTI. The idea is once you have safety and efficacy established, we will launch this as a Ayush product. And during the launch of Ayush product, you will also start collecting data on various clinical parameters on the fatty liver phenotype, and that will be used for global approval with all the sufficient information. So the current status is we have established collaboration. The project is funded by DBT and Dabur jointly. So the third I'm not covering, but here we started with the ASK inhibitor. ASK is a kinase. This was a typical MedChem project. We identified a hit, and then we deprioritized this project because of the negative news on phase 2 clinical trial on ASK inhibitor. So the summary, we have established an FLD model in mice using CDHF diet with complete phenotype characterization. That means metabolomic and transcriptomic. An animal experiment is in progress to study disease progression and phenotype induced by different kind of fat-rich diet. We have a, very detailed plan on this comparative disease progression and phenotype characterization effort. Identification of small molecule DR62 using rational phenotypic drug discovery approach. So we have planned to progress this molecule further for better understanding of structure-activity relationship and the detailed efficacy studies. Efforts on therapeutic development in progress for traditional Indian herbal plants, where we will not go for cure, we will go for the management of fatty liver. Thank you, thank you. So these are the students who actually contributed to the study. Dr. Ajay and Dr. Ruchi, they contributed on in vitro side. Dr. Jashwant helped on metabolomic side. Dr. Sanjay Banerjee, he actually started with the animal models, and then he transferred this to my lab. Dr. Rajni Jadhav helped on all the histopathological study. Dabur India is a collaborator and funds from THSTI, DBT, BIRAC, and Dabur. Thank you, everyone.
Thank you, Dinesh. I think we will take questions towards the end of the session altogether. So I would like to invite the second speaker for the session, Dr. Ajay Kumar. He's going to talk about in vitro cellular models of drug discovery in NAFLD. Ajay is a senior research scientist at THSTI. His research is focused on designing and establishing in vitro cell-based and in vivo mice models targeting disease phenotypes of NAFLD. Ajay, please.
Hello. Yeah. Good afternoon, everybody. Thank you so much, sir, for the kind introduction. So it's been a very learning experience today. I guess it has been for all. So I would quickly start the presentation. So basically, I would like to use this opportunity to showcase the models that we are working on, the in vitro models using various human cell lines, and we are also trying to identify some leads which can be eventually investigated in animal models. So, all right. So my presentation will basically talk about disease phenotypes, the phenotypic models, although very, very simplistic models, but yes, they are very important at the initial stage of drug discovery, where we have to evaluate so many compounds together. So we have to identify leads, and eventually those leads can be studied in more depth in specific models. Then there is the drug discovery pipeline, the efficacy studies with herbal extracts and the small molecules, and then the ongoing grants. So as we have already been informed about the disease progression in NAFLD, here I'm only introducing the three specific disease phenotypes. The steatosis basically is the excess lipid accumulation inside the hepatocytes. So excess lipid accumulation eventually triggers inflammatory response, and this inflammatory response over a sustained period of time triggers the fibrotic response. So I am particularly working with human cell lines. So we are using HepG2 cell line to represent hepatocytes, the THP1 cell line, which is a monocytic cell line, that is being used to investigate inflammatory response, and LX2 cell line, which is basically representing the stellate cells, is being used to target the fibrotic response. So these three specific models are currently in place in the lab. So all the investigations using the small molecules or herbal extracts, we are basically using the preventive model. In preventive model, the cell lines are first treated with the extracts or the small molecules for a duration of say 30 minutes to 1 hour. And eventually the cells are triggered with phenotype specific triggers. Say in case of steatosis, we use 3 fatty acid combination conjugated to BSA. For inflammation and fibrosis, we are using LPS. We are also using TGF-beta for fibrotic response. So the endpoints that we are looking at are the cell viability using MTT assay, lipid accumulation using Nile-Red DAPI staining, which is a fluorometric based endpoint readout, lipotoxicity again using MTT or LDH assay. The inflammation and the fibrotic response is being chased using gene expression studies using RT-PCR, targeting specific markers, gene markers for the respective phenotype. So firstly, I'll talk about the steatosis assay. So this assay it has been developed in HepG2 cell line. So as we can see in the images which are projected, so there is even in the control cells, the upper image shows the red spots which are oil red stain, and in the lower image, the blue stain represents the DAPI dye, and green is the Nile red dye. So both Nile red and oil red O stains, they basically they bind to the free lipids inside the cell. So in control cells, even there is sufficient amount of lipids present. So when we trigger these cells with free fatty acid mixture, so we can see the accumulation of the lipids inside the cells increases significantly. So over a duration, over a gradient of FFA concentrations, the accumulation increases. So what my assays are basically looking at, lipid accumulation and the cell viability. So we intend to identify candidates which reduce the lipid load inside the lipid-induced hepatocytes, and also the other condition should be that they should not have any adverse effect on cell viability. So this is one assay. The other two assays are inflammation and fibrosis in THP1 and LX2 cell. Again, the gene expression markers we can see as compared to DMSO treated cells, MCP1 and TNF alpha was significantly increased in THP1 cell. MCP1 and TNF alpha both are pro-inflammatory markers. And in LX2 cells, again, collagen 1 and MMP2 gene expressions were increased in TGF beta treated cells as compared to the control cells. So using these three models, we are into the drug discovery process. The drug discovery pipeline basically includes the herbal extracts or formulations which are provided generously by the Dabur, which are our collaborators. So the other are the new chemical entities. Basically, the new chemical entities are designed in-house by my colleagues, Dr. Dinesh Mahajan and Dr. Shailendra Asthana. And also we are evaluating drugs which are already approved for other diseases. So we have commercially available libraries available with us, and we are evaluating those drugs in our disease models. Eventually, we want to identify compounds which can be investigated in animal models. So this is just a cartoon of 11 well-characterized herbal extracts which were used in the herbal screening study in collaboration with Dabur. There were 2 herbal compounds and a polyherbal formulation, Hepano. So all these extracts were screened using our in vitro models. And as we can see, for all the 3 phenotypes, there were some extracts which showed some efficacy, while there were others which showed no efficacy or very little efficacy. So all these extracts, after being evaluated in vitro, we eventually started the in vivo study. So here I am sharing a snapshot of the study where we used the animal model to compare saroglitazar and Hepano. Hepano is a polyherbal formulation from Dabur. So it's already marketed for hepatoprotective efficacy. So the mice were first fed for 4 weeks on both with chow and HFHF. There were 2 groups, one on chow and the other one was on high fat, high fructose diet. So after 4 weeks, the treatment with saroglitazar as well as Hepano was initiated for another 8 weeks, and subsequently after 8 weeks, the mice were sacrificed. As we can see in on the left-hand side, the body weight increased, while in case of treatment conditions, both saroglitazar and Hepano showed reduced body weight. Regarding the insulin sensitivity, again, there was some corrective effect in presence of both saroglitazar and Hepano. So looking at the histopathology images, so the liver color changed significantly in animal model, HFHF treated animals. So when we treated them with saroglitazar or Hepano, the color reverted back to its normal type. ORO represents the steatotic condition. So again, as compared to the disease model, the steatosis was significantly corrected in presence of saroglitazar as well as Hepano. In H&E stain represents the ballooning part, the inflammation part. So again, the inflammation was also corrected in presence of both saroglitazar as well as Hepano, and we observed no effect on fibrosis during the duration of 12 weeks of HFHF diet. So therefore, we could not really evaluate these molecules for the fibrotic phenotype. So towards the right-hand side, we can see the various scores for cytosis, inflammation, lobular inflammation, ballooning, and overall NAS score. So they all depict the corrected phenotypes in these things. From the list of 11 herbal formulations, so Sharpunkha and Chiraita both showed some significant efficacy in this model, in this HFHF head mouse model. So towards the images which are visible to you right now, they represent the results from Sharpunkha study. So there was a corrective measure in insulin, in IPGTT, body weight, fasting blood glucose, as well as hepatic triglycerides. Also, as compared to the disease model, Sharpunkha showed correction in steatotic score as well as ballooning. So again, in case of Chiraita, we had similar results. There were corrective efficacy in presence of Chiraita as well. So then we have the small molecule screening. So in this case, we have almost 70 molecules which are synthesized in-house using medchem approaches, and around 22 molecules which are synthesized using biophysical approaches. So, and there's a drug library which has almost more than 3,500 compounds, which are eventually being screened using the existing models for phenotypes, disease phenotypes. So as we can see from the medchem approach, from the molecules which are designed using the medchem approach, we have obtained two separate leads, DR62 and DR176. So far, they have only been investigated in the in vitro models, and the animal model studies are being planned. So in vitro results clearly depict correction in lipid accumulation when treated with the DR62 as well as DR176 as compared to the vehicle bar. So again, in case of MCP1 and TNF-alpha, which are inflammatory markers, there was a significant amount of correction in both of these, with both of these molecules. Using the from the screening of compounds which are synthesized using biochemical approaches by Dr. Asthana. So we have identified 3 molecules, A03, C06, and C04. So again, as we can see, there was correction in lipid accumulation, MCP1 gene, and collagen 1 gene using for C04 and C06. Whereas A03 showed correction only with fibrotic marker. So these are the shortlisted compounds so far from the small molecule libraries that we have screened, and we are currently planning the animal studies for some of these. So the next set of molecules that we are screening is the reposition drugs. So the FDA approved library that we have contains over 3,500 compounds. So if we look at the clinical information available for this existing library, most of the compounds, around 66%, are already launched for some diseased condition. There are others which are in phase 4 trial, phase 3 trial, and phase 2 trials. And if you look at the distribution based on the disease area, around 30% of these compounds are targeting some sort of cancer. Then there are targeting infection, neurological diseases, inflammation, metabolic diseases, and so on. If we look at the pathway distribution of all these compounds, the majority of them represent anti-infection and cell signaling pathways. Then there are apoptotic and metabolic pathways, membrane transport, autophagy, and so on. So so far we have already screened almost 50% of these compounds for their anti-steatotic activity. So we have got around 53 compounds which are showing anti-steatotic activity, and the distribution, the disease area distribution of these 53 compounds are cancer, infection, inflammation, neurology, as well as metabolic diseases and CVD. And that's a brief snapshot of the list of all the compounds that are showing anti-steatotic activity. So, so this is another study that is going on in the lab. Okay, the effort in this study is basically to improve the existing in vitro models that we are using to screen small molecule libraries or the herbal libraries. So the thought here is that if we compare the existing cell line models with the primary cells in both FFA treated condition as well as the untreated condition, and then eventually target the proteome as well as the metabolome of these treated cells these primary as well as cell lines, we would like to identify the proteins that are common in both the cell types, the primary cells as well as the cell lines, and those proteins which shows differential expression in the two treatment conditions, they can further be used for targeting in our in vitro models, in the simple models. So the idea here is to make our cell line models more physiologically relevant to the disease condition. Currently, as we all know, we must be aware that the cell lines basically change their phenotype or have a tendency to change their phenotype or genetic makeup over a certain number of passages. So in order to maintain reproducibility and dependability in these cell line models, this particular effort could add value to the existing in vitro models. The other study that has been recently granted by DBT Biorec and is in collaboration with Dabur India Limited. So again, we wish to investigate fat-based diets, different fat-based diets, which is high fructose, high fat diet, and choline deficient high fat diet in mice model to track NAFLD phenotype development. So in this study, we will we are extending our model from 12 weeks to 20 weeks. Earlier model that we have used was only for 12 weeks. So in that case, we could not really develop the fibrotic phenotype. So here we are expecting that over a duration of an extended 8 weeks, we will be able to get the fibrotic phenotype. And we also wish to identify an intervention point, which could be either 4 weeks or 8 weeks. And based on the this identification of intervention point, we will start the treatment for various herbal extracts as well as our small molecules eventually. So the effort here is basically focused to develop a herbal formulation for treatment and or management of NAFLD using this diet-based model. So we will pick the best diet which can actually develop all the 3 phenotypes, and then that model will be used to identify to investigate the efficacy of these herbal extract combinations. So the other idea is, as Dr. Jain had already mentioned, we intend to use labeled palmitate in our cell models and eventually try and chase palmitate for the synthesis of lipids inside the cell lines. So we will use that model. It's already been published. So this model we will be using to screen our leads that we identify from our basic screening for their effect on palmitate synthesis. So finally, I would like to acknowledge and thank ED sir for giving me this opportunity. My colleagues and contributors, my team, Deepika, Vidhi and Anshita have contributed to this data generation, and my collaborator, Dabur India Limited. Thank you so much.
Thank you, Dr. Ajay. Thank you very much. I will now pass on this responsibility to my co-chair, Dr. Jain.
Thank you. I think the next speaker is Dr. Ruchi Tandon. She will be talking on 3D spheroids and organoid culture in drug discovery and research on NAFLD. So I want to introduce Dr. Ruchi. She is a drug discovery scientist at THSTI, and she has more than 16 years experience in the field of metabolic and inflammatory disorders. Before THSTI, she was working as assistant director and group head pharmacology at Daiichi Sankyo Pharma, where she led the R&D portfolio of drug discovery programs for their preclinical development. And it's not mentioned, but I know that she had previously worked with she was in Ahmedabad and worked with Torrent also. So good drug discovery experience she has. She has 25 publications and 2 patents as well. And here at THSTI, she's working on both targeted and non-targeted approaches to identify potential therapeutic options for NAFLD. So with that introduction, I would request Ruchi to proceed, please. Thank you.
Thank you, sir. So preamble of my presentation comes from the 2 talks which we heard in previous session from Dr. Tuseja and Dr. Mukul Jain, where they had discussed about the predictability and the failures and challenges in developing the discovery drugs for NAFLD. So this we have seen also in the drugs which had gone up to later stages of phase 2 or phase 3 in the clinic, and then they were withdrawn or were taken from the market due to several toxicity issues. Like Ferrodine, which was a drug approved initially for hepatitis B. It was tested in clinical trials in 15 patients, and 5 patients died because of severe liver toxicity, and 2 of them had gone liver transplantation. So severe toxicity was observed in liver for this drug. And similar was the case for Proglitazone, which was launched more than 20 years ago, and then it was withdrawn because of hepatotoxicity issues. Similarly, there were other drugs. However, there was drugs in the similar class, like Proglitazone was PPAR alpha gamma agonist, and so is the Pioglitazone. But similar kind of toxicity was not observed in case of Pioglitazone, at least in terms of liver. And this was reviewed in Nature Reviews and also recently in the publication, where they had tried to see what could be the possible reasons for the toxicity of these molecules and whether anything can be done to really prevent this at an early stage so that we can prevent the huge revenue loss and also avoid the fatalities. So as we see here, Ferrodine and also like Proglitazone, where they were tested in the 2D models using hepatocytes, even these cells were primary hepatocytes. Up to 14 days of evaluation of toxicity, they did not come up with any warning signs of toxicity in these models. However, the same drugs which were then evaluated in 3D models in this 3D environment, then they had started showing toxicity starting as early as 72 hours of time. So this is really concerning, whether what we need to do really to have an early assessment, and whether we need to really pay attention to our models, which we are looking at for evaluating our molecules and then taking them further for their further development in clinic or maybe initially in the animal models. So what are the current issues? The current issues we have at our hand is there is no in vitro or in vivo model which clearly mimics the liver microenvironment. Cell lines which we really use, they do not actually express all the functional markers of hepatocytes, which may be the reason we see the poor translation of in vitro to in vivo findings, and also the translation of in vivo findings to clinic is also lacking. So what can be done? As we see here in case of the NAFLD is this advancement of steatosis, which is fat accumulation to NASH. But it is not only the hepatocytes, it is the interplay of several cell types which are available, which are playing interplay in the liver environment. And not only this, there are other metabolic tissues like adipose tissue or muscle. And now we have the information from gut microbiota also. So they all work in synchrony to really get something which we may not be able to predict if we really depend on one conventional model. So what can we do to accommodate these complexities? We now recently have seen advancement in the technology where people have seen developing several models where we can use starting from 2D culture, monoculture to 3D monoculture or co-culture involving several cell types which are present in the liver, or even going to the more fascinating way of having a body on a chip. So our key objectives for NAFLD is to develop robust in vitro models which can mimic in vivo conditions as early as we can, so that we can reject molecules early at hand and we can avoid timing to see failures later. And then we can also increase our chances of predictability in subsequent advanced models. For the in vitro screening model, we can depend on initially in the conventional 2D models where we are having HepG2 cells, and then we, as we discussed earlier, we treat them with high concentration of fatty acid and we see accumulation of fat, and then we see there is a steatosis happening. But if we want to really incorporate more number of cell types, we try to see anti-fibrotic activity using a co-culture model, which was of course 2D here, where we had used HepG2 and LX2 stellate cells, and we had seen with regard to the fatty acid challenge, there is an increase in the level of fibrotic marker alpha SMA, and the three most advanced classes of molecules like PPAR alpha gamma molecule, which we have seen saroglitazar, or ASK1 inhibitor, selenosertib, or obeticholic acid, these three molecules had shown reduction in the fibrosis. To address the inflammatory component, we had developed a co-culture model using hepatocytes and also differentiated THP1 cells, which represent the macrophages. And here we have this transfer system, which allows the migration of these differentiated or maybe differentiated THP1 cells to the lower side of the chamber, so that we can have an environment which have the influence of both the cell types. And then when we tested these three classes of molecules here, we saw their inhibition of inflammatory activity of these molecules after a fatty challenge to these cells. So as we see, like we have learned the lesson from toxicological study, like in 3D model, we could predict, we could catch the toxicity potential of the molecules which we failed later, also we spent a lot of money. Their 3D spheroid model was quite predictive to a relevant level. So then we tried to develop this 3D level, where a 3D model using spheroid condition, where these HepG2 and LX2 cells, they were grown in ultra low attachment environment, so that this kind of phenotype we are observing in our cells. And then we observe these cells after drug response, and also the fatty acid challenge for their size and granularity. And we also looked at the levels of hepatocyte functional markers, because these are the markers which tell us about the functional role of our cells and whether these are the right kind of cells or not. So, and also we also looked at the various markers of lipid metabolism. And then after obtaining these results, we conducted a correlation study using 2D monoculture and 3D co-culture. We also tried to build a correlation between in vitro and in vivo findings. So, and then we try to study all these anti-steatotic, anti-fibrotic, and then anti-inflammatory activity of our compounds in these assays. So here, as we see, like compared to 2D models, when they grown for similar amount of time, it was the 3D models which actually express the high levels of functional markers of hepatocyte, which and also like albumin or CYP3A4. And also like other markers we further wanted to confirm, like ApoB and HNF4. These are the functional markers which suggest the functionality of hepatocytes. So compared to 2D cell culture models, the expression levels of these hepatocyte functional markers was much higher, to convince us that maybe we should be really relying more on these models for our further studies. And similar was the case for the markers of lipid metabolism. All these markers of lipid metabolism was much higher in 3D spheroid models compared to the 2D model. So after having these convincing results, we further went ahead and evaluated some of our herbal extract. We first evaluated, we challenged these spheroids with high concentrations of fatty acid, and then we have seen there is increase in the level of COL1A1, alpha SMA or TGF beta, and hepanov, which is a molecules from Dabur. It decreased the levels of COL1A to a significant level, and here we have used saroglitazar as our positive control. In addition to hepanov, we also evaluated molecules from Hayush study, and we had evaluated several molecules in these assay, and selective molecules had shown inhibition of these fibrotic markers, COL1A1, TGF beta, or alpha SMA. So in order to really set up and have confidence in vitro and in vivo correlation with respect to our 3D models, we compared the findings of these functional markers for both hepatocyte function as well as lipid metabolism with these mouse models. In this mouse model, we challenged this C57 mice with high fat and high fructose diet for 20 weeks. And then apart from these basic parameters, we do to test the glucose metabolism and all the hepatocyte parameters, biochemical analysis and gene expression studies. We looked at the levels of these two key component of our cell-based assays. One is like hepatocyte markers, and also second is the lipid metabolism markers. As we see here, compared to chow diet, HFHF model, they had shown high levels of LIPA and SCD, which are the markers of lipid metabolism. And then when we try to compare it with the 3D spheroid model and 2D spheroid model, so there was quite a good kind of correlation occurring. So then we went ahead and then looked at more markers, like in CD36. We saw there in compared to CHO, there is high expression of CD36 in HFSS model, but similar observation we could not see in case of either of the 2D or 3D models. So what we can do? So there still exists a challenge which we need to troubleshoot. It is not a secret anymore that the hepatocytes which are derived from humans, which are the human hepatocytes, they are considered as the gold standards. We all are aware of that, but there are severe limitations in availability of these samples, and also they have limited lifespan. Even if we try to get small amount of samples, we cannot grow these cells for long term, maybe few days, and after these cells they start dying. So what we can do to overcome these issue, we were inspired by the findings which Hans Clever has reported just a few years ago, where they had used the tissue sample derived from humans, and then they tried to develop into the cell culture models, and they developed into the organoids. What is happening with the limitation which we are seeing with our either 2D model or 3D model, we cannot grow them beyond few days or maybe a week. But beauty of developing these organoids is they can be developed even for months. So we tried to look more into this, and then we started seeking the ways to really obtain the tissues from human samples. And of course, there are ethical guidelines we had to follow, which we were following. But meanwhile, we thought we paid more attention to the technology and also the science behind it and how we can utilize it to our interest. What we had seen, like in livers, these are the oval cells, which are actually the precursor of this epithelial, two types of epithelial cells, which are occurring in the liver, which are the hepatocytes, which are actually the monopotent hepatocytes, because they do not really further grow much. And then that's why we have the limitations with them. And then at the same time, we have bipotent bile duct epithelial cells. These bile duct epithelial cells, they are bipotential cells, which actually are the cells which have the stem cell kind of properties by having this stem cell marker, which is LGR5. Because of this stemness, these bile duct epithelial cells, they have the potential to grow in culture, and we can actually make use of these cells. Either we can use them by sorting, or we can allow them to grow in a defined medium so that these bile duct cells can overpopulate over the hepatocytes, which are the monopotent. We use the defined medium like R-responding, which is the agonist for Wnt signaling, and also which is actually the promoting the embryonal development and responsible for the stemness feature of these embryo to develop them further into the hepatocytes or the liver for the tissue. We also, and another important component here is the TGF-beta inhibitor, because TGF-beta is responsible for epithelial to mesenchymal transition. So we wanted to really have a way to really stop differentiation of epithelial cells to further so that we had used these inhibitors, so that, and then we had seen these liver organoids which we could develop in a matricial environment, and then we tried to organize and define this medium further, and we have conducted this in our lab, and then we had grown these organoids further, because organoids are only for expansion, and so that we can populate them further and store them, and then we can use them later whenever we require the cells for our development using primary hepatocyte kind of work, we can further differentiate them into hepatocyte kind of behavior. And then we stop TGF-beta inhibitor here, and then introduce all these supporting recombinant proteins, so that these organoids can further differentiate into hepatocyte. So for this, there are 3 steps which are really important to us. First is we reach hepatocytes.
Dr. Ruchi, please summarize quickly.
Okay, so we have organoid initiation, expansion, and then differentiation. So this is the experiment we had done in the organoid initiation, where we had seen the organoids growing, and then expansion. And we see here, like these organoids, they start budding. As early as starting from day 4 or 5, we see these buds occurring. And then when we try to stop their expansion, and then we try to allow them to differentiate, we saw them differentiating. So, and this we had further captured in the same screenshot. We had seen on day 7 to day 10. These are the budding organoids in the expansion mode, and then with the differentiating hepatocytes, we saw the differentiation. Looking at the image was convincing, but we wanted to be sure by looking at the functional markers again. The markers which are responsible for the differentiating cells, which are the Ki67. We had seen like mature hepatocytes, which we used in the beginning. They had plenty of Ki67, but organoid culture lost these Ki67 because they were not allowed. And then after differentiating them further, we regained these markers again. And then same was the case for ECTEN, which is the marker for ductal epithelial cells and also the marker for stemness. We looked at the markers for hepatocyte function, and then we had seen we lost them in the liver organoid, and then we gained them back because it's the initial few days culture after differentiation. So we gained them these functional markers back. Similar was the case for other functional markers like SOX9 or HNF4. So to summarize, like at THSTI, we have developed 3D spheroid and organoid cultures, and then we are in a state to utilize them for our drug discovery efforts. Or these models can also be useful to conduct basic research on NAFLD and its progression to NASH. And we can use both mouse as well as human liver biopsy samples for this. We can use them for drug sensitivity studies other than NAFLD also. And they can be useful for regenerative and transplantation studies to restore liver function. At HSTI, as we have discussed in last couple of presentations, we have the dedicated drug discovery approach, and for using both targeted and non-targeted approaches. And for targeted approaches, we are working on these 3 targets. And then we have initially actually started using our spheroid technology to evaluate these molecules and also the herbal extracts for these assays. And since we are now ready to use the organoids, we have plans to use these assays for this also. I would greatly acknowledge Professor Pramod Kumar Garg for having confidence in me and giving new challenges. Professor Shalimar for clinical support and coordination. Dr. Madhu Deshit, Professor Sujata Mahanti for stem cell related work. Professor Shinjini Bhatnagar for her help in working with fetal liver samples. My comrades in the lab, and this work, none of my work is possible without their tireless help, like Yamini Gautam, Fulbanti Sharma, Dr. Ruby Bansal, my interns, Lokesh and Akash, and the entire NCD interdisciplinary team, which are always helpful for all these interdisciplinary studies. Thank you so much for all your kind attention. Thank you.
Thank you, Dr. Ruchi. And we have the next topic, computer-aided drug discovery. And the speaker is Dr. Sailendra Asthana. I congratulate previous 3 speakers because managing the time well, they finished their topic within time. And I expect Dr. Sailendra also to do the same. Dr. Sailendra Asthana has PhD in computational biophysics from University in Italy. He was a drug discovery expert at National Drug Discovery Hackathon 2020 platform for COVID-19 initiated by Office of the Principal Scientific Advisor, Government of India. He has authored more than 60 publications and is an inventor in 8 patent applications. So now I request Dr. Sailendra to deliver his topic. Thank you.
Thank you, sir. It was nice introduction. And thank you all. Most of them are waiting to finish this session. Actually, it's the last session. But since morning, if you are listening about NFLD, so what the key message we got till now? So drug except saroglitazole, we have no. Mice model, we are debating. In vitro, there are multiple options, but still none of them is the most promising, you can say accurate. So I'm taking you all to another modeling areas in which we are predicting, which is hypothetical, but have a strong strength now with the help of very pharma industry and the artificial intelligence and computational efforts during COVID time. By that, the advanced computing can deliver 4 candidates in a year into the IND studies and 2 molecules in phase 1 clinical trial, and where this computational study and support is phenomenal. So what is the intention of this? If you see my title, computational driven drug discovery. So the intention of this and the purpose of THSTI team to establish a platform by which in between all these nodes and more effort and more debatable, because they are very challenging and very complex. If you're talking about clinicians, they are challenging. The biology is challenging, basic science, there are lots of problems. So if we accelerate at least one area, and the area is, if we have a multiple pool of small molecule that have a capacity to have a lead-like character, by which you can take those lead molecule to try against your target, and that we can accelerate the pace. And that is the opportunity where people can do to accelerate the most time consuming step of drug discovery, to have a pool of databases to accelerate this process. I would like to emphasize one more important stuff, that why computational stuff is needed. That the reality is we are in the era where data is generating so enormously, huge data we have, but we are lacking about the analysis part. So analysis, generating the data is very important, and that you with accuracy and robustness. And in that area, with the help and the vision of our director, we are doing effort to establish a platform which can have not only impact of the curating, analyzing the data, but also to translate those identification towards the translational aspects. So in these aspects, we are working hard to establish these platforms. And now this picture depicting how strongly we are building this area. So we are incorporating computational biophysics, where we are including the proteins natural behavior. What is mean? Most of the time when we are talking about even the saraglitazole is PPAR. Even if you talk about obeticholic acid, it is FXR. If we talk about the selenosertib, it is ASK1. So what are these? These are the targets. And the targets are most of the proteins. And the protein never will work in a static manner. Protein always work in a dynamic fashion. So if a medicinal chemist try to approach by using a crystal structure, by dealing with few amino acids, the possibility to failure is very higher. And in that aspect, if you capture the time consuming steps, which is the translational towards the multiple state of a trajectory of a target, that computationally feasible. So in that aspect, computational biophysics is very important. Then we are doing the mining with the structures and co-crystal structures to get the information. And then we apply the computational tool, computational chemistry, and these aspects to get these information, which is we call informatic research, and to translate those information with the help of clinician, basic bioscientists, and medicinal chemistry to accelerate towards the translation. So these are the very broad theme which we are working on to establish a complete platform. The aim is to accelerate the pace. Now, this is the recognition process, which is the basis of all the process. So we are basically working by considering all these four domains: protein ligand, protein DNA, protein peptide, and protein-protein interaction. And we are using advanced methodology like peptidomimetics and generating those pipelines so that we can accelerate the pace to identify potent hits. And with this combination, to move towards hit to lead and lead optimization. Now coming back to why we are talking about the NFLD. So as from our colleague, you talk about that we are working basically on two targets: fernoside X receptor, and where we are looking for the agonism, and another one is the ASK1. We are looking for the inhibitor. So these targets, if you see, do you think this is, I'm taking only the FXR monomer state, which is here is the ligand binding pocket by crystallography, and this is a co-repressor site. But these are not static image. This co-repressor, when it binds partial agonism here, it is highly dynamic in nature, and the recruitment of this co-activator and co-repressor induce lots of changes, which I will talk about later. And if you see this structure, ASK1. So I would like to draw your attention here. This is the, in yellow, this is the domain where selenosertib bind, which is an ATP competitor, bind here, inducing lots of kinase related activity. And in people who are designing based on ASK1, they are not talking about all these domains. And what about these disordered zones, which are involved in signaling? So if you are not considering all these aspects, designing the high chances of designing your molecule means if you're lucky enough, you get the result, but the chances to failure chances increased extremely high. So our objective is two-way. If you have to target a protein which is FXR, so we are having approach binding site specific architecture where we can optimize and use the conformational changes in the inside the binding pocket and their substrate binding pocket. And if you have a target like ASK1, then we have a protein-protein interaction approach. Why? Because targeting catalytic site of ASK1 protein, selenosertib already drove in phase 3 clinical trial. So as I said, this mechanism is an on-off mechanism, and it depends on highly switch on, switch off behavior based on the other physiological and pathological condition of the system. And the system is our body. So based on their different parameters, how this on-off mechanism work, it's important to understand how this flexibility happen. So this is the work we communicated last year, and this work in which we are talking about the binding pattern between the co-activator or repressor site is very important to guide the effect of agonist. So agonist binding site, which is just adjacent to the co-activator binding site, the direction and the area behind that is actually modulator, and the key residues, these are the residues which actually belongs to the different loops, playing a critical role. And based on their co-activator positioning and based on their agonistic behavior, this synergy is very important to translate for and to utilize for the designing part. Furthermore, the second important aspect, which is inside the inside binding pocket, how many waters are there? Because water molecule, which is very essential for the designing point, and in generally most of the time it's ignored, and the reason is it dropped the, even if it significantly dropped the effect and efficacy. So a role of water is very important, and I would say when people design this role of water, they should be counted into the designing for the small molecule. Third aspect which I wanted to highlight here is the dynamics and with the direction. So what happened in general, the protein system, when it interact with partner A, and when another case, when it interact with partner B, the direction and the motion change because of the internal intra-signaling. So we are talking about the signaling in our system, but that signaling also exists inside the protein via networking with the amino acids. And that networking we should know, especially when it is deal with the binding pocket area. So you can see when we are talking about the different state of those FXR proteins, their dynamics and their directions are changed. And that dynamic and direction is very important when because that direction impact on your binding site architecture. And when your binding site architecture change, it will affect on your drug or agonist designing. So based on the changes on the architecture, we focus on which kind of amino acid is critical. And now the most important thing is talking about the community and network. So if you see these two are the state where we compare the changes in between partial agonist and agonist. You see, this is the area which is very important for nuclear receptors, that the recruitment of co-activator and activator. And you see here, these are completely tightly bonded. In case of agonist, you see this is the network where most of the residues are common, but the residue which I highlighted here is the reference, and these differences are significantly hamper the recruitment of co-activator and activator, and that is responsible for the agonistic behavior or partial agonistic behavior. So these kind of residual information is very essential, and why, how, and which direction these residues are aligned for agonistic changes, and that signaling responsible for the effect, a target specific biological effect. So at the end, based on the literature, ligands information, based on the structural information, we have established this pipeline in THSTI that if we have the ligand-based approach or target-based approach, we can screen those kind of information. So a structure-guided approach along with the virtual screening, we have established this pipeline, and based on that, we followed the molecular dynamic simulation. So this screening process is highly dependent on the variability, which is largely dependent on the chemical space, then protein biological space and their dynamical space, ADMT property to reduce the toxicity also, and then based on thermodynamic profiling, we can correlate our data with the existing biological results in form of delta E, IC50 values, and KD. And then based on biological research and with this result, as Dr. Ajay talked about already, we have identified 3 different class of compounds, which looks very promising because they are active, not active only on fibrosis, but in the lipid accumulation and others. And we are looking forward to move for the animal studies. So these are the success rate. And another interesting target which people talk about, this ASK1 protein. This is also for us very challenging because catalytic site is not working. So if it is not important for catalytic site for move towards the reducing the fibrosis, this ASK1 protein is still very, very important to explore further. The reason is it is related with the C-zone pathway, P38 JNK pathway, which is highly responsible for the anti-fibrotic behavior. And the ASK signaling markers and pathway indicating that if we modulate somehow this ASK1 protein, the effect of effect of this protein modulation on fibrosis is phenomenal. So we still stick with the this protein, and rather than conventional approach, which is actually targeting the catalytic site, we narrow down all the possible leads here, and the story about selenosertib, that why this catalytic site stories fail. Because success we can monitor, but the more important thing is if we fail, why we fail. So what are the reasons possible behind it, so that we are not following the same route. To know the failure here, we first narrow down all the details after discussing with the clinicians, after reading hepatological journals and others. We find out that the possibility to failure is the treatment time as well. The reason is not exactly the post-translational modification take into the account. And the other reason could be the impact of ASK1 fibrosis, because other domains were not considered except ATP. And ATP binding site involved in other kinome profiling as well. So might be a reason to be a toxicity. However, I got to know from the literature that they have performed the kinome profiling, but the major issue with the selectivity. So considering all these issues, we have a picture that, okay, don't target catalytic site, but is it possible to explore this target via using PPI approach? Because PPI approach can be a possibility. And the paper back to back came into the hepatology in Nature Medicine and highly underscore the possibility that if someone want to explore via PPI approach, that could be a better approach for anti-fibrotic effect. So with this aim, we dig out all these information with the help of this paper published in Nature, that what are the possible proteins to explore. And we got this information and we narrowed out this picture. What are the possible regulators? What are the negative regulators? This information is very important because they are indicating our approach. And this approach is where we are not directly targeting ASK1. So we are not touching ASK1 when it is not in normal state. When we are only dealing with when it is in hyperactive state, which is the first indication of the fibrosis or NASH related property. And in that aspect, if it is hyperactive, what are the negative regulators which can modulate this, and what are the positive regulators via PPI approach? And in this direction, when we started working on it, we focused on those targets by considering not only those protein are interacting domains, but their post-translational modifications also. But as I got to know that one of the reasons of the failure of the selenosertib is not considering those PTMs. But here is the drawback, because we don't have the crystallographic information. If we don't have the crystallographic information, we have to go for the molecular modeling. Hypothetical model is the good enough to start working, and now they are robust enough also, but still they are model. So here we are trying to understand what are the best approach to establish the full model first, to understand, to proceed further for the protein-protein interaction analysis. And based on that, we established this network of the ASK1 and their other proteins. Not they are the best part is, these are those proteins which are involved in the modulation of ASK1, sharing the same interface, but not the ASK1 proteins. So we get the information regarding what are the proteins which are involved in the interaction, what are the amino acids which are critical for the interaction based on their types of interaction, either hydrogen bond or hydrophobic. So, but they are not directly involved with the ASK1. So what are the advantages here? We are not directly touching the ASK1, but we are able to modulate if we are get the interacting peptide with these substrate, which are actually the positive and negative regulators of ASK1. This work has been just got accepted in CSBJ. And based on those information, we an interaction map and mapping, we generated those peptides which are actually giving a positive score based on they are just binding on the interacting partners of ASK1. They are not touching ASK1. So their off-target issues are limited. They are binding to the substrate, and those substrate which are actually toxic in case of a pathophysiological condition because they are highly upregulated, and we want them to be down. So if we want to reduce them, we have two benefits. First, we are reducing those regulators which are highly upregulated, and second thing is we are not touching ASK1. So in both scenario, we are in the advantage, and these are the circle peptides which are looks very promising in the computational aspects. We are doing the in vitro analysis of these peptides, and we are hoping that we get some promising results to move on further. And at the end, I would like to thank to my team. They are actually the people who are working, and they are actually behind all this work. The ASK1 work is doing by Ashish. He is a MK Bhan fellow. And the FXR work is doing by Anita. And the other members are doing other proteins which is related to NFLD, like Mrityunjay is working on SERTwins to understand the pathophysiological aspects and to explore these. I would like to thank to our executive director, sir, because he has a vision to establish a platform by which we can narrow down the possibility to narrow down the complications and to increase the possibility in that aspect. And I would like to thank the NCT team and thank you all for the attentive listening. Thank you.
Thank you, Dr. Salen and the entire drug discovery team, all the 4 speakers. Now, may I request all the speakers to please be on the dais. We can have some interactive session. I'm sure we can take few questions from the audience. Anyone have question? Please raise your hand, introduce yourself, and then ask question. Any volunteers, please?
think very nice and informative talks. Enjoyed all of these. I think maybe I can start with the last one first and then move on some comments because the questions were not really coming in. You know, AI or artificial intelligence is coming in a big way in medicine in general and fatty liver disease in particular. When we talk of AI, you know, the machine learning or deep learning is subparts of AI. And, you know, there are three things which people are not looking into NAFR as a role of AI. Since you were, you know, mentioning about the computational, you know, approach. So the first would be, you know, it's a huge burden of fatty liver disease. You can't do ultrasound and MRI in everybody to identify patients with fatty liver disease. The first role of AI, which people are looking at, is to how to identify people based on machine learning that this patient is at a risk of having fatty liver disease. Right, so that's one area which people are now looking into. Say, you just look at the BMI of the patient, look at his triglycerides, look at his fasting sugar. You can do a logistic regression and calculate his risk of having fatty liver disease. But then that's not good enough. Based on EI, you can do better. Your calculation or your identification that this person is at a risk of, you know, having fatty liver disease really goes up. That's one area which people are looking at. Secondly, as we discussed this morning, all fatty liver are not same. Some can have NASH with fibrosis, without fibrosis, cirrhosis, right? So how to identify? And people have come up with so many non-invasive tests now. Histology is the gold standard, which you can't do in all. So people are using APRI, FIF4, NFS, BART, SAFE, so many scores, right? Again, they are not ideal. So again, people are taking the help of AI to, you know, categorize the severity. And to tell you, we again did some work on this. We submitted our work for ASLD reaching this year. We have a consortium in Asia, like we have a consortium in India, we have a consortium in Asia, we call it as Go Asia or Gut and Obesity in Asia Consortium. And this is probably one of the largest data of 1,800 liver biopsies collected, 14 centers, 10 Asian countries. We collected and we applied the AI machine learning model to identify people within those cohort that how can you predict somebody having significant fibrosis and not having significant fibrosis. Why I'm saying this is because in the community it is very important. You can't refer all patients with fatty liver disease to hepatologists. There are not enough hepatologists. You have to manage them at the community. So how to identify based on machine learning that this patient needs to be referred, this patient doesn't need to be referred, right? This is one area which I'm just giving you some, this thing. And the last is on the drug discovery, which probably is this thing. But drug discovery, again, one is this thing. The second, people are looking at, doing histology again is very difficult in everybody. Non-invasive assessment, as I said, is a problem. So based on AI, now people are actually looking at how well can you look at the efficacy of these drugs, right? Based on the non-invasive thing, which is your area of interest, I'm pretty sure. I mean, these are just my thoughts on, your work, which I said. The second about the other speakers was, the issue on, the drug discovery again. My only question to you would be, you're using the targets like FXR, you have used PPAS and ASK1 and all that. One of the strongest targets, which are the drugs which I showed you, are the GLP-1 agonists, with or without the combination with GIPs. Are you people again looking at those as the targets, GLP-1 agonist? I mean, that's probably the strongest data. If you look at the NEGM studies, no molecule has shown an efficacy of 56% improvement in steatohepatitis than any other molecule. It's only the semaglutide which has shown. Are you people looking at GLP-1, number one? Secondly, what I could understand from your preclinical studies, you are looking at improvement in steatosis, inflammation, fibrosis. But does these preclinical studies also help you in understanding toxicity or the side effect profile also of these drugs? These are the two questions. Thank you.
No, sir, we are not currently looking at GLP-1, and also, but we are actually here to have your advice on this, and obviously we are in a very budding stage right now. It's a very initial setup. We have started with the basic models. Dr. Ruchi is kind of establishing organoid models. I have only ended up establishing very basic models right now. But yes, the target specific models, we are working on it. ASK1 and FXR were very initial models we started with. But again, we appreciate all the inputs that we can get, and we are eagerly looking forward to have more of those. The other thing with respect to mechanistic studies, for now we are only screening the libraries. Obviously, once we have some leads, we will look more deeper into it using specific assays and specific studies for using our omics platforms that we have in-house. Shailendra will be obviously investigating them using his models. And then we will also try and generate some analogs for those candidates and then try and study it more deeply. We do intend to extend this approach, and we do intend to make more assays and models ready for us.
With regard to the toxicity, we do have cell-based models. This could be our first filter to have an assessment about the toxicity. Later, when we really are sure of the in vitro activity and early animal models, we can also do toxicity studies in 4D rodent models also. So that can tell us more about the toxicity potential of our molecules.
Dr. Ruchi, I have one, I think it's over. Yes. Okay, I have one observation from one of your slides, and why I'm asking, because I do agree with that. The rate of translation of the research is very less. When it comes to research, whatever we are doing research, I mean, I'm not saying that we failed to completely translate the research, but the rate of translation of the research into clinical setup is less. So what is your way forward to improve the translational percentage into the clinical outcome?
So I think it's very apt comment for especially people who are working on drug discovery programs, because we really have to identify models
So you
and
have
platforms.
CDSA in the THSTI, and I think that is a huge infrastructure to
Yes.
support to translate drug discovery into clinical research. And
Of
clinical
course.
trial.
So like these models which we have plans to use these 3D and organoid models, which we are convinced that could be more predictive, so that we can, prediction is something which we will be looking forward. And then we will be evaluating the molecules after this conventional assays. We will be looking into these specific models to have more information.
One already THSTI started this collaboration with the industry. I mean, academic industry collaboration may be one way, but yes, with the help of CDs, what I feel, whatever in last few years, I see the rate of translation is increasing, but we need to increase further. With the help of CDSA, with the help of industries, with the help of clinical sites.
Absolutely.
Thank
Yes.
you.
I agree.
So I just want to make some observation. I think, first of all, I think I'm impressed with the approach at THST about the drug discovery. It's good that you set up the models first and then use the models for the research. And I think you've done a pretty good job in developing so many models. So congratulations. I think as drug discovery, we understand that failure is part of life, if every drug becomes a human drug, every molecule that we synthesize becomes a human drug, I think we'll have a problem plenty. We can't have so many drugs. So we make so many compounds and they fail, of course. So getting the perfect model, animal model that will translate, and if we get some molecules active in that model, will really become a human drug, very unlikely to happen, because there are so many factors for successful development beyond just the choice of model. So I think it's a futile exercise, in my opinion, to keep exploring model and find out one day which is the best model and the most relevant model for translating to human. I think we have to live with the available models. So you can try a combination of models, so a couple of models, so that something will work, So you can reduce, say, each model give you a possibility of molecule not working in that. So you can, basically drug discovery is like a filtering process. You have to kill molecule as early as possible. Whenever you see a molecule not meeting a desirable property, you have to kill that molecule. Otherwise, we will end up wasting resources. That's what we have learned. The other thing is, for NAFL NASH, most of these people who have the NAFL NASH, they're pretty healthy people, people like me and you. So the safety of drug is very important. You can't target or choose a target which is not very safe. So maybe keep thinking of that in your mind, that for drugs like metabolic diseases, NAFL, NASH, unless you're talking of fibrotic stage 4 or stage 3, which are really in a different condition. For all NAFL NASH patients, I think you need to have very safe drugs. So choose targets which are appropriate. The idea of getting this 3D models is very good, because identifying the hepatological risk as early as possible is great. Most molecules fail because of liver toxicity in phase 3. And I think it's very bad, because by the time you have spent a lot of money. So if you can, if you have a model whereby you can identify hepatotoxic potential of a drug early, I think it's a great asset to any drug discovery organization. that you can identify the potential. So please, I think you should use it definitely. And if you can come with some models which are replacement for hepatocytes, I think that'll be great. Not only from the toxicity point of view, but also from ADME point of view. The other thing, I think for your herbal things, I think this data on Hepano looks pretty promising. But I only wonder how would you take it forward, because what are the doses and how are you going to monitor? Because again, important is the kinetic and dynamic relationship, we keep monitoring our drug with respect to the level, the effects with respect to levels, in animals, what is the effect and at what dose level or what concentration level you see that, what kind of kinetic is required. I don't know how are you going to address those needs for your herbal thing. Please keep that in mind, that you have to at some stage choose the right doses for human. It's a promising compound, but it shouldn't happen that you're not given enough dose to see the effects in humans. So I think it should be something that you may keep in mind. Yeah. Great job. I enjoyed listening to you. Thank you very much.
Thank you so much, sir, for your comments.
I think if there is no further question, we may conclude the session and congratulate the entire team for a wonderful presentation and excellent work. Thank you very much.
Thank you, sir. We now request Dr. Vrati to kindly felicitate Dr. Mahajan and Dr. Ajay Kumar. We request Dr. Mukul Jain to kindly felicitate Dr. Ruchi Tandon. We request Dr. Anil Pandey to kindly felicitate Dr. Shailendra Asthana. We request Dr. Professor Garg and Professor Shindrini Bhatnagar to kindly come up on the stage and felicitate the session chairs.
We request Professor Garg and Professor Shinjini Bhatnagar to kindly stay back and give away the prizes for the 4 best posters. The winners are Miss Ruchika Maurya, NAPI. Miss Ayushi Purohit from THSTI. Mr. Dipankar Tanu Sarma from THSTI. Ms. Sneh Bajpai from THSTI. Thank you, sir. Thank you, ma'am.
We now request Dr. Amit Yadav to kindly come up on the stage to deliver the vote of thanks.
Good evening, everyone. I know we are all waiting to disperse. I'll take 2 minutes. On behalf of the organizing committee, I'm here to deliver the vote of thanks. Let us thank all the guests, speakers, session chairs, faculty, and students who took out time to be here, especially on a Saturday, and without which this symposium would not have been a success. We would especially like to thank Professor Garg, Executive Director, THSTI, for his time and constant guidance in conceptualizing and arranging this one-day symposium. We also thank Professor Shinjini Bhatnagar and Professor Sudhanshu Vrati to agree to be with us here at such a short notice. We have eminent clinicians and scientists who delivered thoughtful talks to share their knowledge with the audience here. Due to the paucity of time, I would not be able to take all the names and apologize for that in advance. We also thank the session chairs who have helped us conduct the sessions and coordinate the thoughtful and stimulating discussions. The event would not have been possible without their presence, and also the knowledge with which our audience surely would not have wanted to miss. Thank you all for taking out your valuable time to be with us. Now, I also thank the poster evaluation committee headed by Professor Shinjini Bhatnagar, and which consisted of Dr. Mukul Jain, Dr. Shalimar, Dr. Milan Surjit, and Dr. Amit Avasthi, who have helped evaluate the posters and decided the best poster prizes. We would like to thank all THISTI and RCB faculty and the students who joined us for the symposium. It was a tireless effort of the NCD faculty, the student volunteers, the administration, and the volunteers from admin, civil, engineering, and the IT teams, and also the housekeeping staff for making this symposium a grand success. It is near impossible to organize a symposium of this scale, and yet without forgetting to acknowledge some people who have worked tirelessly behind the scenes. So my sincere apologies to people I may have missed in this vote of thanks. Last but not the least, the attendees who have traveled far from NCR and also even from outside, they need a special mention for their efforts to be here. I believe that the agenda of this event to understand the impact and prevalence of metabolic burden has been fulfilled. I hope it would have stimulated new ideas and collaborations to address the gaps in our understanding, management, and treatment of this multifactorial disease. Thank you so much.
We now request everyone to stand up for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
We request you to join us for the high tea, and we hope that you have a happy and safe journey back home. Thank you so much.
All delegates who are interested to avail bus facilities may please gather near the THSTI reception. The buses will depart at 6:15 p.m. We request everyone to kindly take all your belongings with you. Thank you so much.